The leadership of both the New York State Ophthalmological Society and the Connecticut Society of Eye Physicians, with the generous support of our sponsors, welcome you. Sit back, relax, enjoy the program, and recognize the accomplishments that you've achieved during the year of 2020. Our first speaker is Susan Jacob, Master Surgeon from Chennai, India. Dr. Jacob is the Chief of Refractive and Cornea Foundation and Orbit and Oculoplasty at Dr. Agarwal's Eye Hospital in Chennai, India. She's won numerous awards, and most recently is the recipient of Top 3 Women in Ophthalmology and International Recognition of Excellence. We welcome her from halfway around the globe via Zoom. She's going to address the surgical management of keratoconus that overall affects approximately 1 in 2,000 individuals. Its onset often in the teenage years and can progress to advanced stages with a significant impact on vision. All of this with no known preventive measures. Here to help us better understand the surgical approach to the management of advanced keratoconus is Dr. Susan Jacob. Welcome, Dr. Jacob.
Thank you so much, Ed, and thanks for inviting me here. A big thanks to you and Debbie and everyone else who's involved in organizing this meeting. It's a pleasure and an honor to be able to present here across all the 7 Cs. Thank you once again for calling me. Without much ado, I am just going to start sharing my screen and start off with my talk. So, all right. Can my screen be seen? Okay, all right, great, thanks. So my talk is on the treatment of advanced keratoconus, and I'll be covering a few topics here, CARES, contact lens assisted collagen cross-linking. That is one of the techniques for cross-linking of advanced corneas, advanced keratoconic corneas, and also a bit about DALC. I must say at the outset that I have a patent pending for special trephines, devices, and processes used to create the care segments as well as the special trephines. So when you look at keratoconus, when you look at the the prevalence, what we generally read about is about 1 in 2,000, and we think that we don't really come across many patients. But one of the studies that was done by Dr. Randleman and many others in Saudi Arabia actually showed that the prevalence of keratoconus in pediatric patients can be as high as 1 in 21. So when you talk about 1 in 2,000, that's actually the prevalence for fairly late stage disease. And when you look at earlier disease, which can easily be picked up now with all the advanced topography and all the advanced measurement techniques that are available, we find that the prevalence of keratoconus is actually much more common than we think. It may be as high as 1 in 200 patients who have some kind of subtle abnormal findings. So really, we need to keep our eyes open for this disease. So the current treatment of keratoconus has lots of things involved, but one of the things, one of the treatment modalities that's being used is ICRS, which is intracorneal ring segments combined with cross-linking. And many cornea surgeons do like this because progression can often be halted using cross-linking, but cross-linking alone doesn't give a much improvement in the topography. So it's generally combined with some form of shape improvement technique, either topography assisted PRK or implantation of ICRS or some other techniques. Now, the problem with ICRS is it gives great effects in terms of improving the quality of vision. And there are lots of commercially available intracorneal ring segments available. But one thing that's common with all of these is that they're made of artificial segments, that is PMMA or plastic. And we know that artificial segments or plastic in the cornea can lead on to problems in the long term. I'm sorry. Which can include problems like overriding of the segments, erosion of the cornea overlying the segments, melting of the cornea, extrusions of the segment, intrusions of the synthetic segments, even up to infectious keratitis, which can lead on to the necessity for a therapeutic PK, and so on. So even a rate of up to 30% of complications has been reported in some case reports with in some studies with synthetic implants. And I used to do a lot of ICRS, but then because of these problems, I was kind of put off from them. And that's when I had this idea, they give great effect, but the problem is the complications. So how about going ahead with allogenic implants? And this I started working in 2015 We published our first series in Journal of Refractive Surgery, and I call this technique as CARES, which is an acronym that stands for corneal allogenic intrastromal ring segments. And allogenic could refer to anything: fresh donor stroma, preserved donor stroma, processed stroma, or any source of allogenic tissue. So this is how I went about this technique. This is a double-bladed trephine, as you can see there. If you look closely at this trephine, this has got 2 concentric blades. And what I've done is basically take a donor stroma and punch out a ring of allogenic tissue or stromal tissue. So again, just showing you the procedure a little bit more in detail. That's a donor cornea which has been mounted. The epithelium was removed. If you watch again, the first thing I do is remove the epithelium, then remove the endothelium, and then again take that double-bladed trephine, center it on the cornea, and punch it out. So you get 2 concentric rings of 2 concentric cuts rather, which gives you this ring of stromal tissue. Now, what I do is I cut it into 2 halves, and I also fashion these simple instruments from cataract set. And what you can do is make a femtosecond laser dissected channel within the keratoconic patient's eye. And as you can see, you can easily push these care segments inside the cornea. So that's one of them which has gone in. The second one gone in, you can see that you can just push them in and then pull it in from the other side using a reverse Sinskey hook, trim it to the desired size. And you can also go ahead and do cross-linking if the patient has got progressive keratoconus at the same sitting or at a subsequent sitting, depending on your treatment preference. So here's a typical postoperative appearance of the patient. Here you can see in the slit view, the care segment within the cornea, and I'll show you the diffuse view as well there. There it is. So you can see very quiet segments, placed within the about 5 to 7 millimeter zone. And you can also see that they are extremely quiet. They're not causing any kind of inflammation or anything in the cornea. The other thing I wanted to talk about is that it's not just the complications that are associated with synthetic implants. There are also some other disadvantages of synthetic implants. One of them being that you can implant them only if you have a minimum stromal thickness of 450 microns above the in the zone of implantation, which means that you have to have around 400 microns of stroma above the synthetic implants in order to prevent complications. And that by itself means that you cannot really do this procedure in very thin or very steep corneas. So you cannot do it generally in corneas that are more than 58 diopters of steepening. And also you have to implant these segments really deep, about 70 to 80% depth. And these are again disadvantages, because many of the patients where you really want to treat and try to improve the vision, you find out that you cannot do them because they're too steep. And that's where these natural implants or allogenic implants cares come into big advantage. They're biocompatible and biointegrable, so there's a much lower risk of complications, of course, as we already spoke about, but also the advantages that you can implant in thinner and steeper corneas and also in advanced cases. At the same time, you can also implant these in mild cases. And the best part is you can implant it much more superficially. I generally implant it around 50%, so you can get greater effect. And you can also get arc segments of up to any degree, 360 degrees, 340 degrees, whatever you want. So you have a wide pool of patients where you can actually do this procedure. So you can do it in simultaneous with cross-linking. You can do it in already cross-linked patients. You can do it in patients with no documented progression. You can also do it as treatment for synthetic segment-related melts. As you can see here, this is an intact with an overlying melt. And this is in contrast how quiet a care's eye looks. Here you can see the procedure being done. What I'm doing here is that's the segment. That's the intact segment which was being extruded. What I'm doing here is fashioning a care segment, as I had shown you earlier. And we go to the eye with the synthetic segment melt. And what I'm going to do is actually remove this intact and replace it with a care segment. So that's what you're going to see me do. And this, I think, is a beautiful technique for solving these problems. So cares can be used not just for keratoconus, but also for solving problems or complications that are associated with synthetic segments. So as you can see, I have removed that synthetic segment, and then I'm marking the length of the care segment that I need. I dissect it out, and then we go ahead and implant it. We push it in there. And then I just take some sutures which anchor it in place, anchoring sutures on either end actually, and bridging sutures over the top of the segments at the middle, and basically put a contact lens on top. So you can see here, this is about 3 months post-op, before suture removal and after suture removal. And you can see this is a very nice technique to handle these complications. A synthetic segment on one side and an allogenic segment on the other side. This is probably the only patient in the world who has this kind of a combination, but really you can do well with these segments. Here are again some other post-ops, and you can see quiet segments lying within the eye at mid-stromal depth. This is a picture I have borrowed from Jack Parker from Alabama, who's also now doing a large number of these patients. And you can see the difference, the flattening that can actually be brought about by CARES, and the shine plug image, the pre and the post, really shows this extremely well. And if you also look at the difference map of the same patient, you can see that you've got a flattening of about 25 diopters, which is humongous. So you can take very advanced keratoconus patients and put these care segments and get them to flatten out quite a bit, and then combine it with cross-linking and get very good results. So there's a lot of decrease in K1, K2, mean keratometry, astigmatism, as you can see here. Here's a picture of my own patient. Here's the pre-op shown in orange and the post-op shown in blue. And you can see the care segments implanted midway and the flattening that we've been able to get. So now CARES, I'm happy to say, is being done in many centers worldwide. In US itself, it's being done in multiple centers: Canada, Turkey, Lebanon, Israel, Dominican Republic, and so many other countries, Germany, Australia, and so on. And the number of surgeons who are doing this is actually increasing. I'm going to just share some of the results of CARES. So here you can see a lot of flattening of the topography, improvement in uncorrected visual acuity from 624 part to 69 part. Again, in decrease in cylinder, as you can see here, from 9.2 to 6 diopters. Again, in these pictures, you can see 340-degree CARES, which means you've got almost circular segments, which can again be implanted very easily in with these with these allogenic segments as compared to synthetic segments, and also a lot of regularization of the topography, as you can see in all these pictures. So just sharing some more interesting cases with you. These are two segments which have been placed, and you can see the flattening that is achieved in the difference map. Here's a single segment for asymmetric keratoconus. So that's another very good use because you can get rid of a lot of the chromatic aberrations that these patients, the tailing of images that these patients often complain of, can really be decreased a lot. Here you can see that this is a pre-op. On the left-hand side is a post-op and the difference map, and a single asymmetric segment under the decentered cone helps improve the topography of the patient. This is another patient with more advanced decentered cone, and again I've put in a single segment, and you can see about 15 diopters of flattening that we've got, and the patient was very happy with the improvement in his visual quality. Now this is a picture that I'm going to show you just to show how you can also adjust the thickness of the segments and thereby get differential effects using CARES. Here, if you look at the left-hand side, the slit lamp image, you can see that these segments are thicker, and you can see that on the right-hand side of this, the other eye of the same patient, the left eye of the same patient, actually, the segments that have been put are thinner. And if you also look at the topography, you can see that you've got much more flattening with the thicker segments as compared to the thinner segments. So you can actually titrate the amount of effect that you're getting. And another thing that I want you to see in this is that you've got a flattening all around, and you've got a steepening along the preoperative flat axis. So there's an overall flattening with a steepening of the preoperative flat axis, which leads to an overall decrease in the cylinder and a great amount of regularization of the topography and improve visual results. And here in the other eye, because the patient was so happy with the right eye results, he also opted for the left eye, and we found that we could give her with that subtle amount of flattening that was required for the left eye for improved visual acuity. Again, another patient, you can see thicker segments put, and we've got a lot of flattening. In the other eye, he underwent only cross-linking, and you can see almost no change in topography, which shows how much of effect CARES can actually give when combined with cross-linking in actually being able to treat the disease as well as decrease progression. And so the patients can be really benefited. Here's a patient who underwent CARES and CSEXL, contact lens assisted cross-linking, which I'll be talking to you about next. And you can see that this would otherwise have been a patient who would have been a candidate for a DALC, 72 diopters of steepening. But we went ahead and did just a CARES and CSEXL, and we could avoid the DALC, and you can see the substantial amount of flattening that's been obtained in this patient. You can also improve the contact lens tolerance that way, and so the patients can avoid the DALC completely. Here's again another patient who's got about 20 diopters of flattening, preoperative, very steep corneas, and again we avoided a DALC. So one of the questions that people ask me when I talk about CARES is, what is the change in segment thickness with time? It's really not been substantial in our experience, and I know that Mario Nubile, who's also has also given similar results of no change in intrastromal tissue that he places for SLAC. And I think it's basically because of the intrastromal location as opposed to DSEC or DALC, where you can have thinning over the long term. Here we find that there's really not much change in tissue thickness. Or is it because the cross-linking freezes it in place? Is it because of the intrastromal location? We really don't know. But whatever it is, we have to remember that the shape change that's brought about by CARES is not a mathematical calculation. So it's really not that crucial either. And we find that patients continue to enjoy their results. These topographic maps this difference map is taken 1 year apart post CARES implantation, and you can see almost no change and complete stabilization of the patient's keratoconus. This is a software which has been developed by Jad Asaf and my very good friend Shady Awad. And you can see that we use this also for analyzing our results. And this is available on the web. Again, just to show you the decrease in topography with CARES and also the decrease in coma, which you can get. If you look at the preoperative map, you've got about 3.438 microns of coma in the preoperative map, which is decreased to 0.350. So that's really substantial decrease in the chromatic aberrations. And again, if you look here, minus 3.407 has decreased to minus 0.177. So you get a lot of improvement in the quality of the vision. And anti-segment OCTs and light microscopy showing very quiet eyes and well-placed segments. We've done more than 160 patients so far, and we've published our first 24 patients in the Journal of Refractive Surgery, where it was also included on the cover page. And we had significant improvement in almost all parameters in our published study. The second topic that I'm going to come about is something that generally I do in combination with CARES. You could do it just without CARES also for patients who don't want to undergo for any reason, or for whom, or if you're not doing CARES, you could just do plain CSEXL. Contact lens assisted cross-linking, and this is basically for advanced keratoconus, for thin corneas which have crossed the limit for conventional cross-linking. I have no financial interest in this topic. Normally, we know that cross-linking requires a minimum corneal stromal thickness of 400 microns. So you need about 400 microns, and the reason why you need that is because the photosensitizing effect, so riboflavin actually causes UV damage at a level of 0.36 milliwatts per centimeter square of UV. So that's basically, if your UV goes above 0.36 milliwatts, you will get endothelial damage. But what riboflavin also does is it has a protective role. So what it does is it acts as a sink for ultraviolet, and therefore it decreases the amount of UV that reaches the endothelium. So for that sink effect to have, to be able to protect the endothelium, you need a thickness of 400 microns. You need 400 microns of riboflavin saturated stroma in order to attenuate the ultraviolet light that's reaching the endothelium. So I think that's going to be better understood with this diagram. So if you have 400 microns of riboflavin saturated stroma, the ultraviolet light that you apply comes down to very low levels at the level of the endothelium, and so your endothelial toxicity does not happen post cross-linking. But if you don't have 400 microns, for example, in this picture, you've got only 300 microns, the UV doesn't get attenuated to safe levels, and so you can have endothelial toxicity. And that's the reason corneal stromal thickness is very important if you're doing cross-linking. So corneas less than 400 microns after epithelial removal, you do need to have some more safety in the procedure when you're doing cross-linking. And the idea that I had was just to apply, it's a very, very simple idea. What I did was just apply a contact lens that was also saturated in riboflavin. So if you have only 300 microns of stromal tissue, why can you not just add artificially some more tissue on top, riboflavin saturated tissue? What I did was put a contact lens, soaked it in riboflavin, and so I had more riboflavin saturated substance above the cornea. And so my UV attenuation actually started from the level of the contact lens, and by the time it reached the endothelium, it was attenuated to safe enough levels. So the contact lens, what does it do? It basically prevents ultraviolet related endothelial cell damage, as well as the permanent stromal haze that can occur if your endothelium and your stroma are not protected from high UV levels. Which contact lens can be used? Basically something that has an absent or a negligible UV filter. And that's really important because many of the contact lenses that are commercially available have inbuilt UV filters. So if you use any of those, basically you would have done no treatment at all. The patient would have undergone nothing at all. There would be no strengthening or stiffening of the cornea. So it's very important that you have no UV filter in the contact lens, and the best way to check that is check the product literature or use a UV digital meter and just place the contact lens over it and turn the UV on and see how much of UV is being transmitted through the contact lens. So also the contact lens that you should have a thin lens design. Soft lenses follow the shape of the cornea, so I prefer that. Hydrophilic because you want the riboflavin to be absorbed through the structure of the contact lens. And the one that we use is the soft lens, the Bausch & Lomb soft lens daily disposable lens, which is made of Filacon B. It's less than $1 in cost, so it's very cost effective as well. And it kind of satisfies all the criteria for the contact lens that would be ideal. Here's an experiment where I placed riboflavin into the contact lens and put filter paper underneath, and you can see that the filter paper underneath gets stained with the riboflavin, which shows that the riboflavin actually passes through the structure of the contact lens, and so the contact lens is completely saturated with the riboflavin, which is what we want for being able to get adequate cross-linking. There have also been lots of other studies now which have been done on CSEXL, and here's another study, a study which was published in 2014 later about the other kinds of contact lenses that you can use, the other materials that can be used. We used Helificon B, but there are lots of other materials which can also be used for CSEXL. This is how the technique is done. UV barrier-free contact lens. Sorry. So the contact lens is also soaked in riboflavin, as you can see here, and then after the cornea, the de-epithelialized cornea and the contact lens are soaked for half an hour in riboflavin. It's very simple. Basically, what you do is place the contact lens over the cornea and then apply the UV and basically do your conventional cross-linking or accelerated CSEXL, whichever is the technique you prefer. Finally, remove the contact lens and wash off all the riboflavin and place a new contact lens. Now, we found in our study, which again we had published in GRS, that you get an average of about 110 microns additional thickness from the contact lens, and that gives you sufficient safety for the corneal endothelium in most cases. So this is the algorithm that I use. If anybody wants to do wants this algorithm or wants help in doing or incorporating CARES or CSX or any of the procedures that I'm showing you, please feel free to contact me and I'll be happy to help you. This is the algorithm, as I said. So you measure the pachymetry first. If it's less than 400 microns, you go ahead and do CSEXL. If it's more than 400, of course, you just do conventional cross-linking. Now, when you do CSEXL, one important thing is after half an hour, you need to make sure that your functional pachymetry, that is the pachymetry with the contact lens on, is more than 400 microns. So that's something that you have to measure with intraoperative pachymetry. If you find that on adding the contact lens, you've got more than 400 microns after half an hour, that is just before you start the UV application, you can go ahead and do CSEXL or accelerated CSEXL, whichever you want. Now, if by chance your cornea is so thin that it does not come to 400 microns, even with application of the contact lens, a very simple technique that you can do is just put 2 drops of distilled water, and that those 2 drops are generally sufficient to allow the cornea to minimally swell. You just need a few microns, generally about 10 to 20 microns, and that minimal swelling is generally enough along with the contact lens to take your thickness above 400 microns, and then you can proceed with CSEXL or CXL. So we found in our studies that we had 60 to 70% UV transmission through the riboflavin soaked contact lens, and this was then later confirmed. These are our demarcation lines. This is a conventional CSEXL, and this is accelerated CSEXL, and you can see that we've got good demarcation lines in both of them. This is the ACSEXL, about 235 to 36. In our published study on conventional CSEXL, we've got about 250 microns of demarcation line, and here are the IVCM studies which we did with Cosima Mezzota, and also published in GRS, where we saw the demarcation line at safe levels, and also found that the IVCM changes post CSEXL are exactly similar to that after conventional CXL. So we didn't have any significant endothelial loss, pleomorphism, or polymegathism post CSEXL. Our pilot study had 14 eyes, but now, of course, we've done many more patients and also used this technique in much thinner corneas. And now there have been many published studies from all over the world on CSEXL, which has shown that it is an effective technique. It gives you about 70% of the conventional cross-linking effect. So this is a study that we did together with Farhad Hafezi, and basically one of the things that we found in this, that thin corneas actually have higher oxygen availability, and that increased oxygen availability makes thin corneas become stiffer as compared to thick corneas. So actually thin corneas cross-link even better than thick corneas, so that's an advantage, and CSEXL works well for that. These are just different studies which have been published from other centers on CSEXL. One of them showed that HPMC, riboflavin based in HPMC, has greater advantages over riboflavin in dextran, and that's because HPMC can penetrate deeper into the corneal stroma and so give you deeper demarcation lines. Again, different studies from an Israeli group from Molensak et al., who also studied CSEXL and found that found similar results as us, that CSEXL in porcine corneas gives about 1/3 less effect than after standard CXL, which means about 60 to 70% effect, which is what we also said. And they also said that the efficacy of CSEXL may be further improved by not applying that riboflavin film on the contact lens. Here's a study by Brad Randleman and group, who found also that CSEXL is a very straightforward option for cross-linking thin corneas without requiring complicated equipment or precise manipulation, and that the safety has been demonstrated. And these are various charts which he showed, which show that there's about a 70% decrease in cross-linking using CSEXL as compared to conventional conventional cross-linking, which is what again that we had also found with our results, and he had done this study using Brilon microscopy. Now we've got also machines which help you. The Appasamy Associates have actually made this machine, which will take you step by step through the CSA Excel technique. So it keeps telling you, prompting you about the thickness, and then it tells you what to do next, and so on and so forth. I'll come to the last topic, which is basically DALC for keratoconic corneas. Again, I have no financial interest in this topic of presentation. DALC is again done for much more advanced cases. So here's the classical Unver's big bubble DALC, where you go in and inject air into the stromal layers, get that big bubble to form, and then, remove the, basically remove this overlying tissue and replace it with a donor cornea. So again, here's the big bubble being formed, and you can do it in various cases, not just keratoconus, but also in dystrophies. You can do it in post-classic ectasias and so on and so forth. And this is the classical small bubble DALC, where you can see that you've got the big bubble already, and you confirm the presence of that space-occupying big bubble within the anterior chamber by putting in a small bubble into the AC and seeing it move. As you can see here, you can see this bean-shaped bubble moving in the periphery of the cornea. There it is. And that confirms to you that you have the big bubble. So big bubble is a very, very nice technique, Unver's big bubble technique, which helps you to perform DALC beautifully. And what you do then is, of course, transfer the epithelium full thickness stroma onto the host tissue. The host contains only desmoids and pre-desmoids layer and the endothelium. And you can do various suture techniques, interrupted or continuous suture, or a mix of interrupted and continuous, and you can get very good clarity of the cornea postoperatively. DALC has lots of advantages. It has a less risk of expulsive hemorrhage as compared to penetrating keratoplasties. You get much better structural integrity of the eye. The best part is that the endothelium of the patient is retained, so there's less risk of rejection. And also, is there less sutural astigmatism? That's a question that still needs to be answered as compared to penetrating keratoplasty. A lot of it depends on your suturing techniques. Now, DALC, as I said, is a very great technique for advanced, really advanced cases of keratoconus. But the question is it always hunky-dory? And what is the level beyond which you would go for DALC? So DALC can have complications as well. Here you see that I was trying to do the big bubble, and the bubble has instead gone into the anterior chamber, which means it's a microperforation. I tried to do a big bubble at a different site, but you can see that I have really I'm not being able to get the big bubble anymore. So what I do now is just induce stromal emphysema and use that emphysema as a guide to remove the upper stromal layers. So I go step by step, layer by layer, and keep dissecting stroma, and you can still get good results. You can see that small scar where the microperforation happened, but you can see that the patient's really still done very well. You can also get macroperforations. Watch this video carefully. I'm going to inject, and if you watch this area, watch right there. You can see that big macroperforation, just injection of air, and the desmoids was so weak that there's this large tear in the desmoid membrane, which obviously is going to cause me a lot of difficulty in proceeding. I do try to do a dissection to see if I can do anything about it, but obviously it's very obvious that you can't really salvage either. Size of the macroperforation was so big, so I had to convert to a DALC in this case. I mean, an open penetrating keratoplasty in this case. This was about a 34-year-old patient. So I decided to go ahead and also do a cataract extraction, because I don't want to go ahead and do a cataract at a later setting because of the decrease in endothelial cell counts that can happen post-operatively. He was going to be on high dose of steroids and lots of other things. I think actually he was a little older than that also, maybe around 40, and that's the reason I went ahead and removed the cataract as well. And I mean the lens as well, and I've closed the eye. So you can also get microperforation if you do it the wrong way. The big bubble's there, but then you can see I didn't do that slash opening of the big bubble fast enough. I did it slow, and the tip of that knife actually went and struck the desmoid membrane, and I got a microperforation there. I've gone ahead and done manual dissection. So most of these cases, I put fibrin glue to close the macroperforation. Most of these cases, you can manage these cases well, unless you've got a very large macroperforation. Gauge needle connected. Here's one different type of bubble that's formed. Normally you get the type 1 big bubble, but here you can see it's a type 2 big bubble, which means that it's a desmoid membrane in the endothelium that's separated out, and not the pre-desmoids, desmoids, and endothelium. So that's a difficult situation to have. And what I do here is just continue on, carry on the dissection, and you can see that the stroma and the superficial stroma has been debulked, but the type 2 is still there. I take a needle and just open this into the space of the type 2, and then let that air, just milk that air out through that opening, and then we can proceed again. So here's an unidentified big bubble. The big bubble was formed, but it was not identified on table, and only a pre-racematic DALC was done. But this, of course, the bubble just absorbs in the postoperative period, and the patient is fine. Here's a patient who had high drops and the big bubble, and as the bubble is being formed, if you watch carefully, that's a replay. The bubble is forming, but then suddenly the air enters the anterior chamber, and you can see that there's a perforation again. Now, again, in this case, we've been able to continue and put the tissue there, and the patient did well in the postoperative period. So you can see that small tear in the distal membrane there. Now, as you saw now, DALC can go very well and have good results, but at the same time, it's not a completely easy surgery. It does have its complications, and it does have a longer learning curve and a steeper learning curve than CARES. So is CARES a better alternative to DALC? CARES is also, if you actually think about it, a new mid-peripheral, mid-stromal anterior lamellar keratoplasty. Mid-lamellar keratoplasty, I would say. So why CARES in advanced cases? Can you just do CARES in advanced cases instead of DALC? We have to remember that many patients with advanced keratoconus require transplantation early in life. So, there are many keratoconic patients who come around the age of 20, 22, and you do their first DALC because they've got advanced keratoconus, and that graft may not last over their entire lifetime. So maybe by the time they're 40, you need to do another graft, and then successive grafts over their lifetime, and each graft increases the risk of failure of successive transplants. So can you just do a CARES to get rid of these problems? That's one thing that you have to think about, it's nice to think about rather. CARES, what does it do? It actually offers the best of both worlds to the patient. It retains and reshapes the patient's own cornea. It improves uncorrected and best corrected visual acuity. It does away with almost all the disadvantages of complications of a more invasive and extensive procedure, that is DALC. It can be done as a standalone procedure in non-progressive cases and with cross-linking in progressive cases. Also, one of the big advantages of CARES is that it's reversible. So it does not really take away the ability to do a DALC or any other treatment modality that may become available in the future. So you're retaining all possibilities, all possible future surgical opportunities are still present for the patient. You're not taking away the ability, whereas once you do a DALC, it's an irreversible procedure, and then you cannot offer many more options for the patient. And the other thing about CARES is you can also do it as part of bioptics, which means you can use it synergistically with other treatments. So you could do a CARES first and then do a topography guided ablation or a phakic intraocular lens or anything of that sort. So here are some of the complications that can happen post DALC. As I said, DALC is a very nice procedure, but these are some of the problems that we see sometimes. For example, loosened sutures are very common in DALC patients because of the atopic tendency and the soft cornea that they have, especially in the infratemporal quadrant. You very often get these, and they can lead on to vascularization, lipid keratopathy, and so on and so forth, which can ultimately result in the necessity for much more invasive procedures. And especially in patients with Down syndrome or in pediatric cases who are very far advanced, CARES really becomes a much better alternative, because those patients are even more difficult to manage because of the poor follow-up and the difficulty in being able to do post-operative evaluations. CARES also has a decreased risk of rejection. We know that DALC itself doesn't have a high risk of rejection. Typically, if you're using a 7.5 to 8 millimeter DALC graft with about 600 microns of tissue, it works out to about 26 to 35 millimeters per cube of tissue transplanted. Whereas if you're doing CARES, the volume of tissue transplanted is only 1 to 6 millimeter cube. So that's the difference in the amount of tissue transplanted. So with DALC itself, when there's a low level of rejection, CARES has a much lower level of rejection. Also, you're not transplanting epithelium, you're not transplanting endothelium, you do not have sutures, you're having a mid-stromal position of the CARES as opposed to a epithelial portion with proximity to the limbus that happens in DALC. So all of these disadvantages of DALC are overcome, and CARES has lots of advantages because of its mid-stromal position. It gets repopulated by the host keratocytes from all sides, and the worst case situation, let's say the worst case situation is that the CARES tissue does reject, it becomes hazy. It still does not affect vision because it's transplanted outside the visual axis. So that's one of the biggest advantages of CARES. Postoperative medications for CARES as opposed to DALC, I give it only steroids only for about 6 weeks, very low dose, just as my cataract protocol. So that's again another advantage. You don't have any of the surface issues. You don't have any of the interface issues. You don't have any of these folds that can happen in very advanced cases where you do DALC. You don't have vascularization, interface haze as seen here. You don't have the problems of uretzavalia or other symptoms that can happen, or lipid keratopathy. So all of these, vascularization, as you can see here in case of DALC. So all of these problems are avoided, and the visual axis is not touched in CARES. So these are actually, I think, really big advantages. It's also easier and faster. The time taken for surgery in CARES is much lesser than for DALC, and the learning curve is much smoother. It's easy for a cataract surgeon to incorporate, actually. So it's the learning curve is that easy. And also remember that in DALC also you do have sutural astigmatism. So CARES is reversible, whereas DALC is not. And you can also combine CARES with lots of combination treatments. Here's a patient who had only 230 microns of tissue. As you can see here, stromal tissue, and there was some amount of epithelial hyperplasia over this. This is a patient where normally DALC could have been done. I've done CARES in this patient, and you can see flattening here. It was a single segment of CARES, and you can see I've got about 15 diopters of flattening. This was a patient who had cerebral palsy. He was difficult to evaluate because he had to be carried by his friends all the way from another city to our city. He had to take a taxi and come. And so they were really happy that they were able to avoid DALC and all the postoperative follow-ups that DALC would entail. So as I said, CARES can be done for a huge population of keratoconic patients, right from mild to advanced keratoconus, and you can avoid much more invasive surgeries with this procedure. So I think with that, I will conclude my talk. Thank you very much.
What an amazing coverage of the topic. It's fitting an entire symposium into 30 minutes. So thank you so much for that. Do we have any questions? Would anybody like to raise your hand? I don't see any questions in the Q&A box. All right. Well, Susan, Jacob, thank you so much for joining us from across the world this morning. Thank you.
Thank you so much. Thanks a lot.
All right. Next, I'm going to turn this over to Robert Lesser, MD, who will introduce our 2021 Herbst Lectureship. But first, I'd like to give some background regarding the origin of the Herbst Lectureship. The annual Herbst Lectureship at the Connecticut Society of Eye Physicians is one component of the Earl and Shirley Herbst Eye Research Fund, whose mission includes other notable goals, such as supporting eye research at the Yale University Department of Ophthalmology, the Infirmary at Harvard, the Harkness Eye Institute at Columbia University, and to provide low vision services and products in area communities. During the 1980s, Earl and Shirley Herbst were the recipients of ophthalmologic care in Connecticut by our own Vincent DeLuise and Neil Zimmerman, who provided world-class care to them until their passing in 1996. At their bequest, a sizable donation was left to the Connecticut Eye Research Foundation and Opticare. And in 2000, the funds were donated to the Connecticut Community Foundation, who established the Earl and Shirley Herbst Eye Research Fund in 2017, the source of our Herbst Lectureship. From 2012 to 2018, the Herbst Lectureship was a biannual lecture, and in 2019, the Connecticut Community Foundation Board of Trustees voted to turn this wonderful contribution into an annual lectureship. Over the years, our state society members and guests have been able to benefit from the contributors such as Roger Steinert, Hugh Taylor, Amar Agarwal, Lisa Arbisser, Penny Asbell, and Robert Osher. It is truly an elite group of physician scientists who have made incredible contributions to the knowledge base of ophthalmology. These driven pioneers have achieved advancements that have touched millions of patient lives through the thousands of physicians that have been able to meet and learn from these pillars of medicine. This year, we are pleased to present to our membership and our participants from New York and surrounding states, Jonathan Trobe, MD. We are proud to add him to the roster of notable lecturers, and our leadership would like to remember Earl and Shirley Herbst and give a nod to the Connecticut Community Foundation for making this possible. I'll hand the podium to Dr. Robert Lesser, who will take the honor of introducing Dr. Trobe and his 2 lectures. Dr. Lesser.
Good. Ed, do we need to share my screen?
Yeah.
Good, thank you. Okay. John, it's my pleasure to introduce John Trobe. He is a graduate of Harvard College and Harvard Medical School. After completing his residency at Wills, he did a corneal fellowship at the University of Florida, where he stayed on the faculty. But then he saw the light and left cornea to do a fellowship in neuro-ophthalmology with Joel Glazer at the Bascom Palmer Eye Institute, where he returned as director of neuro-ophthalmology at the University of Florida. Although enough training for most of us, he wanted more. He gave up his tenured position at University of Florida and did a residency in neurology at the University of Miami. Since then, for the last 35 years, he's been the director of neuro-ophthalmology at the University of Michigan, with joint appointments in ophthalmology, neurology, and neurosurgery, where he has been a mentor and a teacher to medical students, fellows in neuro-ophthalmology, and residents in ophthalmology, neurology, and neurosurgery. He has written over 200 papers and 8 books, including my favorite, The Neurology of Vision. He was the editor of the Journal of Neuro-Ophthalmology from 2001 to 2010, and has done a superb job, and really changed that journal. He's been on the editorial board of many other journals, including JAMA Ophthalmology. He's the author of a website on neuro-ophthalmology called Neuro-Ophthalmology at Your Fingertips, which I highly recommend. John has lectured all over the world, and we're lucky to have him speak to us today. His Herbst lecture will be about the cranial nerve palsies. John?
Thank you, Bob. I hope everybody can hear me. Let's see. I will try to share my screen and then say a word or two to you. All right, can everybody see that?
Yes.
Bob, say yes.
Yes, I see.
Okay,
yes.
well, thank you very much. I'm honored to be able to give this Herbst lecture. I did not know anything about it, and I have just learned from what you've said, Ed, about it. And I'm hoping to give you a little guidance here about the management of 3rd, 4th, and 6th nerve palsies. Meanwhile, I want to extend my thanks to Debbie Osborne, who has made this really very easy and did an enormous job of organizing. So let me bring you this whole. Here we are. Okay, so I think we ought to look at these cranial nerve palsies as being distinctive. They have their own flavors, and that's why I've made the analogy of ice cream. Everybody loves ice cream, and each flavor has its own distinctive qualities. And let me see if I can convince you of that in the next few minutes. So no conflicts of interest. I'm going to start with a warning, and that is that we fall into this trap. Head trauma is a very common cause of any of these palsies, but you really should not blame the head trauma unless there's been loss of consciousness, because that will not do it, and there may be something else underneath. So keep that in mind, and I'm not going to say anything more about head trauma in the cause of cranial nerve palsy. So let's go ahead and get to the 3rd cranial nerve. This is where it goes. You can see that it starts in the midbrain and has its brainstem segment here. There are lesions that occur here. They're complicated. They generally are not isolated manifestations of 3rd nerve palsy. They're rare, and you're not going to be thinking too much about them. The real action lies here in the subarachnoid segment, where the nerve can be subject to ischemia, as you all know, in adults especially, also inflammation. But more importantly, the nerve passes by 2 lurking places of aneurysms. And although that's not so obvious here, an aneurysm coming off the basilar apex right here can certainly impinge on the nerve. But more importantly, an aneurysm that comes off this juncture right here between the carotid artery and the posterior communicating artery, it can lean on the 3rd cranial nerve and cause an isolated 3rd nerve palsy before it ruptures. And that's the time when you really want to be able to make the diagnosis. Once the nerve gets into the cavernous sinus, it is subject also to lesions, but more likely it's going to be accompanied by other cranial nerve palsies. One thing you should think about is that the orbit lesions do not give rise to 3rd nerve palsy. So the real action is right here in the middle between the beginning of the subarachnoid segment and the entry into the orbit. Okay, now I think you all will recognize the very standard, maybe complete third nerve palsy. And here you see it here in this patient whose eyes, work in his eye works in abduction, but doesn't work in adduction. And you'll see in a second that it doesn't work in supraduction and also in introduction. So, and there it's curling up, showing you that the fourth cranial nerve is working. So, that is the complete third nerve palsy, and that's relatively easy to recognize. You'll have more trouble with the partial third nerve palsy, and so you have to really be paying quite a lot of attention. So, what features are going to be determinative of the cause of a third nerve palsy? And there are two ones that you want to fix on. The first one is the age of the patient. No question that if you have a young patient, it's different than an older patient. And the reason for that is old people have ischemic profiles. And if they do, then they're subject to the most common cause of an isolated third nerve palsy, which would be ischemia to the nerve in that subarachnoid segment. The other feature is whether the palsy is isolated. This is a concept that neuro-ophthalmologists toss around all the time, and it's going to be a very important aspect. If you've got a palsy that has all kinds of other neurologic manifestations, even neuro-ophthalmic manifestations, that's a completely different story than if the palsy is just limited to the cranial nerve. And that's what we mean by isolated. I do want to caution you that history is involved here. And when we say no other pertinent abnormalities, we're also considering important aspects of history. For example, somebody who has multiple myeloma or a previous history of granulomatous polyangiitis. Those kinds of things turn up and are very important in your whole approach to the way you're going to deal with these palsies. Here is a schematic showing you the cranial nerve. It's in red here, and it's traveling in its subarachnoid segment and also in its intercavernous segment. And this is the place where lesions, ischemic lesions, are going to be causing the damage. And most of the lesions are right here after the nerve has left the midbrain. These are reversible. They spontaneously improve and do not show up on imaging, and will be by far the most common cause of a third nerve palsy. The problem is that you cannot clinically distinguish that form of cranial nerve palsy from these two other very important causes. And this is the one that we fear the most. And I'm showing you, of course, an aneurysm here. Here it is at that famous junction of the carotid artery, that's the internal carotid artery, and the posterior communicating artery. And when this bubble forms here in the wall of the vessel, it leans on that third cranial nerve. And this is one that you do not want to miss at any cost, because if you rupture an aneurysm, you have about a 50% chance of not surviving, and very complicated treatment, whereas we have gotten very good at treating unruptured aneurysm. And it's very rare for an ophthalmologist to be in a life-saving mode. This is one place. Don't miss this. All right, the other one it's notable is what I'm showing you here, and this would be pituitary apoplexy. There's blood in the pituitary gland here. When this happens, the gland enlarges and can often put pressure only on the third cranial nerve and present that way. And you generally want to try to get to this quickly, because if you can remove the gland early, then you're more likely to be able to restore full function to the cranial nerve and even the optic chiasm, which is often involved in this. All right, does it matter if the pupil is spared? This is an old story. Those of you who are in the audience who are kind of in more my age and maybe even younger know that we used to teach that pupil-sparing third nerve palsy is never caused by a compressive lesion, and that's just not quite true. And I'm going to have to say to you, do not be deluded by that. That does not give you enough security. And so pupil-sparing isolated third nerve palsy can certainly be caused by an aneurysm. It's probably not common, but it is so easy to exclude that nowadays that I'm going to give you a blanket recommendation that everyone with a third nerve palsy, with or without pupil sparing, gets vascular imaging. So the next slide is going to deal with that. How do you manage an acute third nerve palsy? And the answer is prompt vascular imaging. Underline, bold, add vascular here. You need vascular imaging on everyone. I'm going to recommend to you CTA on adults, MRA in kids and in pregnancy. CTA is easy to get. MRA is not so easy to get. This will give you very, very good results. This is almost as good as CTA. Get this first and you can get it. It takes 10 minutes of study. And I would say they go right from your office to the scanner. And here's what will show up. This is the carotid artery. Here, keep your eye on that structure right there. That's the aneurysm. It's going to show up about 96% of the time if it's there, provided, of course, that you have a good interpreter. And I did want to recommend to you that if CTA and CT and CTA are negative in adults, these things come together as a package. With an arteriosclerotic risk profile, you do not need to defer and you do not need to do anything more. You can wait and let the palsy recover. But if the patient does not have an arteriosclerotic profile, then you are obligated to get an MRI scan. So that's the workup of an acute isolated third nerve palsy. Here's the rub. The rub is that we depend on others, and most of the time they're very good, but keep in mind that most radiologists do not get extra training in neuroradiology, and so they are likely to overlook a little tiny lesion like this. Of course, if you give them direction, it helps, but that's not going to be perfect. And if you'll see here in the Journal of Neuro-Ophthalmology, back in 2011, my colleagues at Emory pointed out that this study suggests that the experience of the interpreting radiologist is probably the most important factor in determining the reliability of a non-invasive scan. So you just have to keep in mind that we're just not always perfect on this. All right, one trap that it comes up over and over again is that you've made a mistake. It's not really a third nerve palsy. And here is an example. I already flipped the switch on this, but this is a patient who comes in with an adduction deficit in one eye, and you'll see it demonstrated here. You can see that patient can't adduct his eye, but he will be able to superduct. I won't show you that for the sake of time, but I will say to you that this was misdiagnosed. It's actually an internuclear ophthalmoplegia, and that requires completely different management. There are some other famous imitators of a third nerve palsy. You probably can anticipate what I'm going to show you here. And here they are, the big three: myasthenia gravis, inflammatory orbitopathy, including Graves' disease, and skew deviation, the great mystery guest that everyone always wonders exactly what is this? And the answer is we don't have time. All right, what else is not a third nerve palsy? Isolated anisocoria is not a third nerve palsy. Think peripheral, think iris, think other stuff. And when it comes to isolated ptosis, same idea. So you are obligated to look for the other features of third nerve palsy, but these patients should not be worked up in the way we work up third nerve palsy, and nor should these. There are other causes for these things. Look peripheral. All right, how do you evaluate young adults for this condition? And the answer is it's not CTA, it's MRI and MRA. It's a completely different story. You really need tissue imaging and blood vessel imaging. And here, for example, is a case of somebody with an inflammatory third nerve palsy. And there you can see enhancement of the nerve as it's just left the peduncular fossa. And that's a diagnosis that you would not like to miss. If you get a negative MRI and MRA, you may need further workup. And this is where, honestly, you're going to have to surrender the patient to somebody who deals more with these kinds of things. All right, let's segue into the fourth cranial nerve, which has a completely different anatomic course. You notice that this nerve leaves the dorsal portion of the brainstem. It exits right there on top and then circles its way around, has a long intracranial course all along the tentorium of cerebellum, and then eventually reaches the cavernous sinus, and from the cavernous sinus into the orbit. Most of the action is again in the subarachnoid portion, not so much in the cavernous portion. The fourth cranial nerve is rather robust there. You can get lesions in the dorsal midbrain that will affect the fourth cranial nerve. So, it's complicated. but it turns out that this fourth cranial nerve is not as much of a problem because why? Because aneurysms are not on the list here, so we don't have to worry nearly as much. There are some famous imitators of fourth nerve palsy. Here they are. They're pretty much the same as you saw before. So, keep these on your list. How do you distinguish a fourth nerve palsy from the imitators? And this is where you have to go to Marshall Parks, who gave us the legacy of the three-step test, which I will not remind you about, but it is there for us to keep in mind. Every resident who goes through any training program in ophthalmology learns this. And there is one other step. You can use the double Maddox rod to look for X cyclodeviation of the higher eye. These are two steps that every resident at Michigan has to pass before they can get out of the program. And if any of our graduates are listening, I think you'll back me up on this. And I bet that Bob Lesser does the same thing at Yale. Okay, so most fourth nerve palsies are isolated, and so what's the cause? I mean, the ones that are not traumatic. The answer is this very strange condition that I haven't even shared with you, but that you all know about, and that's the so-called decompensated congenital superior oblique muscle dysfunction. It's a very long term. Lots of people have different terms for this, sort of sagging eye. We don't understand this perfectly well, but it seems to be something that's more myogenic than neurogenic, and I will show you a little bit more about it in a minute. Fourth cranial nerve palsies can also occur from ischemia, and that's typically in these patients with this kind of profile. And then there are other causes that are quite rare. This one's a biggie, and I think you have to get this one under your belt. Here's this ridiculous anatomy of the fourth of the superior oblique muscle, coming along in here and jerking around this tendon here. And then attaching, going more than 90 degrees away. And you can imagine for yourselves that this muscle is likely not to last a lifetime. And so it's very common to see a decompensation of this muscle presenting in what looks like a fourth nerve palsy, but probably isn't. It's probably a muscle giving up. And how can you tell this from other causes? And the answer is a modest contribution that I believe we made here. And that is that hypertropia is greatest in contralateral upgaze, and that's always a sign of a decompensated superior oblique muscle. Nothing else will do this. And here's the article that came out of here, comparing hypertropia and upgaze and downgaze. And I think we've made a convincing case that this will help you and will allow you to avoid an unnecessary workup and major concern about intracranial disease, because this pattern is not typical of a lesion that occurs in the intracranial side. So how do you manage fourth nerve palsy? Here, you really want to restrain yourself. You perform imaging and get excited and worried and try to not frighten the patient only if the patient lacks features of a decompensated superior oblique muscle. So it's your job to find that out. And if the patient lacks an arteriosclerotic profile, if you can't find either of those criteria, then you really do have to perform imaging, because you're looking for the rare lesions that might be, meningiomas or schwannomas or some weird thing along the course of the fourth nerve, and you have to do it. Otherwise, you're really going to perform imaging only later, and that's only if the palsy has worsened or has not resolved within 3 months, and you cannot attribute it to a decompensated superior oblique muscle. If you can't meet those criteria, then you do eventually have to do the imaging. But you can see it's a completely different approach than we do for third cranial nerve. All right, let's segue to the sixth nerve. This nerve also has a complicated course, and you can see that it begins in the brainstem with a nucleus here at the pontomedullary junction. It then goes ventrally through that junction, comes out, and then makes an almost 90 degree. This is really an exaggeration for clarification, and it travels along the clivus, which is very important, along this bone here that's at the base of the brain, And then it makes a very sharp turn through Dorello's canal into the cavernous sinus. And this is going to turn out to be very important. There are lesions that occur here, and they're important, they're complicated, they give you other kinds of neurologic manifestations. Along the clivus, it can absolutely be an isolated abnormality of the sixth nerve. And then the important thing about this Dorello's canal is that the nerve is tethered in here. And when the brain sinks, as would occur with increased intracranial pressure or decreased intracranial pressure, then the nerve gets stretched right here at this point and causes sixth nerve palsy. You can also get sixth nerve palsies within the cavernous sinus, and here there's a special feature. The nerve lies within the sinus itself, and so when you get intracavernous aneurysms or fistulas, the sixth cranial nerve is often the first nerve to go. You don't have to worry about orbital disease, because just like with the other nerves, or rather with the third nerve, orbital disease is not a feature sixth nerve palsy is not a feature of orbital disease, because the nerve enters the muscle very early. So, disease within the orbit is not likely to affect the nerve. It affects the muscle, not the nerve. And of course, it's the lateral rectus muscle that it innervates. All right, well, this is this is going to be the appearance of a sixth nerve palsy, but I want to caution you that when you see something like this, be a little careful that you have not jumped the gun to say that it is a sixth nerve palsy, because there are imitators. This one is very likely, because of the slow abducting saccade, to be the problem. Watch that slow abducting saccade. That's more than likely to be a palsy rather than myasthenia or some restrictive problem within the orbit. But these are the famous imitators. Keep these packages in mind. Spasm of the near reflex is another one of those things we won't have time to go into, but it's always one of those things that's lurking there as a possible fake cause of sixth nerve palsy. And I did want to give you one other tip, and that is Duane syndrome is one of those embarrassing misses. You don't want to miss Duane syndrome, because that's a congenital abnormality. It won't show up on imaging, and it's not deserving of a workup. And the way you're going to pick that up, of course, is with the changes in the palpebral fissure height, and some other strange sort of up gaze and down gaze movement of the eye. Okay, so let's be sure, though, that the sixth nerve palsy is isolated. This is another big trap that we often find ourselves falling into. Particularly, I would say a big thing in my practice is that sixth nerve palsy is not truly isolated. And that, as I told you at the beginning of this talk, is a big factor in the way in which you're going to approach this. And let me give you 5 quick scenarios in which this mistake is made. The first is papilledema. If there's papilledema, then you may be dealing with a sixth nerve palsy from increased intracranial pressure, and that's a completely different set of circumstances than a sixth nerve palsy from a lesion along the nerve. So don't miss papilledema, that's important. The next one is nystagmus. This one's very often missed. Most of the nystagmus that you will see will be in side gaze or up gaze, in the extremes of gaze, and very easily overlooked. You get kind of overwhelmed with the idea that you've got an abduction deficit, and you tend to miss this. And if you do, you won't realize that you're dealing with a brainstem lesion, which could be extremely subtle, and people go fishing for a long time trying to figure this out. A common cause of sixth nerve palsy with nystagmus would be what? Would be multiple sclerosis in young people and occult brainstem stroke in older people. So it's a diagnosis you don't want to overlook. Another cranial nerve palsy is lurking in there as well, like a seventh nerve palsy or even a third nerve palsy. If you start getting combinations of third nerve, of multiple cranial nerve palsies, we're now talking about cerebellar pontine angle disease, meningeal disease, and even cavernous sinus lesions. So another scenario not to miss. Horner syndrome. Horner syndrome together with a sixth nerve palsy, that's a synapse that is worth sort of implanting in your brain, and the combination would lead you to a cavernous sinus lesion, which again, we just made radiology rounds yesterday. We overlooked a cavernous sinus lesion in a patient with, we think, multiple myeloma. The radiologist missed it 2 times in a row. These things can be extremely subtle, but if you see a Horner syndrome and a sixth nerve palsy, You just direct the radiologist there, and if they tell you there's not a lesion there, you say, look again. Okay, and the final one, the one that really tripped us up, and we ended up publishing some cases on this, was a previous lumbar puncture, or in our case, epidural pain device put in for somebody post-op, let's say for a chest lesion. If you do an epidural puncture, you may end up puncturing through the thecal sac into the subarachnoid space, and then a big leak occurs, and you get intracranial hypotension, and you get a 6th nerve palsy. And I've seen litigation over this. It's something that you just do not want to miss, because these things can sometimes be at least helped with a blood patch, and you don't want to make that diagnosis. All right, so what causes a 3rd nerve palsy? In older adults and young adults with an arteriosclerotic profile, ischemia is going to be, 6th nerve palsy. It's going to be ischemia, 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 and then inflammation and tumor are the other causes. In children, you know, ischemia is not a factor. So inflammation and tumor, which is of course what requires a completely different approach to children and young adults than you do with older adults or those with an arteriosclerotic. See what a difference it makes, what kind of profile you're bringing to the table. All right. In younger people and older adults with an arteriosclerotic profile in a 4th nerve palsy, you can defer imaging and allow spontaneous recovery within 3 months. If there's no recovery or it gets worse, you order an MRI scan. And in children and young adults, of course, you need an MRI scan at the beginning. So you see how the whole approach depends a little bit on the cranial nerve involved, on whether it's isolated, and on what the age of the patient is. So let's just summarize all this. Non-traumatic 3rd nerve palsy, all adults. If the palsy is isolated, you have to get prompt CTA. And prompt really means prompt. The patient doesn't go anywhere, particularly if the problem is very acute. One of my colleagues in neuro-ophthalmology told me about a patient of his in whom he diagnosed a 3rd nerve palsy. He sent the patient out into the waiting room and called the radiologist and went to arrange the CTA. He went out to find the patient collapsed in the waiting room with a ruptured aneurysm, and the patient did not survive. So these things can happen very quickly. It's very scary. It's a CTA before you pass go. CTA is negative, then go on with waiting until the palsy resolves, and then if it doesn't resolve, then you have to get imaging. If CTA is negative in younger adults, of course you have to get an MRI scan, because those patients could have lesions that are not ischemic. In children, you want to get MRI and MRA at outset, and I think we covered all that. In 4th nerve palsy, older adults and those with an arteriosclerotic profile, you want to look for the decompensation. Don't work up these patients. It's completely unnecessary. And really, you can reassure them in the office that this is not anything serious. These are patients who get operated on, and I have in the past operated on many of these patients, and it often works very, very well. You can do a myectomy of the inferior oblique muscle that really will give them great relief. If the palsy is not just decompensated, you should again defer imaging in older adults, and then if there's no recovery, the same argument. In children, you really do have to get the MRI at outset. That's again provided that it's not decompensated, but in children and often you won't find those features. All right, 6th nerve palsy, defer imaging. This is a little complicated. It's a little hard to convince people who have a new 6th nerve palsy that they don't require imaging. You may say, thank you very much, Dr. Tro, but I'm not sure I'm going to follow your advice on this one. You would be certainly justified in deferring imaging if you can convince the patient that it's very likely that this is not going to be a tumor and that you're going to be getting better on your own. And with children, of course, you have to do the MRI at outset. So that's it. That's the message. I hope that you got some guidance out of this. I think this is a relative consensus now. Bob Lesser may correct me on this, but I'm guessing that most of the people in the neuro-ophthalmic community would share these ideas. So Bob, would you have any comments on this?
I have no corrections.
So we agree on this? Is this the only thing we agree on, or?
We agree.
We agree, okay.
Also. And now we'll let you transition right away to seeing but not recognizing.
All right, so I will, first of all, I guess I should stop sharing for a moment, and then now I've got to find my other talk here.
In the
Okay, it does
meantime,
seem,
we do have one question.
Okay.
From the audience. They'd like to know, do you screen for giant cell in older patients?
yes, good idea. I left that out. Yeah, diplopia is not a common feature of cranial nerve palsy, and it may even be not from a cranial nerve palsy. It may be from ischemia to the muscle, but we have to reserve judgment on that, and you're absolutely right. Unfortunately, yes, you do have to screen for it, and you're often going to get a positive, sedimentation rate will be up, and so will the C-reactive protein, and then you're going to be forced into a negative biopsy. And we do these over and over again. Fortunately, it's I don't know. It's a problem. It's a problem. I don't. Bob, do you have an answer to that?
First of all, I'm suspicious in anyone who's at the right age group. I always at least draw a SED rate and C-reactive protein and screen for the history, and that's very important. That's about the extent I go, but I'm always considering that as a diagnosis.
Yeah, unfortunately, yes. I think the answer is, yeah, you got to do it. So let's see, I'm gonna, if I can find my pointer here, I will try to enlarge the screen. There we go. Oh, no, that wasn't it. So somehow I have gotten to, all right. So this is a subject that's dear to my heart, and also Bob Lesser loves this topic. So that's one of the reasons I chose it. And I'll explain that in a minute. As soon as I'm done, I get equal time with Bob. But anyway, I'm calling this seeing but not recognizing. But I probably should say it's really more seeing but not perceiving, because this is a talk about perception. And if there are any optometrists in the audience, they will know that this is an area that optometry has in a way co-opted. It's been taken over in the past by optometrists, and the reason for that is ophthalmologists have not been that interested in this area. And as a result, I would say we've seeded this area, and I would like to take it back and give you a few pointers about this. I really should title this Seeing But What the Heck is Happening Here, because these patients are so bizarre that very often they are written off as being crazy or faking or something, and underneath this there is something going on, and this will remind you a lot of this man here. Do you recognize this guy? This is Oliver Sacks, and Oliver Sacks, you've read his book, some of you, and he died just I think the last 2 years or so ago of metastatic ocular melanoma. That just the cruelest thing. What a guy! He wrote these wonderful books, and so this lecture is in a way homage to Dr. Sacks. All right, I don't have any conflicts on this.
You need to share your screen.
Oh, so you're not seeing the screen. Okay, so. Now I somehow have gotten out of this. Okay, are you seeing it now?
We are seeing you.
You're seeing me, okay. All right. So I don't know here, let's find this. And you're still not seeing it?
Correct.
Let's see, I have to. Okay, now let's see, share screen. And are you seeing it now?
Yes.
Yes.
Okay, so we're there, but it's,
Great.
okay, are you seeing it now?
Yes. Yes.
Oh,
Joe.
wonderful.
Excellent.
Okay, so let's go on. This is Oliver Sacks. I just showed you a picture a minute ago. So let's move on here. And, neuroscientists have told us that that visual perception really is divided up into two components. And I'm showing those here to you. Spatial vision, which really has to do with the relationship of one image that you see compared to the other. In other words, if you see my face, you're wondering, what's the relationship of my face to something else in the background? And then there's this other component down here that's in the occipital temporal region, and that has to do with recognition. That is the ability to tell whether something is. So are you here? Can you hear my voice?
Now we can, yes.
Yes, we can.
Okay, I'm sorry for the flubs. Okay, so that you have spatial vision and you have object vision, and some people consider this pathway the where pathway, and this pathway the what pathway. So this is where things are in space, and this is what they are in relation to what you know and what you've experienced in your earlier life. So this has to do with familiarity or recognition, and this has to do with spatial relations and attention. And those are concepts that we not often deal with, but neurologists deal with them all the time, and certainly I do. Okay, so I'm going to start by showing you a patient who has bilateral parieto-occipital lesions. So those are going to be in the where pathway, and I'm showing you here with these arrows where these lesions will be on both sides of the brain. And that will generate a condition called Balint-Holmes syndrome, which is named after Balint, who was a Hungarian neurologist, and Holmes, who was a British neurologist. And they together get credit for describing what people look like who have this, and they will come to ophthalmologists only. Okay, so here's my patient, who is a 65-year-old woman who almost got run over when she was crossing the street. And her daughter said, it's because she can't see. But when she comes to you, she has 20/20 visual acuity in both eyes. And, you're wondering, and her eye exam looks perfectly normal, and you're wondering what is going on here. And here is an examination of this patient. So this can frustrate you. And here, this is what this patient generates, is these very, very constricted visual fields. And, you're kind of puzzled as to what's going on. And then you go on and you do this exam here. So she's reaching for that card and she says she sees it, but somehow she can't find it. And here is what she looks like when you have her follow your finger. So she seems to be following it, but not really. And then here she is. So you can see how this So you see, she has the concept, but she just cannot put it together visually. And this is what her brain looks like. And you can see that the back of her brain is atrophic. And you can see it here on MRI scan. And here might be an autopsy of the brain. And you can see that the sulci are large and the gyri are small here, and it's mostly in the back of the brain. And some people have called this posterior cortical atrophy. It's actually a form of Alzheimer's disease, which again has gotten the moniker visual variant of Alzheimer's disease. It's Alzheimer's disease manifesting predominantly in the visual spatial domain. And here is a PET scan showing hypometabolism in exactly the area that is most affected in these patients, which is the parieto-occipital area. The very area that I just pointed out to you is the one that has to do with visual spatial concepts and attention. So that is what people have decided is the underlying concept of Balint-Holmes syndrome. It's a disorder of distributed attention, and that concept is itself difficult. Distributed attention really is when you are looking at things, you have to decide how much valence, how much importance, how much priority you're going to put on each thing that you look at. So if you were looking at my face again, at this point you would say, well, he's the guy I want to look at. I don't want to look at the person next to him, and so on. That and all of that has to do with limbic inputs and putting importance on certain things, and that seems to be what these patients cannot do. So there are three fundamental clinical features that you will see in this Balint-Holmes syndrome, and here they are. Acquired oculomotor apraxia. The patients are unable to generate saccades or pursuit to command. They can do it reflexively, but they cannot really do it properly to command. And you saw that this patient, how terrible her pursuit was. She's just kind of all over the map. The second feature is something called optic ataxia, where patients cannot reach accurately under visual guidance. And you saw that as well, the patient trying to reach for the Snellen card there. It's called optic because the ataxia is really entirely based on being under visual guidance. If you close your eyes or you ask the patient to touch her nose, she can really do it. So that's the optic idea. It's different from other forms of ataxia. This one is by far the most interesting feature. Some people have called, this was a German neuropsychologist who named this simultanagnosia. And this is the one that's the most interesting and the one that really affects us when we're examining patients. They can't integrate elements into a visual display. And this is the one that the illustration that I like best. This is a famous painting by Arcimboldo, who lived in the 16th century. And you can see that this is this whole thing is made up of fruits. And patients will look at this, and what they will identify is that this is an apple and these are grapes, but they cannot tell that it's a face, that it's a person. And moreover, when they read, if you give them a reading passage to do, it was raining in the morning, but by afternoon, the sun came out, so the boys were able to play ball and so on. This is what they will do. They'll say it was raining, and then they get all mixed up, and that's because they have a spatial alexia and they move phrases around. If you could imagine what it must be like for these patients to have this unstable perception, it just kind of comes and goes, and it's all jumbled, and will drive them crazy, and it will drive you crazy. The simplest way to pick off these patients is that they cannot do anything on this. This is the control plate, which everybody says, you should be able to do, but these patients can't do it because this is a visual spatial task, and they cannot rearrange this to indicate the number 12. A patient of mine who looked at this picture of a baseball said it was railroad tracks. And here's something else, a term that's been applied, the spasm of fixation. or the visual grasp reflex, if you show a patient like this a dollar bill, they may say that they see that that's George Washington, but they have no idea that it's a dollar bill because they are so consumed by looking at this that they do not see what's around the edges. And that's this concept of simultaneagnosia, the inability to integrate all the elements into one thing. And that's why these patients will often generate these very, very small visual fields because they are completely consumed. Now, this whole concept of poor distributed attention has real world implications. And I'll show you this has been adopted actually in California in kind of visual screening for drivers. And you can see the concept is the useful field of view. Some of you may have heard of it. Those of you who may be attending who are optometrists will be very much more familiar with this. If the patient is confronted with an object at fixation, he or she will be very slow or may never actually see the other image that's then shown in the periphery. And you can imagine that if you're a driver and you are looking ahead of you and you have this condition, you may not see another car coming at you. And that's the implication of this. It's not really a loss of visual field in this traditional sense, but rather a problem of spasm of fixation. All right, well, I wanted to just be sure that you knew that there is an acute form of Balint syndrome, and that's border zone infarction. So if you have a heart attack, as this patient had, and you infarct this area here, which you see on necropsy in this specimen here, where you have this bloody area right up here, that can certainly give you the same features, maybe not quite as severe, but certainly worth reckoning. So that's the acute form. And we're now going to segue into one example from the temporal occipital portion where object vision or the what pathway is lesioned. And I'm going to show you an example of a unilateral left temporal occipital lesion. And this one you may have run into in the past. Let's see. This is going to be called pure alexia, also known as alexia without agraphia. It was described quite a long time ago. Here is an example. Here's a 65-year-old man. I made it the same age as the other patient. He awakens and he says, I can't read the newspaper. And when you get him on the Snellen chart, he doesn't do very well. And here he is. So he calls it a P, but watch. He says that's a D. But look, he traces it out beautifully. Now he knows it's an N. Okay, so he has a right homonymous hemianopia. So this is pure alexia. It's a disconnection of the visual cortex on both sides from the language center, which is in the left, for most of us, in the left angular gyrus. So, you know, the common causes here are a posterior cerebral artery occlusion. That's by far the most common cause, but there are these other causes as well. And here is a picture of a stroke that will typically do this. This is a big one. It's a proximal posterior cerebral artery infarct, and it is impairing the communication between this visual cortex and this one, because this one's lesioned, and the splenium, which carries information across from one hemisphere to the other, cannot get to the angular gyrus over here. You get pure alexia or alexia without agraphia. So, you know, these patients, this is what they'll look like to you. They sometimes read letters correctly, and so they may pass the Snellen test, Snellen acuity test, but they can't read words unless they spell them out letter by letter, as you saw with this patient. If he can spell it out, he can read it. So this is a disorder of reading, and it's an isolated disorder of reading, acquired. This is not a dyslexia, this is an alexia, an acquired disorder. They can write and they can spell to dictation, so this does not qualify as an aphasia. It's not an aphasia, and there are no other language deficits. Almost always you're going to find a right homonymous hemianopia. In fact, I try to tell our residents that if they see somebody with a right homonymous hemianopia, you better look for alexia, because that could be there, and that's so much more devastating than just a right homonymous hemianopia, which will make you read slower, but it will not interfere with your ability to read. And there are patients who have the severe form of pure alexia who cannot even read single letters, so they fail the Snellen acuity test, and you're going to be looking for problems in the eyes to explain this, and you won't find them. So one way you can get around this, of course, is some patients will be able to do the tumbling E's because the tumbling E's do not require a lexical ability. You can do this on the basis of the orientation of those fingers in the E. So the deficit often improves in time, thank goodness, but many patients never completely recover. So this is an example. This one that I've just showed you, shown you is an example of a visual agnosia, which is the kind of disturbance you get from involvement of this pathway. And it's basically, as I said to you earlier, it's a recognition disorder, and you don't recognize familiar items. For example, in this case that I just showed you, it was lexical information. That's reading material. But there are other examples, and this can be so severe that you don't recognize any objects. So if I showed you, a pen or a pen light or or a key or something like that, you would not be able to recognize it by sight alone. But if you touched it, you would know what it is. And then the more famous example of this, which is prosopagnosia, and that's the inability to recognize faces. And these can be isolated disturbances. You may get one without the other. And we show patients familiar faces and see if they can pick them up. I sometimes laugh if any of you in the audience that failed this test, see me after class. All right, so the big question for you really and for me is, can you diagnose this stuff in your office? And the answer is yes, you can. And so let me offer you a couple of office tests here. The Boleyn-Holmes syndrome, you can show patients a reading sample. That's not something we usually do, but maybe after you've heard this lecture, you get somebody who stumbles on the Snellen acuity chart, you'll think about doing that. Visual grasping, you can have people try to reach out for something and you'll pick it up. And then of course the Ishihara control plate, the patient who misses this, you may be inclined to say the patient is faking, but if the patient has other features that suggest Boleyn-Holmes syndrome, you will be thinking more in that vein. All right, so there's that control plate, which comes in handy. And finally, for pure alexia, if the patient is stumbling, then go to the tumbling, which is a little mnemonic that I remind people of. If they can't do Snellen perfectly well, give them this. And if they do that pretty well, and they have a right homonymous hemianopia, you may be onto something here, and that's this pure alexia. Making this diagnosis is helpful. It certainly explains why people are having so much trouble. And just a reminder, these are people who can't read, but they can spell and they can write. And then after they've spelled it and written it, they can't read it. Or rather, if they've written it, they won't be able to read it. And that's the clue to the diagnosis. Okay, that's it. That's my transition to this guy here, who is our next speaker. And Bob, are you there?
I am here, thank you.
Okay, so I don't know if I will stop sharing in a minute, but okay. First I want to say a few words about my dear friend Bob Lesser, who has just or is about to retire from a brilliant career as a neuro-ophthalmologist in Connecticut, really in the world. And what is it, Bob, 50 some years of doing this? Putting down your instruments, putting down your, your optokinetic tape. And Bob has done sort of a twofer. He's been a community ophthalmologist as well as the neuro-ophthalmologist extraordinaire at Yale. He has trained umpteen residents in ophthalmology, in neurology. He has trained fellows, many medical students. They've written papers together, which have had a great impact on patient care. They're wonderful to read. They have a lot of practical value. Where did this guy come from? He was born in New York. He's a New Yorker. Maybe when you hear him talk, you'll recognize the lingering bits of a New York accent. Went to Queens College, then Cornell, medical school. Then he did his residency at Yale and neuroophthalmology down at the Bascom Palmer Eye Institute in Miami. He has won gazillions awards. They're just too numerous to count, including the Senior Honor Award, whatever you call that, from the American Academy of Ophthalmology. He has won the teaching award a record 4 times at Yale. I don't think anybody else will ever match that. This sounds like Rafa Nadal, who almost made it to 14, but anyway, in neuro-ophthalmology, it's the equivalent of Rafa Nadal. Bob has been a participant in the major clinical trials in neuro-ophthalmology. He's given talks all over the world, publications, over 100 publications, and an expert on Lyme disease, spirochetes of all kinds, Creutzfeldt-Jakob disease, idiopathic intracranial hypertension, optic nerve sheath meningioma, you name it, and also non-organic vision loss, which is where I will stop sharing my screen and invite my dear friend and neuro-ophthalmologist extraordinaire, Bob Lesser, to give the next talk.
Thank you very much, John. I appreciate that very much. Let me go to share my screen. Ed, has that come up?
Yes, I'm still on and I can see it.
Good. Okay, so let me start right here. And I'll bring this up here. Good. So today I would like to talk about non-organic visual loss, also known as the acronym of NOVEL. And I have no financial disclosures. And what's in a name? Terminology, very interesting. This has been caused, has asked you to start your video. Well, I'll wait on that. Okay. Novel is, remember, can be fiction, but there are many other terms that have been used: hysteria, functional, malingering, conversion disorder, feigning, fictitious, and factitious. And so, Ed, I am not able to move this forward. Let's see. Good. Okay. So functional, everything is working. And interesting, the word hysteria comes from the Greek. I mean, hysteria is uterus, and hysteria used to be thought to be a uterine condition. Greeks believed that nervous symptoms were observed only in women and therefore uterine. Plato thought the uterus had a will of its own to produce children. If unfilled, the uterus became restless and wandered about the body. When below the cartilage of the ribs, it's called hypochondria. So I think we'll return to the term novel or non-organic visual loss as the most politically correct term for today. What I'd like to do in the time that I have available to me is to discuss what are my favorite tests. And I'd like to start off, first of all, with the patient presents with decreased vision in one eye and what the refraction strategies are that I like to use. Let's do a case of a 38-year-old man with blurred vision in the right eye for the last 3 years. He had 3 procedures for sinusitis with fluctuations in vision after each procedure. When I saw him, his vision was Count's fingers in the right eye and the left eye was 20/15. His pupils had no afferent pupillary defect on the right eye, and cranial nerve testing showed he had decreased sensation of first and second division of 5, but at the midline. And recall that, of course, there's cross innervation at the midline with the cranial nerve. So this gave us a sense right away that this guy was probably faking. We then did a polarized refraction, which documented he could see 20/30 in the right eye, and what I call then a microscopic killer refraction, which also showed that he could be improved to at least 20/30 in the right eye. So my 2 favorite tests that I want to discuss today are, one is the microscopic killer refraction, and the second is the prism dissociation test. Microscopic killer refraction, you start with the phoropter open in front of both eyes, and you blur the vision in both eyes. Then you gradually change the lenses bilaterally using the correct refraction in the bad eye while leaving the good eye blurred. I apologize for the background noise. you start at the 2010 and you perform dramatically. And what I mean by that is that you take your time, and doing very carefully to review all this. You turn the lights on, you turn the lights off, you ask the patient to look carefully. So here I'm starting at the 2010 line, and I go up and I point. Are you sure you can't see any of those letters? I turn, again, I'll use the Risley prism, I'll use the Jackson cross cylinder, and spend a lot of time doing this. And of course, at 2010, no one usually sees that, but at least they got the concept of what's happening. I then turn it up a little more up to the 2015 level, and I repeat the same strategies again. And again, the more dramatic you can make it, the more you can perform, the easier this becomes for the patient to fall prey to your plan. And again, by the time then, usually you get to the 2020 level, they think it's the big E and they read it off to you. I ask them to read it forwards or backwards or individual letters or guess. And I'll use, as I said before, the Jackson cross or Risley prism or sometimes a pinhole. And usually that's quite effective. The disadvantage of this test is it takes time. You also can do it with individual, you can do it with vertical letters like this, starting at the very low level here and working your way up. That's another strategy that can be used. So I call this the microscopic killer refraction. It's also been called the doctor killer refraction. And Lawton Smith used to call it the toothpaste refraction, squeeze it out of them. So it takes time. The other test, which I like a lot, is the prism dissociation test. Here I'm putting two base down prisms in front of each eye. And what I'm doing is confirming that the patient had no history of diplopia. I'm then confirming when I put the prisms in front of the eye that indeed I've induced diplopia. Then I place a half prism diopter base down prism in front of the good eye and a 4 prism diopter base down prism in front of the bad eye. That confirms, therefore, that the image that you're going to see will be from the bad eye will be inferior. And here you can see on panel A, if the patient actually is faking, then they're going to be able to read both lines. And I usually ask them to read it quickly. I say, read the bottom line backwards for me first, then read the top line forward. And then, but on the other hand, if they truly had organic disease, as you see in panel A, then of course it would be blurred right there. Now you can do the same thing with individual letters. And here again, patient's faking up on top and has real disease on the bottom. Now, the prism dissociation test has the big advantage, it's much quicker. And so I often do that as a screening test. Here's another example of a 32-year-old man who had real disease. He was hit with a bungee cord in the left eye. He developed a hyphema and retinal edema with vision improving from Count's fingers to 20/50 in 8 months. But his visual field showed generalized constriction. His ophthalmologist had given him a disability of 43%. When I saw him, his vision was 20/20 in the right eye and 20/50 on the left. The prism dissociation test confirmed that he actually could see letters, 2 of the letters on the 2015 level. And then with more time with the microscopic killer refraction, I could document he could see 2015 also. So those are my 2 favorite tests that I love a lot and find them very helpful. Now you can also do the red-green duochrome. And here, of course, in order for a patient to have if both eyes are functioning, then with a red-green glass, they will be able to read the letters on either side of the panel. The problem in my hands for this test is that I find that the patients often will close one eye quickly and sort of figure out how this works. Mm-hmm. You also can do the same with the Polaroid lenses. I place Polaroid glasses on a patient. Some letters are, of course, again, seen only by each eye. If all letters are red, then gotcha. So another test that's no longer available, one that I like a great deal and I just want to present for historical purposes, was actually developed by a former Yale resident with me, John Bullock. And it's called the Binocular Integrated Multicolored Vision Assessment Test, or BIMVAT. And here what you can see, again, instead of red-green, you're using blue and orange, but again, you're isolating 2 eyes with the filters. And so either it's going to be, if they really have disease, it'll be read as an L. If they have organic disease, if they're non-organic, it'll be read as an E. And what I like about this passive-aggressive thing on plates 9 and 10, if the patient spells out all of these letters, what he or she has spelled out is, I really can see, and you just proved it. Now, in a younger patient, you can fog one eye, you can use cycloplegia and then ask the patient to read it near. That's another option. So the key points for the refraction that I want to go over again are that my two favorite tests are the prism dissociation test and the microscopic killer refraction, with the understanding that usually what I'll do is do the prism dissociation test first. And once I have a good sense that this patient is faking, that's the point at which I will then go ahead and do the microscopic killer refraction, which takes time. Now, sometimes you'll have patients who present with a fixed dilated pupil like this. And you have to worry, is that an aneurysm? You heard John just give a wonderful talk about how you should be aggressive in terms of doing CTAs. But keep in mind and remember that if you have pupil dilation with no other evidence of a third nerve palsy, this is local pharmacologic blockade or an 80s pupil or something like that. It is not a third nerve palsy. And so again, you can use 2% pilocarpine and you'll document it doesn't produce constriction. And so you really want to be careful. Has the patient put anything in their eye that could have produced this? Now, either it can be done inadvertently or deliberately, contamination from transderm scope. You could use Jimson weed, particularly in the Midwest. What this patient that I showed you had, he actually got a hold of belladonna ointment and put it in his eye. And we were able to find he was able to even give it to us so we could see it. The other important point for your pupils when you're dealing with visual loss in one eye is look for the APD. If you see nothing in the anterior or posterior segment and you don't have an APD, that should certainly raise the suspicion that this is going to be non-organic. It's not always the case, but it certainly is possible. I'd like now to transition to non-organic visual field loss. And let's do another case. Here's a 22-year-old woman with temporal field loss after an automobile accident. Interestingly, she had no loss of consciousness. Her vision when I saw her was 20/60 in the right eye and 20/20 in the left. And I could document that with the microscopic killer refraction that her right eye actually could be corrected to 20/15. Here's her visual field, and you can see this temporal loss in the right eye only, which is an unusual defect, but it can occur. Remember, you can get posterior optic nerve disease that can produce this. So anyway, we worked her up further. We did a Goldman visual field. It showed a temporal defect in the right eye, but it showed no respect for the vertical meridian. So we were suspicious right away that this was not real. I then did the test that I call the Saccade NV field test, which I'll explain in more detail. And that showed that her temporal field was full. My final impression was that she had non-organic visual field loss. So let's talk about this test, which I like a lot, called the Saccade NV test. Here you see in panel A, the patient's visual field is being tested. And the examiner is asking the patient if the finger can be seen in that spot. And of course, the patient is saying no. On panel B, what I'm doing here, what the examiner is doing at that point is actually telling the patient at a different time of the exam, we're now going to test your eye movements. We're testing your pursuits and saccades. And with this, you put fingers up on both sides, or hands up on both sides, then put your finger up and say, I want you to look at this finger as quickly as you can and go back to my nose as fast as you can. And many patients will then fall for this right away. And I'd like to show you a video which shows this in much more detail. And I hope you're impressed that you'll see that sometimes for some non-organic visual field patients, I will even make a house call.
You're wearing sunglasses all the time, I noticed, since you've had this accident. Why do you wear, does the light bother you all the time?
It does. The light bothers me, whether it's natural light, electric light. At night, it bothers me.
At night?
Mhm.
Do you drive with them at night?
Yes, I
Wow,
do.
okay. Well, the test I'm going to do, I need you to take your sunglasses off, please. And what I want you to do is cover your left eye with the palm of your hand. And I'm going to have you look here at my nose. And you're bumping into things all the time, is that right?
Yes.
So I want to just test for that. I want you to tell me when you can see my finger for the first time. As I move it in, just tell me when you can see it. You don't see it yet? Okay. Tell me when you see it.
Now I can see.
Okay,
it.
good. Now I'm going to do the same on the other side. Tell me when you can see it. Tell me when you see it for the first time.
Now.
Now you see it. Okay. Let me step back farther and see. Here, cover your left eye again. Same thing. Tell me when you see it now for the first time. Look at my nose. Look at my nose. Keep looking. Keep looking at my nose.
Now.
Good. And the same thing over here. Can you see my finger at all?
No.
All right. Tell me when it comes into your view.
Now.
Okay, thank you. So now what I want to do is cover your left eye again. I'm going to test your eye movements, which have anyone said you had any problem with your eye movements at all?
No.
Good. Cover your left eye for me with the palm of your hand. Look here at my nose and follow my finger for me, just like this. Follow my finger. Excellent. Whoa, excellent. Look at those. Has anyone ever told you a great smooth pursuit?
No.
Wow, that's terrific. Keep following it. Okay. Now I want to test another eye movement that's called saccades. These are fast eye movements. What you're going to do is look at my finger, and then as soon as you look at my finger, go back to my nose as fast as you can. Look at my nose straight. Go ahead. When my finger goes up, look at it now. Go ahead. And now go back to my nose. Terrific. Look at my finger. Look at my nose. Look at my finger. Look at my nose. Wow, that's terrific. Gotcha.
Okay.
You're wearing sunglasses.
So again, you can see here's an example of the patient who, when testing, we told them that we're testing saccades, she then looked far away where she previously couldn't. The other field test that abnormality you want to look for is what's called the cloverleaf pattern, and this is on Humphrey visual fields. Most people don't have access to a Goldmann field anymore, but you all have access to Humphrey fields. And the Humphrey field can show here, remember that when you're testing, well, I'll show you on this next picture, it's easier to appreciate. Here you can see right here that these are the first 4 spots, 9 degrees from fixation, that are to determine threshold for the field that's being done. So if the patient responds to that, but then afterwards has no response beyond that, you get this strange looking field, which is classic for a cloverleaf and for automated perimetry, showing that this is non-organic. And of course, you see a central area. Remember, patients who present with decreased visual acuity, but really have a small, even a central field, that is physiologically inconsistent. Now, there are very many different types of visual field loss you can see. There's generalized constriction with decreased visual acuity. It's often seen in patients with idiopathic intracranial hypertension. You can sometimes get a unilateral hemianopia, as I showed before. Sometimes they're binasal or bitemporal defects, central scotomas, cloverleaf pattern. Interesting, a homonymous hemianopia is rare. So one of the things that I do is that I will repeat the test with special lenses that I tell the patient enlarges the field. I'll sometimes encourage the patient to concentrate and try harder. I'll tilt their head in one direction or another. I test with both eyes open, and I test with either a tangent screen or at least by confrontation at different distances at 1 and 2 meters. Remember, the normal field should enlarge. If it remains tubular, then it's non-organic. And that's actually seen right here on this graphic that I got from Nancy Newman. As you can see here on the left, this is the funnel field. Here it's constricted. It's this level at 1 meter, but it enlarges at 2 meters. And here, with a patient who has non-organic disease, the field remains the same width here and here, so consistent with the tunnel. So if it's funnel versus tunnel. Now, the classic one you also see on Goldmann fields is the spiral defect. And you also, when you test patients bilaterally, here's a patient who had a temporal defect in the right eye with a normal field in the left. But suddenly when you combine the two with both open, it became a homonymous hemianopia. Same thing here, you have a markedly constricted field on the left, and you have a full field on the right, but that converts to a homonymous defect here. So again, not physiologically consistent. So the key points here are look for the cloverleaf pattern field defect, remember to do the saccade envy test, and then test at 1 and 2 meters, remember to look for funnel versus tunnel. Now I'd like to switch to motility, and actually John made reference to this, and I will discuss this in more detail. There are 3 movements, 3 things you want to look for that suggest non-organic motility disease. One is spasm of near reflex. Second is voluntary nystagmus, and the third is monocular diplopia. So here's a patient that looks like she has a 6th nerve palsy. But if you look carefully, she actually has some pupillary constriction here. And what's important to recognize is that this is intermittent. And that's seen here best on this patient who presented like this. And then here about 30 seconds later, she could look out an AB duct completely. With a real 6, that's not going to be the case at all. And we actually have a Yale resident, Greg, who is kind enough to demonstrate we made him a car accident victim here, and you can see he has the ability to do spasm of the near reflex.
This gentleman was in an automobile accident, and he claims he's having double vision. Can you look to the left now? Can you look to the right now? Now look straight ahead again. Can you do it again? You can still do it? Can you still have weakness in the, there he goes. Perfect.
And even with that skill, he's going into glaucoma, not neuro-ophthalmology. Very
Oh.
This gentleman was in a
Now, also, you want to look for voluntary nystagmus and recognize it. It's rapid, small amplitude, high frequency oscillations that are intermittent and often associated with the sort of lid flutter that you're seeing here also. And then for monocular diplopia, clarify, are they really talking about a ghost image with monocular diplopia, or they mean two distinct images? If you have two distinct images from one eye, then it most likely is non-organic, and that can be confirmed with the pinhole when the diplopia doesn't go away. So the key points for motility are, again, look for spasm of the knee reflex, recognize it, think of it when it looks like, because it looks like a variable sixth. Recognize voluntary nystagmus and be aware of monocular diplopia. Now, how do we approach the patient with profound visual loss in one or both eyes? One of my favorite tests is the Narcissus test. And here, what you're doing is the patient's claiming that they have Count's fingers or light perception vision, and you put a mirror in front of them and you move the mirror and see if they respond. And I have a video that will show that here.
We're holding a mirror in front of you now. Do you see your eye in that mirror?
No, I
Not at all?
don't, I don't see anything.
You're sure? Okay.
Yep,
Now, you still don't see it, is that
No.
correct? You
No.
sure you don't see it at all?
mm-mm.
Thank you.
Okay, now you can also do the same with an OKN tape as
We're
well.
holding a,
Right here, you can see with an OKN tape. Here, we'll demonstrate with this video.
now I'm gonna show you some diamonds here. Do you see anything on this tape that's moving here?
No,
You don't see anything?
no,
No? Okay, stop.
Now, what I'd like to do is go over a few proprioceptive tests that can be helpful. If you instruct a patient who's blind to look in their hand, they will look in the direction of their hand. A blind person won't see it, but they'll still look directly at it. Non-organic looks to either side. And then finger touching is a very useful test. Here on the panel on top, what you can see is that the patient's eyes are closed, and yet they can still touch their index fingers. This other patient down below, who looks like Nancy Newman, is actually faking at this point, and she's claiming no light perception in the eye, but claims she can't touch her fingers. So that's a very useful test in the appropriate setting. Also, you saw my patient that we did the house call for. She was wearing sunglasses. That's very commonly seen in novel patients. And in one study, about 50% of the patients wore sunglasses. And another study, 26 of 27 of the novel patients were claiming workers' compensation, disability, or there was a lawsuit involved. So always think about that. Now, it's important not to be cavalier about this. You really have to be sure that you're not missing subtle but real disease. So on the cornea, look for irregular stigmatism, early keratoconus, anterior basement membrane dystrophy, corneal scar, amiodarone. Look for a subtle cataract like an oil droplet one, or look for minimal nuclear sclerosis. For retina, you want to make sure that you have a normal OCT. Otherwise, you will miss things like occult macular dystrophy, a cone dystrophy, paraneoplastic retinopathy, early Stargardt's, minimal epiretinal membrane, paracentral acute middle maculopathy, or acute macular neuroretinopathy. All can be missed. For optic nerve, always be sure you've ruled out toxic or nutritional optic neuropathy, autosomal dominant optic atrophy, or low tension glaucoma. Now, sometimes you will get non-organic disease associated with other diseases, as you saw in the patient I presented earlier. This is classically seen in idiopathic intracranial hypertension. Many of them present with a constricted visual field, and yet their optic nerve doesn't look anywhere out of as damaged as you would expect it to be for a patient who really had that kind of damage. There have been reports, Rod Faruzan reported some patients with non-organic visual loss in patients with multifocal intraocular lenses. And then there have tragically been troops from Afghanistan and Iraq who had either eye or non-ocular injuries while serving in combat operations in Iraq and Afghanistan who had non-organic visual loss. So in summary, I like to review again that for a refraction, Remember the microscopic killer refraction, remember the prism dissociation test. For visual fields, remember saccade envy test. Look for the cloverleaf pattern. Remember to test at different distances, looking for funnel versus tunnel. For motility, recognize spasm of the near reflex, recognize voluntary nystagmus. For profound visual loss, remember the Narcissus test or OKM. Don't miss subtle disease. Check for both real and non-organic disease. Multiple visits may be necessary to confirm the diagnosis. Don't get caught napping. Be alert to non-organic disease. Thank you very much.
Thank you, Dr. Lesser. A wonderful, wonderful talk. If Dr. Trobe and Dr. Lesser, if you'll stay on for just a minute, we have a couple
Sure.
questions. But I did want to point out, Bob, your videos look quite good. You actually had multiple camera angles and
Wow.
it seemed well directed. So kudos to you for high quality videoing.
Well, thank you. I'll tell you, that's kudos to my son, who's actually a video web producer. So thank you.
I'd also like to mention that those of us in Connecticut who have been lucky enough to have Bob Lesser in our medical community, just a huge thank you for all of your years
Wow.
of dedication and being available to us. I know that, you know, as a retina guy, I'll look at some of these things and say, oh, let's call Bob. Let's call him right now. So thank you for being there for us really all the time. And you've trained some wonderful people who we're going to depend on going forward, and they all will bring your spirit forward.
Thank you very much.
We have a question that says, once you're comfortable that it's non-organic loss, what do you say to the patients? Do you say explicitly that that the report does not confirm the given disability? Is there any benefit in confrontation? This person has mostly stuck with, well, I think the wiring is intact and I hope that the vision comes back soon. What would you say?
Yeah, no, it's actually, it's a difficult situation. What I don't say is that this is related to stress, because I used to sometimes say that, and I found out lawyers could use that and claim a disability even if there was nothing wrong. My usual response now is that I will say that I'm delighted to report to you that your visual system is working perfectly. It's much better than you thought. And gradually this is going to get better. And we'll follow you for a while and support you and be there for you. The patients who let's say there's some litigious involvement here, they know what that means right away. They realize that I'm not going to support them for their case. For the patient who has deeply rooted psychiatric disease, it's more complicated, and I'll usually try to be supportive of that patient and watch them for a while. It's extremely rare that for those patients I will send them for psychological counseling, but if necessary, sometimes I've done that also. But by far, most of them in my world seem to be related to some sort of, it's usually a car accident and some minor injury and claims of disability that are not appropriate. So they've gotten the message from me, I think, pretty quickly.
And this question is for either of you, but regarding the first talk on 6 nerve palsies, what about possible post-viral and post-vaccination 6 nerve palsy in children? Do you get an MRI at the onset?
John, you want to take that?
Yes, I do. I'm not sure that there's any way around that. You know, the position that you can take in deferring imaging is really with people in whom you can blame an ischemic cause, and that has to be the adult who could be, you know, who has a profile that suggests that if you have a young person, can imagine, and you know that this is true. You've got somebody in your office and whose parents are right there, and they're deeply concerned that this child now cannot look, you know, to one side cannot abduct. Well, you're going to be fumbling with an explanation. You're going to say, well, this could be, but then they'll look on the internet and they'll see that, gee, it could also be a tumor. This is not, it's not easy to wriggle out of that one. So I think those patients need to be scanned.
Yeah, and I would agree with that. I think it's more controversial. I mean, in some cases, the parents want to defer it because the child's too young to really be able to go through an MRI. Sometimes I've let them go for a little while, but I stress that if it's persistent, that we have to image the patient. I mean, the worst thing you could do is miss a brainstem glioma or something in a child, or any lesion, and and spend a few months following them. So in general, I agree that I will image them right away.
And we have another question. Are you familiar with, and would you comment on vision snow syndrome?
Yeah.
Bob, I want you to take this one first,
Okay.
because it falls more into the non-organic.
Okay. Well, it's often labeled as non-organic. It actually was first described by Steve Galetta and his group in, I think it was 1998, and it was called persistent visual phenomenon. And patients basically complain of seeing like looking through a snow globe all the time, and that it's there constantly, and there's nothing they can do to make it go away. And my bias is that I think it's a real disease because you hear this so frequently. It's thought that it used to be thought that maybe this is migraine, but it's probably not. There's some studies that would suggest that it's not migraine, or maybe a migraine variant. And I've seen it once after trauma and wonder if that was real or not. But otherwise, it appears spontaneously and is persistent. All I can do at best is reassure the patient that it's not going to be progressive. It's not going to be, there's no permanent neurologic damage from this, but it's not going to go away. And that's been my experience. I'll be interested to hear John's experience with this also.
Okay, the 155 people who are participating in this all know that this is a very difficult problem and that it's not uncommon. Not just neuro-ophthalmologists, everybody sees these patients. You know, the term visual snow, I think, is a little unfortunate because it has somatized this condition. I'm going to be I think, in a little bit of disagreement with, not very much with Bob on this one. I think that, yes, it's been very difficult to find a real home for this, to explain this. Let's just put it this way. There are a small fraction of these patients who have either outer retinal disorders like Azor or genetic dystrophies, who can have positive visual phenomena that are persistent, and those people deserve to be diagnosed. Then there are people who have occipital lobe disease that, for example, stroke, where it can go on for a long time with positive visual phenomena. And those are relatively easily diagnosed. The ones with occipital lobe disease are almost always going to have MRI abnormalities. And the people with outer retinal disorders, you can usually figure out in the ways that we know how to figure out outer retinal disease, with OCT and with ERGs and with ophthalmoscopy, and maybe fluorescein or ICG, something like that. The others, and I think that 98% of the patients are in that other category, where you just cannot figure out anything organic, and we don't have the means of doing this now. I tend to think of this as an overheated brain. These are people who simply are not disregarding. I mean, we talked about relevance of sensory phenomena. These are people who just simply cannot disregard what the rest of us don't find annoying. It's, you're screening out things that are not there. And how you label this and what you do about it is very complex. People are very annoyed if you start throwing psychologic things at them. But somehow you have to get there. And I agree that migraine has often been blamed. Yes, migraine, status migrainosis, can give you positive visual phenomena. I've had it myself, but it's typically brief and it occurs in episodes, and that's not what we're talking about here. The rest of it is really trying to figure out, why is this patient seeing things that nobody else, who doesn't have this condition, doesn't see. So I'm going to have to leave it to you. I find it very difficult. I usually try to explain to people that this is kind of an overheated, hypersensitive state. And many of these patients are also anxious. And I think that, they respond to anti-anxiety medication. And I kind of leave it at that.
Thank you. And I'm sorry to say we have lots of other questions, but we don't have time to address them right now. If I could have the speakers just go to the chat and go to the question and answer one, and maybe you could answer it on that format so
Sure.
that people can get their answers. Our next speaker is Gregory Ogawa, who shared his evening with us and gave an insightful talk on Thursday. Dr. Ogawa specializes in complex anterior segment, cornea, and cataract surgery at the Eye Associates of New Mexico. He's clinical professor at the University of New Mexico and is medical director of the New Mexico Lions Eye Bank. His talk today addresses something that we've all encountered, the iris defect, whether it was from trauma, surgery, congenital, or an inherited condition. Patients can be functionally impacted by the resultant photophobia or want an aesthetic modification to suit their preferences. Whatever the situation, we can all benefit from employing some of the pearls that Dr. Ogawa is about to share with us. I welcome our next speaker, Dr. Gregory Ogawa. Greg?
Okay, very good. Thank you very much. I'm trying to share. Should be able to see the tackling iris repair
Yes.
there. Excellent. Well, it's an interesting world with virtual talks and so forth. I was in New York City this morning working with residents on a macro, actually iris repair lab, and I'll be doing that again in a little bit. So it's rather interesting how all this plays out. So we don't have let me get the, okay, so I'm just going to get rolling here since we are a little bit behind time. So no financial interest and a bunch of things we do in ophthalmology are off label that we routinely do. So the types of iris defects, there's sphincter damage, which can be focal or diffuse, radial iris defects, which will almost always involve the pupil margin, though not always, and then further involve the stroma. Iridodialysis, which of course tear at the iris root, which can be small, large, singular, or multiple. And remember that the iris root is the thinnest part of the iris. So it is rather prone to injury, even though we often see iris sphincter injuries a little more often. And then stromal attenuation and atrophy from various causes can be focal or diffuse. Scarring of the iris, fibrosis, ectopic pupils, bunch of mechanisms for that. And then combinations of all of those. The analyzing the iris by inspection, there's when you have a diffuse iris sphincter damage, the pupil is usually large and have an unresponsive pupil. And you can test this in the office by putting shining light in the eye, of course, or as long as the optic nerve and retina function. And then I feel a little funny saying these sorts of things right after neuro-ophthalmology talks. So I'm generalizing here. In all due respect to what we've just heard. And then intraoperatively putting in miotic agent inside the eye can also help with that. Sectoral damage, I'll show you this in just a minute, but a spreading of the radial aspect of the iris. Even though we think of some of these circular elements of the iris is really oriented pretty radially when you kind of look at it in an impressionistic painting sort of idea. Tears, the general appearance of the iris, whether it looks fairly normal or scarred or attenuated, and if there's part of it incarcerated in a wound or a laceration that may need release. So here's a pupil, it's not perfectly round. It's a little bit egg-shaped, as that yellow line shows. Say, okay, so what's going on where on this? So I've drawn some dashed, excuse me, yellow lines over the iris with mirroring or matching the radiality of the iris fibers. And you can see that down below here, here's the V configuration that I was speaking of, and you can see it a bit here as well. That's because in this area, the iris sphincter is not functioning well. Over here, it's doing well, and same sort of thing over here. We've got the non-radiality. So between the green arrows and between the red arrows are areas where the iris sphincter is, let's say, underperforming. And so here it is again without any of the overlay, and then the overlay again. And so that's, you know, office reading. You can see there's a traumatic cataract there as well. And then intraoperatively, gentle probing of the iris and manipulation, checking for elasticity, and unfurling posteriorly rolled iris. So posteriorly rolled iris. You know, if you have this photomicrograph on the right shows the dilator muscles here in the back, sphincter muscle here near the pupil margin, but all of this muscle is in the back of the iris. You've got all this stroma in front. So when the sphincter gets damaged, you still have, if you have intact dilator muscles, they're contracting, the stroma is up above, and the sphincter, the pupil margin or the iridodialysis tear edge rolls posteriorly. And, you know, equivalent to cicatricial entropion sort of concept. And so you may need to unfurl the iris with an IOL manipulator or something like that to actually find the edge of the iris before you start passing sutures. Things that are useful intraoperatively, acetylcholine is quite helpful in most cases. I avoid having any epinephrine or phenyl in the infusion bottle because that can artificially make the pupil bigger. Keep the eye pressurized, either with OVD or infusion. Remove the vitreous from the area where you're working so you don't create vitreous traction and retinal tear, as trying to make the iris better. Tenopolypropylene on a long curved transchamber needle. That's really the, you know, that's the weapon of choice, essentially. That's what they use for almost everything on iris from a suturing standpoint. Suture retrieval instruments, intraocular forceps, scissors, and then iris stabilizer or manipulator type instruments. And there are several different types of sutures that can be done. So a simple interrupted, a bite in one spot, bite in another, tie a knot. Iris gathering with multiple iris bites, but still just one knot, is better for longer areas of sphincter attenuation and also for managing areas of symptomatic transillumination. Mattress sutures are the choice for iridodialysis, and cerclage for extensive diffuse sphincter damage. We just mentioned about how to look for that. So that's what it's for. I want to mention what it's not for is for patients who have some iris sphincter function left. Even if it's, you know, 2 or 3 clock hours, that's too much. You have to do multi-bite interrupteds or something. And I didn't know the importance of saying that until I saw a patient that from someone who had attended a course and did an iris cerclage when the patient needed 1 interrupted, and the result was actually quite poor with doing a cerclage. And I'll just go through this quickly, but there's essentially 3 categories of intraocular knots: tied and tightened externally, CSEP with multiple variants, tied externally, but then tightened internally with one intraocular instrument. A knot that I'll show you that that I published like 23 years ago or something, an Ahmed variant, and then using 2 forceps to tie the knot inside the eye, essentially functioning like the cornea isn't there. And I want to go back here on knot basics. So when we were in medical school, we learned, square knot, granny knot, and there's some people who speak around the world currently are using the word throw instead of the word wrap. So they're, this square knot has one throw that has, the first throw has 1 wrap, the second throw has 1 wrap. So for instance, a 2-1-1, this is the shorthand notation. First throw has 2 wraps, second throw has 1 wrap, third throw has 1 wrap. Okay, so this is a macro video of a knot that of this Ogawa intraocular knot. So pulling both of the sutures outside. And the reason I show this, and this is an easier one to teach for some folks, is that there's a 2 wrap throw. It's all outside the eye, just like you do if you're gonna, do a skin or cornea closure. So you pull that throw up to the outside of the paracentesis, and then the 2 arms, you hold 1 loop a little longer, but hold both of them in 1 forcep, and then use an IOL manipulator of some sort as a pulley, essentially, to tighten the knot. So it's going to the far side of the knot, and so she can tighten it, lay it down flat. And here's the second throw is a single wrap throw, doing the same thing, pulling it up to the throw to the outside of the paracentesis. And this time the yellow is going to go in. To get the knot to lay down and look nice like this with an actual square knot, you need to alternate. But with a 2-1-1, even if you've done it as a granny knot, it's still gonna hold for iris. It'll be good enough for iris. And we're wrapping with the red here, but in what I do surgically is just keep 1 arm longer, and that's the arm that I wrap with, and then alternately taking the shorter, the longer arm into the eye to get the square knot. So that's the last. I'm going to move on here to the next. So in April of this year, this committee published this particular paper, and I did the kind of video that you just saw for the knot that I just showed you, but also about a half dozen others. So if you're interested in seeing how you actually tie all these different intraocular knots, there are macro videos there. It's also just a nice article in general. But so this is a simple interrupted. So needle going through the iris on one side, through the iris on the other side, and then pulling both arms out through a single paracentesis, and then taking off the suture. So here's the other arm, and then we're going to do what I just showed you on the macro level, but now it's microscopic level. 2 wrap throw, pull it to the outside of the paracentesis, put the 2 arms together in 1 forcep, angled IOL manipulator here to catch the other suture, take it across, and there's the first throw. And in the interest of time, I'm going to skip ahead here, and trim. So there's with more throws in pupil, a nice pupil from what was a larger defect. This is a multi-bite suture. So passing through the iris using a iris reconstruction hook to support things. You can see we've got multiple bites there, but we're still going to do one knot, and you'll see how it takes that. So I'm pulling it out through paracentesis here on the left, cutting off the needle, and then using 2 forceps inside the eye. So that was 2 wrap throw, and grab the other end. And you often have to do this, kind of use the 1 forceps to slide off the other, slide the suture off the other, tighten it up, and then 2 more through. And you can see how much that shortened the pupil margin in that area and got us to a decent pupil size. So I'm not going to show the other 2 throws here and the suture trimming, but that's the intraocular with 2 instruments. This is a patient who had injury several years ago, multiple years, 13 or something, iris with a fishing weight. So zonules toasted here, vitreous in the front of the eye, and the iris with that appearance, large, and that's probably a 5 clock hour iridodialysis. And so some vitrectomy, cleaning, removing vitreous. This is, and actually I'm going to skip ahead here. So this was, now we've got the, we've done with the IOL part. And so this iris has been so relaxed for so long that I need to stretch it out a little bit. So going through paracentesis, through the pupil, and then from behind, it's easier to catch the very edge of the iris margin because of the, because it rolls posteriorly. And so this one, it can close really with just 3 sutures. I typically do a 2 wrap throw and then a half bow until I get all of them in place and then can adjust them. But I guess I was feeling confident on this and permanently tied each of them. It's important here to bury the knot inside the eye. Under the conj will, in multiple patients, eventually erode through. So here's a second mattress. And what I do is watch the pupil more than, getting the iris to the sclera. The iris is often left back in a hangback sort of situation. And then I'll just fast forward a little here. So there's our end result, pretty different than what we started with. So this is actually kind of fun here. So this is the diathermy that retina docs use. And this is a disposable one, so I was able to put a bend in it. And in low settings, we use it to shrink the iris tissue. So that pupil, I'd already sewn right here, sutured up a big defect. Pupil was not well centered. And the closer to the pupil, the more you change the shape of the pupil. Farther from the pupil, the more you move it. And so this is still not perfectly centered, but it's a lot better than it was. There's the before diathermy picture, and you can see how much we moved the pupil over. So in special situations, central iris atrophy, don't try to sew these. It'll be one of your worst days in the OR. It's extremely friable. You can, sometimes there's a band through the middle of the pupil that you can cut with a vitrector and remove. The artificial iris has actually become a key help for these. And then congenital iris coloboma, which I'm gonna show you about here. So this is a schematic that I made on my computer of a normal iris, blue being dilator muscles, red being the sphincter. And then this is what iris coloboma is. Remember, embryologically it does not finish forming. So there's sphincter muscle all along the sides. And so the key in doing this, the number one key, is removing the sphincter from the sides of the coloboma. And when you're doing cataract surgery, the pupil's nicely dilated. You say, oh, this coloboma is not that bad. And some of them aren't, but you would know that ahead of time. Don't change plans during surgery. And essentially with the coloboma, if you don't repair it, you're going to have IOL edge in the pupil space, glare. It's just optically a bad result. And if you just do simple interrupters, you make the pupil too small. So the way that you work on this is use the vitrector in sort of iris removal mode with slow cut rate, low flow, low vacuum, go slowly and watch for tension release. Then putting the edge of the pupil together and close the rest of it. So this is a patient who someone had done cataract surgery, completely ignored that they had an iris, or chose to ignore, let's say. They had an iris coloboma and what they call a lens coloboma because the zonules are missing in that area, which creates the decentered bag. In a lot of cases that are kind of more involved with manipulations, oral subbrital sutures can be really helpful. There's vitrectomy to remove the vitreous is prolapsing, and there's the acetylcholine, the miotic agent. And I like the acetylcholine because it gives a more realistic pupil shrinkage. Here's using the vitrector to shave off sphincter muscle. And all sorts of IOL gymnastics could also have been done to move this more centrally, but we were doing this because this patient had terrible vision, aphakic, IOL edge, etc. And I was able to, so here's the first pass. These are simple interrupteds, one bite on each side. And so that's the pupil margin to pupil margin, and bringing those out. And let me see here, the tying will be the same as we've already seen. And here's the first two have throw being tightened up, and you can see how the pupil is coming together there, then closing up the rest of it, and patient has a result like that, which, IOL still decentered, but works great. Now that June JCRS journal that's sitting on your desk, it actually has this technique, and it's got video of doing this in conjunction with cataract surgery, as opposed to after the fact, and also some professional medical illustrations, in case you're interested in this more. I'm going to show you just very short. I'm trying to catch up time-wise for us a little bit here. So this is a good case for iris cerclage. And this is actually one of the more difficult things that I do. It's dramatic and wonderful, but it depends on the case. The bigger the pupil, the more challenging, the more paracenteses need to make. But basically, it's going in through a paracentesis, weaving through the iris, so multi-bite, and the closer together the bites are, the better the resultant pupil is. And then here's using a 24 gauge cannula to come out through the paracentesis. I've rotated the eye. So now we're going back in through the paracentesis. Most important thing is to not catch corneal tissue going in or out. Otherwise you wind up sewing the pupil margin to the paracentesis to the cornea. So again, in time interest, I'm going to skip ahead here. And so here's using that same intraocular knot. I target 4 millimeters. And for some patients, this is literally a life-changing sort of thing, especially here in New Mexico, where we have incredible sun intensity. Going from a 10 mm pupil to 4 is a multi-fold change in decreasing light. I'm going to end with iris prostheses. There's the medical iris prostheses, human optics, custom flex. It was FDA approved in 2018. It's still a challenge with insurance companies. It's getting better, but it's still a challenge. No other devices are available in the US, and all those other devices that used to be compassionate use, because there's an FDA approved option, you can't get approval for those. And then there's the cosmetic. These are horrible. These are blinding, UGG syndrome, wipe out the eye from glaucoma, and you really need to emphatically discourage patients or encourage them to have them removed. And this is a medical human optics. Is a case from Sam Maskett. So this was the right eye, left eye in the middle, dense cataract, and on our far right is the post-op on the left eye, which has the custom-made artificial iris in the capsular bag. You can see, and if you can't put it in the capsular bag, there's other ways to attach it, but it goes behind. This is a stump of the iris from over here. It goes behind the iris. In comparison, these cosmetic go in the anterior chamber, and they go to the angles, iris necrosis, and literally blinding. So if you see one of these, that's a call 911. You're going to take it out yourself or get phone a friend kind of thing. All right, I'm going to stop sharing my screen. Let me just see if there are questions here that.
There's a question in the chat, and it's during your iris repair, is each bite and tie using a new separate double-ended needle?
Let's see, for which
I think in the first repairs that you were describing.
No, those are all, so in the interrupted knots, those are cutting the 4-inch. So that's a CPC 6L 10-proline 4-inch long suture, cutting it in half. You just need 2 inches for those. The only thing that I leave double armed is in the iris cerclage. Because I start on one side and sometimes the needle will get dulled, or you get in a place where it's just ergonomically hard to do, and then you can go back to the other needle and go the other way around.
Thank you very much, Dr. Ogawa. Really enjoyed your talk Thursday night and today. Appreciate your time.
Very good. Thank you.
We'll continue with the CME portion of our program. Next, we're going to hear from Dr. Warren Hill, the medical director of East Valley Ophthalmology in Mesa, Arizona, and an internationally recognized expert in cataract and refractive surgery. Today, Dr. Hill is going to show us why we should no longer accept a post-cataract surgery outcome of 80% predictive goal when using current power formulas. Dr. Hill has developed several AI models that are free from calculation bias and now make a 90% predictive goal possible. He'll be giving 2 sequential talks, the first concerning AI and power calculations, and the second talk applying to toric lenses. Welcome, Dr. Hill, and thank you for spending time with us today.
Well, okay, thank you very much. It's a great pleasure to be here with all of you. Let me get my screen set up here. Are we, okay, there we go. All right, does that look okay to you?
It does.
Good. Okay, good. Okay, so what we're going to talk about this morning are 2 topics. The first is artificial intelligence for lens power selection. This is pretty much the next place we need to go as far as accuracy. We're kind of running out of steam with traditional Gaussian methods. And I'm going to show you from beginning to end how this project was put together and where it's going in the future. And I think you'll agree that there are some very exciting developments, some of which are actually within the last few weeks. And by way of disclosure, let's take a look here. Okay, these are my industry relationships. And of course, I'm the author of the Hill RBF calculation method. All right, so for any plan for cataract surgery, how can we be the most effective? Well, we're the most effective by avoiding complications. I think we all would agree with that. And when we think about anterior segment complications, we all have this list in our head, and we go into the operating room and of course hope that none of this occurs. But actually, an unanticipated refractive outcome is the most common complication, if you think about it in those terms. And we're actually being judged by our patients and our peers by our refractive outcomes. So this is a place where we really need to put our effort and our time. So said another way, when we go into the operating room and we think about refractive outcomes, the elephant in the room is really IOL power selection, and every single one of us is aware of that. So let's start with some accuracy standards, and should what's most common be good enough? And we can look at a number of well-known studies. There's Gale's National Health Service study, there's the HAN study in ophthalmology, the Swedish registry study in the Journal of Cataract Refractive Surgery, the Kaiser study in ophthalmology, and of course the Haggis formula optimization database, which is now up to about 300,000 cases. And for those of you who track your outcomes, this the 78% number should seem very familiar, because this is what we see over and over and over again. And as I've reviewed thousands of physicians' databases, this is what I see. So this is the gap that we're looking to close with current technology. And this is what 78% accuracy looks like, with the black dots indicating where we don't want to be. And if we're putting in torics or multifocals or extended depth of field lenses, I think we can do a lot better than this. So let's talk about what most of us are using right now, and then where we're going to be in the future. And most calculation methods that we use are based on the effective lens position. And this is where that comes from. This is from Carl Friedrich Gauss, the first half of the 19th century. And you may remember from your physics class, object vergence plus lens vergence equals image vergence. And fast forward to right now, and this is our modern backbone for lens power calculations. And it's really just a Gaussian formula, except we've added an AM/FM radio and some mag wheels, but pretty much we're still back in the first half of the 19th century. Now, the part that's interesting is that, remember, the power of a lens inside the eye is relative and not absolute. So if you have a 21 diopter lens and you bring it 0.5 millimeters closer to the cornea, it's now a 22 diopter lens. If you take it 0.5 millimeters posterior to its optimal position, it's now a 20 diopter lens. So basically, in a two lens system, the second lens, in our case, the intraocular lens, has a relative power. Now, what the formula does is it estimates the effective lens position, and the effective lens position can only be estimated. It cannot be calculated. And that's one of the problems that we have with theoretical formulas. And that's about 30% of the calculation accuracy. So we've got a problem, and we're going to try and fix it. So here's a couple of examples to show the impetus behind looking to do something different. Here's a database of 3,445 cases. We're going to run it through SRKT, and these are the cases outside the half diopter accuracy. We'll take that same database and fit it to an artificial intelligence model, and my goodness. Okay, so right out of the chute, we know that we can do a lot better than a backbone from the first half of the 19th century. So what we need to do is we need to think different. And we've come up with a method that uses pattern recognition by artificial intelligence. Now, remember, artificial intelligence isn't one thing. It's many different approaches. And I'll share with you how we got to where we are right now. But pattern recognition is a very powerful tool. And it's more than just kind of recognizing grandma's face. There's a lot to this, and there are a lot of methods that can be used. So think about when you got your iPhone for the very first time. The instructions from Apple said, lift and rest the edge of your finger on the home button repeatedly. And you got these little interesting kind of cartoons showing, your fingerprint. And you did this multiple times until the device was able to come up with the things that made your fingerprint unique and individual. They assign symmetrics. And then from now on, when you want to access your American Express card or do a password entry, that's you in a unique and individual way. So let's look at some other ways of pattern recognition. And this is going to demonstrate the power of what we're doing in some pretty stunning ways. So let's take a look at this little box right here. It's got 1,000 seemingly random points to it. These points aren't actually random. They've been placed inside this box using something called a Manhattan distance generator. And the Manhattan distance is the distance between 2 points, as though you were driving through the city of Manhattan and you have city blocks. Now, of course, we can't go through buildings, so we have to go around buildings. And in mathematics, this is also known as the taxi cab distance. So if we want to go from point A to point B, if we want to go from here to here, we have to kind of go in this stepwise pattern. That's a Manhattan distance, as opposed to a Euclidean distance, as the bumblebee or as the crow flies, that would be a straight line. So these points represent Manhattan distances. So what we're going to do is we're going to take some basic artificial intelligence modeling. We're going to give the algorithm 5,000 chances. And with today's scary fast computers, that's a very short period of time. And we're going to give it that many chances to find the internal organization of this seemingly chaotic collection of dots. So here's 40 cycles, 120 cycles, 500 cycles. By 5,000 cycles, the artificial intelligence model has figured this out. And it's figured it out pretty nicely. And this is just child's play as far as artificial intelligence goes. So based on the distribution and the spacing of the inputs, it can find the internal pattern. Now, this is a completely different way of thinking for lens power calculations, because when we think about axial length, central corneal power, anterior chamber depth, lens thickness, zodiac sign, mother's maiden name, whatever metrics we want to use, it's a pattern. And the wonderful thing about patterns is that there's really no bias. So we can come up with a new way of looking at lens power that doesn't have the traditional biases that we have with Gaussian methods. So again, why not IOL power? Well, let's explore that and see how that works. So the advantage here is it starts out with adaptive learning, which means we get sophisticated pattern recognition based solely on data. So it's software that writes itself. Isn't that interesting? And manual optimization methods, of course, limit possibilities to situations that we already understand. We can only think about things we already know. This goes way beyond that. And it's well suited to real world problems where ideal models are not available. So if you take the normal parameters you might measure with the Almaster 700 or the LensStar, and you go in quarter diopter steps from plano to -2, that's about 680 million combinations. Well, there's no theoretical formula that's going to be able to keep track of that. No matter how sophisticated your regression methods are, they're going to have to go through the middle of clouds of data and not be able to keep track of everything. We're working in 6 dimensions here. It's a completely different story. It's also self-organizing, so it can create novel representations of the data, things that we've never thought about before. And it has really enhanced sensitivity for identifying and unraveling nonlinear relationships. Let's say there's a relationship between the white to white and the Ks that we never knew about, and that becomes a new variable. We can find this out. And it's free of calculation bias, as I mentioned. So let's look at what it took to develop this calculator. So the first thing is, what measurement should we use? As I mentioned, should it be the mother's maiden name, favorite dessert, shoe size? We were open to all possibilities. And we started out with 13 different parameters, including some very non-standard things like pupil size, 6mm spherical aberration, age, gender, a lot of other things like that. And this is the basic technique that we used. We use a genetic algorithm, which is an evolutionary iterative factor selection process, and it copies Darwin's evolutionary model. So we started out with these collections and we went all the way out to 13 items. And basically we began with a simple model. And then we start making random iterations and creating new models. And again, with these scary fast computers that we have, we can do this very fast in a very sophisticated way. So the best performing candidate models are identified, retained, and ranked, and then we do it again, and we do it again, and we do it again. And we can keep going with this until we can't get any better. And so we reproduce the process over and over and over again until things get better. And what we're doing is we're identifying what factors have the best chance of giving us the information we're looking for. Three things came up. One was, how accurate is it for the numbers that we're looking at? And you can almost fit an artificial intelligence model to a bologna sandwich if you have the right metrics. In this case, this was probably about 700 or 800 cases, and we fit it to about a 97.8% accuracy. But we also held out 20% of cases, and we went back and then checked the accuracy for cases that were naive to the development process. And that had to be at a 90% level or better. So those were our criteria. So this second item here with the post-op spherical equivalent, the axial length, central corneal power, and anterior chamber depth for a given eye well implanted came out with exactly what we were looking for. So that's what we went for. And also we developed something called a boundary model, and we wanted to have a low number of out-of-bound points. And I'll explain to you how that works in just a minute. Okay, so we have our basic factors that we're going to measure, and we can apply some simple neural network technology, and we can create something called an optimized surface response model. And you can see this isn't very good. You know, it's just using a basic neural network, we're not getting the kind of accuracy we would want, because it's kind of lumpy, bumpy, and it should be a smooth sheet at about a 45-degree angle. So we looked for some other ways in which we could do this within the artificial intelligence modeling process, and we could use polynomial models, basic neural networks, Gaussian process method, which actually works pretty nicely, something called Kriging, stochastic process methods, kind of a random sort of thing, and memorization. We can keep track of all kinds of stuff, so let's memorize things. And we ended up with the radial basis functions, and that's where RBF comes from. It's a radial basis function, activation function for the artificial intelligence model, and I'll show you how that works in just a minute. So this is what we found when we applied a radial basis function activation model for our artificial intelligence algorithm, and bingo, we were able to hit it pretty good. So next we need to fit real world big data to an artificial intelligence model. We're starting out with about 980 cases. That's not enough. We need numbers in the tens of thousands. And so how do you get that? Well, first thing we did was we reached out to some of the really most accomplished and accurate cataract surgeons in the world. And we now have study centers in North America, in South America, in Europe, the Middle East, Africa, India, Asia, and Australia. And again, these are some of the most accomplished surgeons in the world. We have a former ASCRS president, former editor of the Journal of Cataract Refractive Surgery, people who just have a gift for coming up with really accurate outcomes. And these are the people that have been working with us. We now have 44 participants in a total of 20 countries. Nobody's paid for any of this. This is all volunteer work. And that's really one of the beauties of this project, is that it's a worldwide collaborative effort. Everybody's pulling in the same direction. Everybody wants the same thing. And what we're getting is everybody's best effort. And this is really one of the highlights of my career. This is the best thing I've ever done, is working with all of these people who freely give, many, many hours of their time to move this project forward. So this is a listing of who we have right now. And many of these names will probably be familiar to you if you read the different journals. And we're very, very grateful for their work. It's been an absolute honor to work with these people. So, okay, so here's the nuts and bolts of how we do it. We have our factors now for a given eye well power. We're looking at axial length, central corneal power, anterior chamber depth, and the desired postoperative spherical equivalent. We use the radial basis activation function in our hidden layer of the neural network process. We get our power. And then we have a backward propagation method by which we adjust a series of things called weights until the accuracy doesn't get any better. So again, this is software that writes itself. We just keep doing this. So here's the very first effort, about 980 cases, took a cloud of data and turned it into a straight line. That was a lot of fun. And we look at outcomes. These are the cases outside a half diopter accuracy. And what you can see is really there's no bias. We'll have more cases outside if the numbers are larger in that area, but it's free of calculation and bias. That's really nice. Now, we worked with the engineers and mathematicians at MathWorks. And one of the engineers said, well, where's your boundary model? Well, in engineering, this is a very common concept. In ophthalmology, we don't know anything about it. And if you want to solve a problem in artificial intelligence or mathematics, optics, physics, you don't ask ophthalmologists, you ask physicists and mathematicians. And so here's how a boundary model works. And this is the first time this has ever been done in ophthalmology. So this is what's called a pairwise boundary model. We have central corneal power against axial length. And what we've done is we sampled the accuracy edge of this database. So all of these little black dots within the boundary model, if we have 5 other boundary models where our data points are within it, we can predict a 90% accuracy for the outcome. So this is the first calculation method that tells you prior to surgery how you're going to do. I can't tell you how powerful this is. So Mrs. Jones comes in and she's got weird Ks, funny anterior chamber depth, really short eye. We're outside our boundary models. The first thing we do is we strike up a conversation with Mrs. Jones and we say, Mrs. Jones, God gave you an unusual eye. We can't accept, or we can't anticipate we're going to have the kind of outcome we would like. Well, if you tell people beforehand, it's not your fault. If they find out afterwards, you own it. So these are the out of bounds data points for this particular pairwise boundary model. And if we have out of bounds data points, it flags the user. So on the lens star, you're going to get an out of bounds calculation symbol, that little yellow triangle, and also for the online calculator. You have to be within the boundary model for all 6 pairwise boundary models in order to have an inbounds calculation. In other words, we have sufficient data to do the calculation with the level of accuracy that we want. Right now, that's 90% given current technology. So again, this point right here would not invalidate the calculation, but what it would do is tell you, at this time with the data we have and the artificial intelligence model that we're using, we can't predict a 90% accuracy. So version 1, we decided to do a prospective evaluation, and we had 459 sequential cases at 3 different study centers, Steve Scoper in Virginia, and Mike Snyder, who works with Bobby Osher in Cincinnati in my practice. Wide range of lens powers, axial length, central corneal power, etc. And here's what we came up with. Guess what? For all eyes, it was about 90%. Well, gee, that makes sense because that's the boundary model. For normal eyes, it was a little bit better. I like that. Axial myopia, we blew the top right off of it. And that probably has to do with the fact that these are low-powered lenses, and the effective lens position probably doesn't make much difference. Now, what was really encouraging was for the axial hyperope, because now we're at 84%. And those of you who do a lot of cataract surgery know that the axial hyperope is probably one of our biggest challenges. We often get those annoying, myopic surprises. So other people started using it. This is Roman's group. I've never met these people. They presented this at ASCRS. Guess what they got? 92%. That's the boundary model. So here's version 1, and I'm going to show you how things have progressed as we continue to work with this. There's an eye with axial myope, normal Ks, normal anterior chamber depth. Everything's within the boundary model. It's an inbounds calculation. So let's do things a little differently, a little bit longer eye. And now we have unusual Ks and unusual anterior chamber depth. Outside the boundary model, it's an out of bounds calculation. So let's now, with version 2, we're going to increase the number of cases. We're going to go up to about 12,000 cases. And what we've done is we've increased the size of the boundary model. So we've increased the breadth and depth of the boundary model. And now that out of bounds case is inbounds, out of bounds case is inbounds, it's an inbounds calculation. And this is just from the European Journal of Ophthalmology, showing that version 2 is doing better than calculation methods. We're now in version 3, and now we have an expanded and further refined boundary model. It's all about the data, of course. And this was released last December. And let's take a really unusual eye, 32 millimeter axial length, incredibly flat Ks, very deep anterior chamber, you can see we're within the boundary model on all of these data points. And so it's an inbounds calculation. We also flattened the power prediction curve. So you can see where, say, RBF version 2 and Barrett diverge as we get, very short and very long eyes. That's the majority of cases, but you can see we flattened the accuracy across a wide range of axial lengths. So this is the calculator. This is the online calculator, and basically you can read about what this is. It explains some of the basis about it, and if you want to go into all the scary math, we'll provide that as well. Here's the calculator itself, and basically through an enormous act of generosity, Hogstrite, who sponsored this, has also made this calculator optimized for other biometers. Now, how many companies do you know that would actually do this? So you can choose all these different biometers like the Tomei OA 2000 or the IOMaster 500 or 700, the Movu Argos. And I think that's a very nice thing to see. So basically you put in some information about your patient, the pre-op measurements, the lens, and then you're going to get a calculation including inbounds and out-of-bounds indications. And in this case, near about -1/4, it's inbounds, but for more hyperopic outcomes, it's out of bounds. We just didn't have the data for that. Now, what you may see is for two different calculations where the lens power is the same, you may get inbounds and out of bounds calculations. And of course, it just means that the data points were outside the boundary model for that particular eye, for that particular patient. So again, it's a heads up that it may be a problem. We've optimized lens constants for pretty much every lens used in North America, Europe, and Australia. So you can go to a part of the calculator for that. And in summary, this is basically where we stood with version 2. This is version 3. So we're now down to -5, axial hyperopes up to 34. And we've added central corneal thickness, horizontal corneal diameter, lens thickness, and gender, believe it or not. If you have a large enough database, you can actually pick this up. So these are the additional measurements. And of course, we've refined the boundary model. So to show you the difference between version 3 and version 2, here's a short eye, and version 2, every single prediction is out of bounds. Version 3, every prediction is inbounds. Same for a very, very long eye. The majority of predictions are out of bounds. Every single prediction is inbounds. And typical with what we do at Hogstrite, have you ever seen anything from Hogstrite that wasn't perfect and didn't last forever? Well, the same thinking goes to lens calculations. And we did a little less than 10,000 cases from our different study sites. And these are cases that were naive to the development of the calculation method. We're at 91.2% for version 3, 89 for version 2. So we're getting sequential improvements. And of course, once you get to 90%, I mean, every percentage point after that is just like, you just have to scratch, to get even another 0.5%. I mean, it's really difficult. And this is a limitation of technology. Now, this is an article that's in press right now in the Journal of Cataract Refractive Surgery, and it will be published next month or the month after. And it shows that the version 3 of the RBF method, this is from an independent group in Israel, has the lowest standard deviation now of any method currently available, which is nice to see. And then this is the half diopter accuracy. For this particular study, we can see we're actually at 95%. The EVO method from Singapore is about 91, and Barrett's about 92. Barrett's a wonderful calculation method, and then Kane is about 91. So let's talk about the future, a little bit about lens calculations, because that's what I'm always interested in. How can we do this better? And hopefully there's somebody listening right now, in the audience for this webinar that's going to take what we do and you're going to do it better than we did. And that's the whole idea here, is to give everybody a heads up that there's things other than Gaussian formulas. Artificial intelligence is one method. Maybe there'll be another method that somebody will come up with. Right now we have ray tracing, like the Olsen method, which is a hybrid and includes ray tracing. Artificial intelligence, advanced versions formulas like the Barrett method, and actually it's not a formula, it's a calculation method. According to Graham Barrett, it's about 3,000 lines of code. So it's a very, very sophisticated model. And of course, intraoperative aberrometry. And as far as I can predict the future, the method with really the greatest sensitivity and flexibility will give the best accuracy as technology advances. And where we need to go right now is for the central corneal power. That's the biggest wild card that we have. And for those of us who develop lens power calculations, if we could get better Ks, that would be fantastic. Very strongly committed to research in this area. And again, we have a very large collection of participants who share this commitment. So right now, 78 is plausible. That's what the majority of ophthalmologists have. 84% is acceptable if you really fine tune your measurements and use modern formulas. 92% is achievable. We're at 94 in our practice right now. Two of us in our practice are actually a little bit above 92%. So, we're making a lot of headway. And again, this is how you're judged as a cataract surgeon. So, we really are excited about some of these advances. So quick review. This is what 78% looks like. I think we can do better. This is 90%, which is the boundary model for the RBF method. And then this is where we're hoping to be. Remember when we went from A-scan ultrasonography to optical biometry? Suddenly you just didn't worry about things anymore in terms of the axial length. The goal of this project and perhaps other projects that come along in the future will be that we just don't have to worry about the spherical power, the spherical equivalent anymore. And we can really spend a lot of our time focusing on more important things and maybe take things up to another level. And the way to do that is to get better measurements. And so we need industry to give us a way to have really good Ks, to give us a way to be completely certain about every other measurement. And then those of us that work in these calculation methods can do a little bit better job. And that elephant in the room will eventually drop away. And basically, we'll have time to explore other things and maybe have happier patients. So thank you very much for your attention. I think this is a very exciting area for all of us. And I hope you share my enthusiasm with what the future may hold. Thank you. Okay, so are we off now?
You are still live.
Okay.
And we have some questions here. Do you feel it's time to demand the manufacturers of IOLs in quarter diopter increments?
Yeah, that's really an excellent question. That we didn't have quarter diopter IOLs because we didn't have the measurement or the calculation technology to make it better. A really quick answer, remember, lens power calculation accuracy is a multi-part process. And the paradox of a multi-part process is if you take one part and make it perfect, it doesn't really change the outcome. But if you take one part and make it not very good, the outcome is bad. So it's the old square root of the sum of the squares. So now that we have really good calculation methods and soon we're going to have even better measurement processes, I think it's time for industry to put the power of the lens on the box. That's what I think.
And another question, how much of our accuracy is a function of the quality of the implants that we use?
Well, remember, the large companies do a really good job, like the Restore is to within 1/10 of a diopter. I know the ANSI standards don't look very good, but the companies that make lenses, I mean, the big companies, they do a fantastic job. So the quality of the lens implant is not an issue. They're in half diopter steps, but the accuracy is in half a diopter. The step is in half a diopter. The problem we have right now is the Ks. And if I could make an impassioned plea to everybody listening, what you want to do is optimize the ocular surface before you do biometry. Warm compresses twice a day for 2 weeks, followed by lid scrubs and high quality tears. And suddenly those variations in the Ks go away and your accuracy goes up. So the single best thing you could do right now would be to optimize the ocular surface before you do biometry. I think that would help quite a bit.
Another question, can the Hill RBF formula be added to IOL Master 500 or 700 software? And if so, how?
Nope, right. Well, this is me. And I've decided not to give it to Zeiss quite yet because Zeiss wasn't involved in the development of this. Hogstrite, in unwavering fashion, supported all the work we did in terms of hiring consultants and developing artificial intelligence models. And for the time being, I'm just going to work with Hawkstrike because they've just been a marvelous company to work for. And we're just going to have it on that machine. But we have made it available to the ophthalmic community for free, just not part of their software. So that's a good question.
And I have a question texted in. It says, where is the United States in the race with this technology? Are there more advances going on in Europe and Asia?
No, it turns out the mathematics community is kind of a big network. We all talk to each other. So it's pretty much the same everywhere. I mean, there's published papers, and I don't think there's really a race. In mathematics, people share things openly. And there are companies that transcend political borders, and people tend to work together, at least in this field.
And one last question is IOLM 700 with TK and RBF 3.0 the most accurate?
TK doesn't really make a difference. That's what I found. In fact, that's what that article shows that I just put up. So either in the next month or the month after, in the Journal of Cataract Refractive Surgery, it'll show that it doesn't really make a big difference. The measurement of the posterior cornea right now is not really ready for prime time. It might make things a tiny bit better, or it might not make things any different at all, but it's not a big difference.
Okay, great. Would you like to go on to your second talk about toric IOLs?
Yeah, I need to get my screen back. Okay, let's do that here. Okay, so let me do that. Okay, can you see my screen now? Do you have my screen?
I have your name up. I need your
Okay.
screen.
Okay, how about now?
There we go. You're on the screen now.
Okay, good. Okay, this is another topic near and dear to my heart. I was part of the Alcon team that developed the toric IOL. I actually authored the first toric calculator. So this is our favorite lens in our practice, and we're gonna go through how to get it right every single time. And I'll share with you some of the insights that go back to the actual very first cases done with the Alcon toric IOL, and kind of have moved forward through a number of different platforms. And I have no financial interest in any of the items presented here. Now, it's no secret that anybody that makes an IOL, especially their flagship platform, is going to have a toric IOL. And this is almost 6,000 cases from our practice. And what you see is the ones on the left are the ones that walk through the door, and the ones on the right are the ones that you remember. But a little bit more than 50% of cases have more than 3/4 of a diopter of astigmatism.
Excuse me, Warren,
sorry.
you need to
Yes.
share your screen with the PowerPoint. We're seeing you personally, but not the your PowerPoint.
Okay. How do we do that?
You have to go down to share screen
Okay,
in the green.
share screen.
Yep.
Okay, and is that it now?
Not yet. If you're using more, here we go.
There you go.
Now you got
Okay,
it.
we okay now?
Yep.
Okay, here we go. Okay, so basically, this is a kind of asymmetric curve. Cases on the left are the ones that actually walk through the door. Cases on the right are the ones we remember. To get started with premium lenses, the toric is really a fantastic, first introduction. And the public health question is, should this be an option or standard of care? And in Australia, a toric IOL is provided by the government. It's like, when we make a glasses prescription, you wouldn't think about just putting in the spherical equivalent. You also would do the prescription. Against the rule of astigmatism, half a diopter or more is a candidate for the toric IOL. With the rule of astigmatism, it's 1 diopter or more. And 43% of ophthalmologists say that 100% of their patients would get the toric IOL if cost was not a factor. So let's talk about the preoperative evaluation. There's a tremendous amount of misinformation and kind of confusion here. And we're going to walk through a way to get it right every single time. I think that's worth the price of admission here. So what do you need to know? And you might say, well, I've got the MOVU, I've got the EyeMaster 700, I got a LensStar, they give me great Ks, that's all I need. And that may be the case, but let's take a look at this. This is from the EyeMaster version just before the EyeMaster 500. And the diagnostic criteria is 3 measurements within a quarter diopter in each of the principal meridians. So there's our steep meridian, there's our flat meridian, there's our power difference, and we got 3 measurements just like it. So you think, okay, we're good to go. Well, let's take a look at the topography. And this is somebody that's had prior hyperopic LASIK. And what they have is a steep zone. They don't have identifiable steep and flat meridians. So it's easy to get fooled just by the Ks. So, what's your plan? Well, think about that old proverb about the 6 blind men who were asked by the king to touch the parts of the elephant and tell the king what the elephant's like. And some said it was like a rope, like a tree branch, like a fan, like a pipe. And, the king said, you know what, you're all correct. The elephant has all of these features, but each one of you is kind of touching, different parts. So fast forward to a big program, and 6 new cornea fellows are asked by the department chairman to calculate the power and orientation of a toric IOL. And each asserted that the cornea is something different using SIM Ks, auto Ks, shine flow Ks, OCT Ks, slit scanning Ks, manual Ks, ray tracing Ks. And the department chairman very wisely says, you know what, every one of you is correct. The cornea has all these features you described, but not all of these instruments are equally useful for the toric IOL. So this is fundamental point 1, is you got to use the right instrument. Remember, a Scheimpflug value and auto Ks and slit scanning Ks, ray tracing Ks, they may use different algorithms, measure different areas. You're going to get different numbers. So they're not all interchangeable. Okay, so what are the most basic measurements required for a toric calculation? Well, number 1, we need to determine the orientation of the steep and the flat meridians. And we need to do this in a way that's correct, not just with button pushing, not just looking at the set of Ks. And then we need to accurately measure the power difference between these 2 meridians. And that's our anterior corneal power. Now, there are some options for directly measuring the posterior cornea. I'm here to tell you this really isn't ready for prime time yet. We have numbers, but they're not really all that accurate. And mathematical models that are used for this are much better with current technology. So ASCRS did a survey in 2019, and they asked people, what drives your toric IOL calculation assessment? And they used topography and the auto Ks of a biometer. So is there a way to accurately use these 2 things for our toric IOL? So let's develop a method that we can use, what we got in the office to get it right every single time. So let's go through some basic steps. So let's start with a topographic axial curvature map. Everybody's got a topographer, everybody's got this. And we're going to look at the central 4 millimeters. What's going on in the periphery really doesn't matter to us for the toric IOL. Step 2, is the power distribution suitable for a toric IOL? And ideally it should be regular, which means we can draw a line through the corneal vertex in the center of each of the astigmatic lobes. And is it symmetrical, which means we have similar power on either side of the corneal vertex. Now, irregular and asymmetric astigmatism is a completely different discussion, and we approach this differently. So first, what's this orientation of the steep meridian? Again, we're looking at the central 4 millimeters. We're going to draw a line through the corneal vertex and the center of the 2 astigmatic lobes. And we note which meridian is intersected in the periphery. We now have 3 very important pieces of information. Is the astigmatism regular? Is it symmetrical? And what's the steep meridian? We got this just from a topographic axial curvature map. We haven't even fired up the biometer yet, and this is correct. If we draw that line through the center of the 2 astigmatic lobes and the corneal vertex, where it intersects the axis scale in the periphery can only be the steep meridian. It can't be anything else. So this is very valuable information. Step 4, we're going to get our keratometry, and we're going to look and see if what we know to be the steep meridian corresponds with what the biometer is telling us. So we're confirming that autokeratometry agrees with this. And why is that important? Because autokeratometry uses a lot of iteration, a lot of extrapolation. So let's do an example. Excuse me, sorry. So remember, astigmatism is a vector. It has both magnitude and direction. This is Master 500 and earlier models. We have 6 measurements, 3 above, 3 below the horizontal meridian. They're separated by 60 degrees at 60, 120, and 180 degrees. Everything in the middle, everything in between is iterated. It's extrapolated. So these aren't direct measurements. So a steep meridian here is going to be 140 degrees. But let's say measurement 1 is correct. or measurement 3 is correct, that's a 15-degree angular error. And that would result in a 50-degree reduction in the toric IOL correction. This is where a lot of these problems come from. It's not just the magnitude of correction, but it's also the orientation. So without some validation of the steep meridian, autocaves alone may not be reliable as your primary instrument. And each device is slightly different. This is the Varion, this is the Almaster 700, this is the Lenstar. And so each one of these, it has a slightly different algorithm. So we need to come up with ways that are a little bit more bulletproof. So step 5, so with the steep meridian validated, the measure power between meridians is very likely to be correct. So now we have, is it regular? Is it symmetrical? What's the steep meridian? What's the power difference between? Okay, and if you have this kind of picture, you're going to nail it every single time. So just, basically just a quick overview. The axial curvature map is our primary instrument for the steep meridian and the patient's candidacy, and autokeratometry is the primary instrument for the power difference, provided we validate the measurements. Remember, a measurement's only as good as our ability to know what it means. And here's somebody with the rule of astigmatism. You can see it works exactly the same way. Steep meridian's 85, and here's our Ks. Bingo, this is going to be good. So this is how you get these great outcomes every single time. Remember the old Russian proverb, we trust, but we verify. Okay. So, after implanting a toric IOL, how many degrees of postoperative rotational error is acceptable? Well, the last ASCRS survey said it was 10 degrees, and people are getting a little bit more sophisticated. Now it's 5 degrees or less, and I would say that's a pretty good answer. So what are the consequences of an angular error? Remember, we said astigmatism is a vector. It has both magnitude and direction. So let's just take a look at that. And here's the refraction. This is plus, or rather minus 150 plus 3 at 110. That's the pre-op refraction. And we're going to put in a T7 with 110 degrees as the ideal meridian of placement. Okay, so let's see. Okay, if we get it right, then basically we're plain own, we have no astigmatism. So there's our 110 degrees. We got it right. So let's say we're going to be off by 10 degrees. We now have a diopter of residual astigmatism. If we're off by 20 degrees, it's more, and if we're off by 30 degrees, it's as though we put in a spherical lens. And as we keep going, now what we're going to do is actually increase the amount of residual refractive astigmatism until we get to 90 degrees, where we double it. So if you switch the meridian on your keratometry, you'll give grandma twice as much astigmatism. Let's talk a little bit about posterior corneal astigmatism. This is really one of the true breakthroughs that we had for the toric IOL. And this originally came from Doug Koch and Li Wang at Baylor University, where they quantified the posterior corneal astigmatism in some meaningful ways. And then Graham Barrett incorporated this in his toric calculator, and really the rest is history. So most people right now are using some accounting of the posterior corneal astigmatism in their toric calculator. And I think pretty much all of us are doing that right now. But this is where this basic insight came from. And again, I was part of the team that developed the original Alcon toric IOL. And this is what we saw in the beginning with the original toric calculator, which did not take into account the posterior cornea. And we always saw outcomes that were skewed. It was like there was some unseen hand kind of moving everything over to one direction for with the rule of astigmatism and against the rule of astigmatism. And the Holiday toric calculator saw the same thing. And again, it was Graham Barrett that showed us it was the posterior cornea. Once we began to incorporate the posterior cornea, like in the Barrett toric calculator, things moved back to the center. So that unseen hand was actually the posterior cornea. So huge way of making things better. Now, the Barrett toric calculator does have a method that we can add the posterior cornea, but I think really that mathematical models are probably still a little bit better. These are regression-derived values, and they take into account other things besides the posterior cornea. And for right now, my money's going with, say, the Barrett toric calculator with the mathematical model, rather than a direct measurement. Now he has the Barrett True K toric calculator, which can be used for eyes with LASIK, keratotomy, keratoconus, eyes with prior penetrating keratoplasty. And there, measuring the posterior cornea is a lot better than using a mathematical model because these eyes are so very unique and individual. We can't do this. So for those, yes, you would put in a direct measurement of the posterior cornea, and that could be with the Galilei or the Panacan or some other similar device. So this is an option on the Barrett toric calculator. Now, surgically induced astigmatism, we're beginning to learn a lot about this, and there's kind of some surprises here that go against everything we were taught as residents and everything we learned subsequent to that. And I'm going to share with you where these insights came from and what we're currently doing with them, because it's going to make a difference in terms of how you do your toric calculations. So I've written a toric calculator. It's been online for probably about 10 years. It's at sia-calculator.com. And we have about 60,000 cases right now. In fact, I think the number is probably closer to about 80,000 cases. And what we found was that when we're starting to look at these databases, that this was a mean value. It's about 0.4, 0.5, and that's the number that we used for the original Alcon toric calculator. But we saw a wide range. Here's almost 1.5 diopters. Here's almost nothing, and it was really all over the map. And we thought, well, maybe these doctors just aren't doing a really good job. Their measurements are sloppy, or they're putting in the data wrong. Well, it turns out, no, their measurements were perfect and they were putting in the data correctly. The insight that was wrong was ours. And we didn't really understand this. So as we began to look at this, these are the basic insights we came up with. So what determines surgically induced astigmatism? Well, we all know location. Superior is going to be different than temporal. The incision width and architecture, 3-plane, 2-plane, single plane may be different. The corneal radius is going to have a direct effect. The thickness is going to have effect, and the rigidity. And you might remember from physics, class as an undergraduate, these are the 3 components of Laplace's law. The effectiveness of an incision into a part of a sphere is related to radius, thickness, and rigidity. That's our cornea. Also, the folded diameter of the IOL passing through the incision is going to have a transient effect on surgically induced astigmatism. Take a big IOL, cram it through a small incision, you're going to stretch the incision. So even with the same incision type and location, it should not be expected that the amount of surgically induced astigmatism is going to be the same for all patients. So what do we do with this? How do we make this work for us? So with so much variation, what do I use? Well, here's the conclusions that we came to. And Graham Barrett talked about this in his Innovators lecture at ASCRS. So we know that the magnitude shows wide variation from one patient to the next. And the orientation may not be predictable. So we were taught that if we make an incision, say at 180 degrees, we flatten at 180 degrees, it will steepen at 90. Well, it turns out that that's wrong. And that was a big surprise to us. The mean value may not apply to individual cases. The median value, the number in the middle of a series of patients, is less sensitive to outliers, but it may not work. And we're starting to use something now called the centroid value, which is a 2-dimensional average of a series of cases. And I'll show you how this works. So here's let's see, we got 147 femtosecond laser cases. And for this particular surgeon, they were using the femtosecond laser to actually make the incision. So same location, same architecture, very much the same every time. And look at how things are oriented. The circles are quarter diopter rings, and then we have the meridians from 0 to 180 degrees. So here's same orientation, different value. There's same value, different orientation. And of course, my favorite is no pattern whatsoever. So the way we make sense out of this is by taking a 2-dimensional average. The calculator, the online calculator will do this for you. And if you're not sure what to do, use 0.12. If you're using about a 2.4 to 2.8 millimeter incision, that'll work pretty nicely. And very rarely do we ever see numbers greater than about 0.16 diopters, unless there's something very unusual about how the surgery is being done. So if you go to the calculator and say you put in about 60 cases, you're going to see numbers that look like this for almost every database that you enter. So which calculator do you use? Okay, well, I'm pretty much in favor of the Barrett toric calculator right now. It's the best thing we have going. And And but there are multiple calculators available from industry, from individuals and organizations. And the ideal features are that the posterior corneal astigmatism should be added based on a mathematical model. And the two models that I think are the best right now is Graham Barrett's model and then the Abu Lafia Koch model after Doug Koch at Baylor and Adi Abu Lafia in Israel. And that's added as an additional calculation factor that you don't have to worry about. The calculation method needs to add, or it needs to determine the effective lens position of the toric eye well and apply that to how much toricity. So let's say you have a shallow eye and they have a lot of astigmatism. The toricity is going to, that's needed, is going to be less than if it was a very long eye and a very deep anterior chamber. So that small refinement needs to be part of the calculation process. And it needs to calculate the spherical equivalent, using an advanced formula. And it's used with a centroid value for the surgically induced astigmatism. So ASCRS survey, what would you use the majority of the time? Well, most people are using the Barrett toric calculator. So let's go through the Barrett toric calculator. If you're not using it, this is what I really recommend. And it's really worthwhile, and it's available on a lot of instruments. Simple thing is you can just go to the ASCRS website. There's the Barrett toric calculator, click on that, and it will take you to a link to the Barrett toric calculator on the server in Singapore. So what Graham has done is some very sophisticated stuff, like where it says optional K1 and K2. You can enter the Ks here from your biometer, and this is used to calculate the spherical equivalent of the eye well. This is what we do. Now, down here, you can enter the flat K, its meridians, DK, and its meridian. And this is used for the toric calculator. If you leave where it says optional K1 and K2 blank, it'll just go ahead and use these values. But this allows you to decouple the spherical calculation and the toricity, which is really nice. Because remember, for the toricity, for the meridian, we're doing this using the topographic axial curvature map. So we have our regular, some biometry measurements, the target refraction, lens thickness white to white. Our surgically induced astigmatism is going to be a centroid value. And we want to do the incision at the same location every time. A lot of times people will chase the steep meridian and always put the incision on the steep meridian. That's a really good way to get a lot of variability. So always make your incision in the same place for every single case. And that's a really good approach. And what you get is a graphic representation of the spherical power, optimal toric eye well alignment. We have this variable effective lens position. Now, the Barrett toric calculator has a recent refinement called integrated Ks. And what integrated Ks are is you can take the Ks from 3 different devices. We have 3 keratometers. They should probably be 3 similar devices if you have those in your office. And it does something called a vector median, which means it takes the magnitude and direction of the astigmatism, it disassembles it into Cartesian coordinates, finds an average, and then reassembles it. And this is a very nice way to refine things, and we're doing this in our office as well. So there's instrument 1, instrument number 2, and number 3. And again, if it's best if you use, say, 3 keratometers, because they use similar methods. And with this and the other things that I've shown you before, I can't remember the last time we had an outcome with greater than half diopter residual refractive astigmatism. And every single person listening to this, if you follow these recommendations, you should be greater than 90% for the half diopter accuracy for your toric eye wall. So here's the output for the Barrett toric calculator. We get a range of spherical powers and then the predicted spherical equivalent. And this is for standard biconvex lenses. For I don't think they're negative power toric eye wells, but the Barrett formula can also do meniscus power lenses. It also does a company specific recommendation like a T3, T4, T5 for the Alcon series. And then it gives you this graphic representation I mentioned. So for you get less toricity for with the rule astigmatism, more toricity for against the rule astigmatism. And the Barrett Tor calculator is pretty much the standard that a lot of us are using. And of course, the alignment will be influenced by the contribution of that additional vector of the posterior cornea. Now, to finish up, I'm going to share with you something that we've been using for a couple of years now, and it's really changed our approach to the toric IOL. This is our traditional toric IOL alignment. We have our preoperative marks. We stabilize the IOL, remove the viscoelastic. We have our toric alignment marks about 30 degrees, from where we want to put them, and then we rotate it, and that's where we end up. But the marks are, they're pretty fat, so it's easy to be off by 4 or 5 degrees, even if you do everything correctly. Well, what if you didn't do ink marking? And we use the femtosecond laser for this. And the femtosecond laser, this is the LENSAR, creates these capsular tabs. And you can see how they would line up with the toric IOL. And there's no compromise in integrity. That's 179 degrees. That's not 180, that's 179 degrees. And you can get this to within a fraction of a degree. You also get horizontal and vertical alignment. So here's a video of the actual creation of the capsulorhexis. So it uses iris registration to get everything lined up correctly. We're getting ready to do the capsulorhexis. Here's where we want to make our capsulorhexis tabs. Capsulorhexis tabs are created. Now we're going to go ahead and do our patterns for nuclear disassembly. And very, very nicely done. So here's a tab intraoperative. And then there it is after the toric IOL is lined up. You can see we're probably off by 1/10 or 1/4 of a degree. Oh my goodness, the humanity of it all. I mean, it's made it so incredibly precise for doing this. This only works though if you get the calculation correct. I mean, it allows you to line up the IOL, but you can also tell if the lens is rotated because you knew you put it right at the tabs during surgery. And if the lens is in a different place, then that would be due to rotation, not to misplacement. So my partner Yuri McKee and I would sometimes, we sometimes travel and talk, and I'll do a surgery and he'll see my post-ops. And for this case, I guess I asked him, how is Mrs. Smith doing? And he said it's exactly 190 degrees, and he sends me a photograph. So again, that's a lot of fun to know that we can get it this accurate. So quickly, in summary, if I can leave you with one thought at all, think about the central 3.5 to 4 millimeters of your cornea when you're doing the toric IOL. Line up, the corneal vertex with the center of the 2 astigmatic lobes, and make sure that that matches keratometry. And you're going to be on a very solid footing as long as the astigmatism is both regular and symmetrical. So the topographic axial curvature map confirms regular symmetrical astigmatism. Optical biometry A's and K's to calculate spherical power. The topographic map validates the orientation of the steep meridian, and the steep meridian validates the accuracy of the power difference by keratometry. Use a centroid value for your surgically induced astigmatism entry, 0.12 if you're not sure. You can go to sia-calculator.com to do the actual calculations for your own patients. If you're not doing it already, consider using the Barrett toric calculator and refine and be willing to rethink your method of toric alignment. I mean, when we adopted the femtosecond laser with this IntelliAxis feature, it completely changed everything we did for the toric IOL, and alignment issues are just, not even an issue. I'm here to tell you that most practices are seriously underutilizing the option of the toric IOL. It's a wonderful adjunct to your practice. You get it right, and your patients will name grandchildren after you. And it's a win-win situation pretty much for everybody. So thank you for your attention, and I hope this is helpful as we all kind of get better at using the toric IOL. Thank you very much.
Thank you so much, Dr. Hill. We have numerous questions here. We have time for a couple of them.
Sure.
Which do you trust more and use in the calculation for toric if the Ks from optical biometry are different than topography?
Okay, first of all, you would never, ever use simulated Ks for the toric IOL. Stop doing that. Do not do that ever again. Remember, you want to use the auto Ks from your biometry. The simulated Ks are a topographer trying to be a biometer, and they really don't work all that well. So that I'm going to speak infallibly like the Pope. Just don't do that, and you'll have much better outcomes.
Any comments, about or experience with the Kane formula?
Well, the Kane formula is a machine. It's a machine learning device of a database. I don't know where the database came from. But in either the next issue, as I mentioned, in the next issue or the issue after that, in the Journal of Cataract and Refractive Surgery, there's an article outlining the accuracy of the various formulas. And I think version 3 of the RBF method and Barry Universal 2 formula do a little bit better.
And one last question, why is the T2 Alcon toric not available in the US?
Well, Alcon did a study with the T2, and they couldn't show that it was actually better than the SN60WF. The problem is, I think the study didn't have validation criteria applied, and I think if the study would have been done a little bit differently, it would have been available. And I think it might be a time for the people at Alcon to revisit that, because we now have methods to approach the toric IOL that can really give us very good results. So I think it might be time for the T2 to be revisited and perhaps put into use by people here in the United States. I think one of the lenses by Bausch & Lomb actually has a very low toric value, and I think people are kind of drifting towards that.
Dr. Hill, thank you so much for spending time with us on Saturday. If you wouldn't mind taking some time and just going to the question and answer box and answering some of the remaining questions, but thank you again for your time and expertise.
It would be my great pleasure. Thank you for having me.
We're going to move on to making complex cornea ridiculously simple by Dipinder Dhaliwal. Dr. Dhaliwal is professor of ophthalmology at the University of Pittsburgh School of Medicine. She holds several directorships, including Director of Refractive Surgery, Director of the Cornea Service, Director of the UPMC Laser Vision Center, the Associate Medical Director of the Campbell Ophthalmic Microbiology Laboratory, and she recently has been appointed as the co-director of the Corneal Stem Cell Task Force. She's Vice Chair for Communication and Wellness at the UPMC Department of Ophthalmology. Dr. Dhaliwal is going to take us on a carefully selected tour of cornea topics, including differentiating corneal dendrites, nuances of assessing the dry eye patient, and finally, taking a close look at a thoughtful approach to infectious keratitis in contact lens wearers. Dr. Dhaliwal, thank you for being here today.
Hello, everyone. It's such an honor and privilege to be here. And let's see, I'm going to start my screen and I'm going to go into slideshow mode.
And now we can see your slides.
Wonderful. This is working from the beginning. All right. So I am just absolutely honored to be here with all of you. I was able to be live at the Connecticut Society of Eye Physicians many years ago. And I have to say, you guys have a wonderful, wonderful society. It was a wonderful dynamic, a great kind of vibe. And, it's because of the people that you have a really great eye society. So I'm just thrilled to be here, albeit virtually. Hopefully this virtual thing will end soon, but this meeting has been fabulous. I've learned so much from Greg Ogawa, from Warren Hill, from our wonderful neuro-ophthalmology colleagues. And I want to get started and talk to you about cornea. So here are my financial disclosures. And I just need to take a minute and really, the heart and soul of your society is this woman, Debbie Osborne. And I really think that, she deserves a ton of credit. It works tirelessly for all of us, not just those people in Connecticut and New York, but for all of us so that we can practice medicine. And she's just an unsung hero. And I wanted to just, I wish we were live because we could give her a round of applause, but just, give her a little shout out here that she is an incredible woman. So this is a picture of myself with my two sisters. One is my biological sister, that's Roop Garewal. And the one in the middle, of course, you recognize Debbie Osborne. And again, she really has been phenomenal. And during this pandemic, she was thinking about how to kind of practice medicine safely. She was sewing masks for all of us. And then the fact that she's delivered this amazing world-class content to all physicians free of charge is really kind of over the top. So Debs, we love you. And thank you again for working for all of us so that we can do what we love to do, which is practice ophthalmology. Okay, so now to complex patients. We're going to make complex cornea ridiculously simple. Now, when I was putting together this talk, I was thinking about the patients that really kind of suck the lifeblood out of me. And those are really unhappy post-op patients with corneal pathology and some without. Now, most of these are referred patients, but definitely I've created some on my own. Another group of patients, the dreaded dry eye, especially when they come and they say they've seen 5 other doctors and here's their list of medications, a bag full of drops. Those are challenging. And the last kind of category are the dendrites, right? So many different types of dendrites, herpes simplex, herpes zoster, and then even acanthamoeba can kind of present as a dendrite. So I want to kind of take you guys through this stepwise approach. The goal of today's talk is to learn strategies to deal with these challenging conditions that we face so that it can be a little bit easier. And when you go to your offices on Monday, you'll be able to use some of these pearls that we've discussed. So this is a really a downer, right? You finish perfect cataract surgery, you put in Malyugan rings, you put in hooks, you might have even sewed a segment, and it was perfect, right? IOL is beautifully positioned, but the patient is unhappy. It is like a dagger through our hearts, right? I mean, we work so hard, but this is a strategy that I've realized. First, you have to take a deep breath. Breathing is very important. Then you have to do some deep listening, followed by a deep dive into the exam, and finally having a deep discussion with the patient. So let's take those one by one. So as I've gotten older, I realized the importance of breathing. And the deep breath is critical because it's very important for us to not go on the defensive. Patients sense this. And when you go on the defensive, they become more unhappy. And albeit it's very challenging for we as surgeons who elegantly perform this perfect case to face an unhappy patient, they have no idea how many potential complications were avoided. But the critical thing is to stay calm and take a deep breath. The deep listening comes next. So now that we've taken a deep breath, we're ready to listen to this patient. And what I say is, tell me in your own words, what are the top 3 reasons you are unhappy with your outcome? If they say blurry vision, I ask them, at which distance? Does it improve with refraction? One key to diagnosis is this word ghosting. If a patient says they have ghosting or a double kind of image, ghosting is classic for residual astigmatism. So I know that we're dealing with a little bit of refractive error issue. How about if they say fluctuating vision? So sometimes it's really good, sometimes it's not. Then I think dry eye. It's some ocular surface issue. If it's hazy vision in the morning only, then I'm very suspicious for mild corneal edema, because when the eyelids are closed overnight, the cornea is decompensating. If they complain more of kind of a distortion, a distorted vision, I think more of irregular astigmatism or cystoid macular edema, a retina problem, like an epiretinal membrane or something else that's distorting the vision. And if they're just unhappy because they have burny, gritty, itchy, dry, right? Cataract surgery caused their dry eye, you have to think of an ocular surface problem. Now, here's what now I say, we understand. Let's do some more investigation and we're on this journey together. When a patient feels like you're on their team, that you're gonna solve this together, they are much more willing to share and to be open to possible strategies to help them. If they feel like your opponent, then they're like really defensive also, and they're, you know, trying to get a second and third opinion. But if they feel like you have got their back, then obviously they're going to stick with you. So the next thing is the deep dive into the exam. And we're going to talk about the refraction, topography, or tomography, the slit lamp exam, dilated fundus, and then possibly a macular OCT. Now, refractive error is the #1 cause of unhappy patients after refractive IOL. So it's the residual refractive error. Such a simple thing, right? So use your best refractionist. So Warren Hill just elegantly told us how we can optimize our IOL calculations and try to nail it every time. I now tell patients that we don't do IOL calculations, we do IOL estimations, and that it's not an exact science, that nobody has a perfect result, not even Warren Hill is 100%, but we are going to do our best. So then with correction, is your patient happy? Is there a loss of best corrected vision? Some patients have had pre-existing amblyopia for forever, right? I mean, pre-existing amblyopia, but the cataract was kind of, you know, masking. You might have just met the patient, and it's important to elicit that from a history. You know, were both eyes always correctable to 20/20? Maybe not, and maybe they forgot. So just remember that that could be an issue, and especially if there's a big difference in the refractive error in each eye. And then we carefully assess residual astigmatism, especially in our toric IOL patients. So the topography, tomography, critically important to look at the ocular surface. You want to rule out irregular astigmatism, you want to rule out ectasia, and you want to reassess the corneal astigmatism. So Warren beautifully, you know, talked about the corneal topography. I'm not going to belabor this point, but just, you know, for those people who you know, are not, for those of us who are not used to looking at topographies, I just, you know, tell the residents, I say, draw a line through each pole, try to bisect each pole of that figure of 8. So here is a curvature map. And if you bisect each pole, this is actually regular asymmetric astigmatism. That's my cornea. So it's okay. I don't have ectasia. And this is acceptable. This other top map, if you bisect the top pole, you bisect the bottom pole, they do not intersect. That's not just one line. This is what we consider irregular astigmatism. So it's a very simple way to just figure out if it's regular or irregular. And we call it non-orthogonal astigmatism, okay? And that next step then for that patient would be a pentacam. And here you can see the posterior elevation map is really important. And in fact, this patient has ectasia, okay? So this patient is not going to be happy with the quality of their vision because they have keratoconus. And you would think, boy, that patient should have known they have keratoconus. No, because it can be masked. This patient might have been totally dependent on their rigid gas permeable lenses preoperatively for excellent vision. They might not know. And I've met patients who are very unhappy afterwards who really, you know, they were discovered to have keratoconus after the cataract surgery. So definitely, as Warren said, you want to diagnose all these things ahead of time. Now, again, Warren's talked about all this. Remember the different corneal versus lenticular astigmatism. So look at the Ks, not the refraction, regular versus irregular. And I will say one thing, I put toric lenses in patients with irregular astigmatism as long as I have a very detailed discussion with the patient. Because if I have an elderly patient who is not ever going to wear a rigid gas permeable contact lens, and they have all that astigmatism correction in their glasses, then why not help them and put the bulk of that in the IOL? They're some of my happiest patients. But the critical thing to ask is, does this patient wish to wear a rigid contact lens post-op? If they do, then I avoid a toric lens. It's just more challenging to fit a lens after. It's not impossible, but definitely more challenging. And this was a very unhappy patient I met after cataract surgery because they just, weren't aware that that would be an issue afterwards. They thought they could go back to their contacts. And And again, if they don't wish to wear a rigid contact, then we carefully explain that only the regular component of astigmatism will be corrected with the implant similar to their glasses correction. So it's not going to be crisp and sharp, but it's going to be better than what they have now. So remember that patients need to keep their contact lenses out prior to biometry. Some patients just think, oh, they're going to come in for the cataract evaluation and then that's it, right? But we insist, because garbage in, garbage out. So for soft contacts, 2 weeks out, and for soft toric or for rigid contacts, at least 3 weeks, at least. Now, if they're still changing after 3 weeks, then we have to keep them out longer. And I had a patient just recently who was out of her contacts for actually 4 months, and her case kept on changing because she was an RGP wearer, and they kept on changing. And at the end of the day, you won't believe it, she didn't even need a toric lens because her astigmatism actually improved over time. And we ended up putting a regular monofocal lens in, and she was thrilled. So let's just a brief message about keratoconus, because I think that we need to educate our patients about this condition. There is a huge overlap with keratoconus, eye rubbing, floppy eyelid syndrome, and sleep apnea. So when I see a patient with any of those conditions, we ask about loud snoring, daytime somnolence. Remember, sleep apnea can cause sudden death and blindness. So this is a big deal. And we as ophthalmologists may be that physician who really prompts the patient to go get tested for sleep apnea. It's critical that patients stop rubbing their eyes, because that will cause ectasia, any ectasia, to progress. And remember, tell them to stop sleeping on their eyes. And they might look at you strangely, but a lot of patients sleep with on one side every single night, and the keratoconus is often worse on the side that they sleep on. So if they do that, we sometimes have them wear a fox shield at night to protect their eye during sleep and to avoid pressure on their eyes. So no pressure on their eyes. I say this all the time to my patients. I sound like a broken record. Do not rub your eyes. Do not rub your eyes. Do not sleep on your eyes. No pressure on your eyes. And if we told our patients this, at an early age when they're kids, then I think that we could really slow down keratoconus progression just by some education. Now, when you're doing cataract surgery, a little detour here for keratoconus and cataract surgery, remember it's a very challenging view through a steep and irregular cornea. So always use trypan blue, it helps. And if you're gonna do femtophaco, the catalyst system can be considered, because even with very steep corneas, you're not going to get any distortion because there's no applanation plate. So that was successful in my hands. And remember, these corneas are thin and they leak. So have a very low threshold to seal those wounds. Please do not add limbal relaxing incisions in an ectatic cornea, because it will destabilize the cornea further. And I always have a challenge, right? You have these very steep cases, how do you pick an implant? So this article changed my life, and it made life a lot easier in terms of picking an implant. So this is an article from the BJO, and basically you look at the keratometry, and if it's under 48, you're going to use the actual Ks and you target a -1. If it's moderate with Ks between 48 and 55 diopters, you use the actual Ks and target -1.5 diopters. Now, in those patients that have severe keratoconus with Ks over 55, and we see those not uncommonly, this is the amazing thing. You use an average K of 43.25 diopters, and you target -1.8. I know this sounds crazy, but this has been working in our hands. Now, remember, these are severely ectatic corneas. We just want to kind of get in the ballpark, right? These are way outside the norm. However, instead of picking, minus lenses and all these things, what we do is we use this very simplified approach, and it's been nice. Okay, so back to our patient who is, we're taking that deep dive into the into the slit lamp exam, remember to look for ocular surface disease. And this is the #2 cause of patient dissatisfaction after refractive IOLs. Put the fluorescein in the eye, assess the corneal surface, and you're looking for basement membrane disease, nodules, all these things, right? And this is very, very common and often unrecognized, that irregular pattern of staining. And this causes patients to have blur. So remember to enhance that corneal exam. A clear cornea can be very deceiving, but when you put that fluorescein in and use a diffuse blue light, it's amazing what you'll see. So I would highly recommend that approach. Now, if there's a lot of basement membrane dystrophy, a very simple way to optimize the ocular surface is to do a superficial keratectomy. And what we can do is just remove the loose cells with a Wexel, and then this is a wonderful PRK spatula, and we can just go ahead and remove the central cornea. And remember, quick strokes, and we go from periphery to center, so you don't remove all the peripheral cells, which are very important for the limbal stem cell niche. We wait for 8 weeks for the cornea to stabilize, and then we use the new Ks. Now, you're doing a deep dive into the slit lamp exam and looking for this is in our post-op patient who's unhappy. You look for IOL centration, IOL positioning, and I really try to avoid a YAG capsulotomy until an IOL exchange is ruled out. Always, check the fundus, and this has been lovely with OCT. It really helps us understand what's going on. And then it's time for the deep discussion, right? So if you have refractive error, we talk to the patient about the options. Now, glasses is an option. And, I sometimes tell my patients ahead of time, I say, listen, it's okay. It's not a failure if you have a premium lens and you have to wear a thin pair of glasses for certain activities. In fact, I think that that's totally okay. And so sometimes that's safer than doing PRK enhancement because that can have complications as well. So always discuss all the options and remember that conservative options are acceptable. Remember to optimize the ocular surface, and we're going to talk about that in a second. And if there's corneal edema or guttae, I usually use a lot of steroids, Muro 128 ointment, and these patients can do very well with a DMAC as well. Treat aggressively the CME, and if it's just poor quality vision, again, education can help these patients. I tell people, this is really a piece of very sophisticated plastic that we're putting in the eye. It's the best we have right now. It's not as good as you were born with, right? And so there has to be some adaptation. So here are a few of my pearls that I've learned over 2 decades of doing surgery. Friends make your patients crazy. So what I've learned is that you should tell your patients not to discuss their implant choice or cost, what they paid, with any of their friends. This is absolutely critically important. I had a patient who came in who was happy initially, and then like at her 1-month visit, she came in and she was crying. I said, "What's wrong?" She said, "Well, why didn't you put in the multifocal lens?" I said, "Well, because you're not a candidate for a multifocal lens. You have an epiretinal membrane, you have some corneal dystrophy." She said, "Oh, my friend told me that I was cheap and I chose the cheap lens and that, and he made me feel so badly." So there you go. Please, I tell my patients, do not discuss anything. Tell them that you have a one-to-one discussion with your surgeon and that's all you know. And so they're much happier if you do that. Another critical thing is happiness equals reality minus expectations. This is an equation that really is one of my guiding principles in life. And we really work hard to set the expectations preoperatively so they're reasonable. So happiness will equal the post-op reality. Absolutely important. It's worth those extra minutes in the exam lane with the patient, managing expectations. And then there's some unhappy patients after cataract surgery who will remain unhappy despite your best efforts. And we call that patient selection error. All right, so the key things here, when facing an unhappy cataract surgery post-op patient, remember to systematically evaluate the patient, develop a roadmap for success, stay calm, don't be defensive or judgmental. Remember, patients have the right to voice their opinions, but we choose our reaction to that. And remind patients that you're willing to help them in any way possible as long as the benefits outweigh the risks. So now I want to just tackle a few of these other issues, and we're going to talk about difficult dry eye and a few quick pearls on this. It's very common. It affects all parts of the exam. This is a patient who had uncomplicated cataract surgery from one of my colleagues who came in with a melt 10 days after uncomplicated phaco because she had Sjogren's syndrome that was not treated appropriately. So again, some history pearls for dry eye patients. Don't ask what seems to be the problem. I ask, what are the top 2 things that bother you about their eyes? If symptoms are worse in the morning, then think lag of thalamus, floppy eyelid, or blepharitis. Ask if they sleep under a fan. That's critically important because that is very damaging to the ocular surface, or if they use a CPAP, that can also have some leakage of air. So another thing, ask, does anything make your symptoms better? And if the patient replies no, I put a drop of artificial tears in. If there's still no improvement, we put in proparacaine. If there's still no improvement, then I'm thinking about neuropathic pain. And then I know I'm probably not going to be able to help this patient with ocular surface treatment because they likely need some medication such as gabapentin. But if the artificial tears help even for a second, or the proparacaine helps, then I know we can optimize our ocular surface. So remember, the exam for a dry eye patient starts when you first enter the room. Think about their blink rate. Parkinson's patients, they just don't blink. Look at their amount of eyelid closure, the eye rubbing, and then do a really good external eye exam. If nothing else, just remember this external eye exam. It will help you diagnose so many issues. So you pull down the lower lids, have the patient look up. You're going to detect chronic conjunctivitis, mucus fishing syndrome, very common. Look at the lower lid snap. Pull the upper lids up, have the patient look down, detect floppy eyelid syndrome, SLK. And SLK is very commonly associated with severe dry eye. And this is what it looks like. And can you guys still hear me? Okay. Well, maybe not.
Yeah.
Okay, so this video is just showing how I do this in every single patient who I meet, and I just look up, look down, look at those floppy eyelids, left and right. And so that took what, 5 seconds, and you'll get so much information. Now, just for the trainees out there, when you pull down the lower lids and have the patient look up, this is how you can diagnose conjunctivitis in 2 seconds. If the hyperemia involves the bulbar and tarsal conch, the diagnosis is conjunctivitis, pretty easy. If the hyperemia is limited to just the bulbar conch, think episcleritis or scleritis. And again, floppy eyelid syndrome, keratoconus, sleep apnea, remember those associations. And SLK is associated with dryness. So we talked about the critically important fluorescein exam, and then remember to have the patient look down and look for the cylindrical dandruff. This is Demodex. This is a little Demodex mite, and we're learning so much more information about Demodex. There's some exciting treatments coming down the pike. In terms of testing, I do some testing, but honestly, I don't do a lot. I think my corneal exam is really much more important. And then in treatment, you're going to target it based on what you find. If they have low tear volume and inflammation, I'm all about using an anti-inflammatory for these patients. And when I first meet them and they're super inflamed, a little bit of mild steroid, and then I start either cyclosporin or lifitegrast initially. And I don't put punctal plugs in until the surface inflammation is optimized. And one thing that I will say is, if a patient is using even a preservative-free tear every hour, what happens is they're just like wiping away all the natural mucins and all the good stuff. And I call it dishpan eyes because they actually get more dry. They get more kind of dependent on those tears. So what we have is we have our patients using tears on a schedule, and not every hour. So the maximum would be, you know, kind of six times a day. I do use Restasis more commonly. And so let's see, I think I need to wrap it up. I see Ed Lim coming back, so I'm just almost done here. The treatment, remember, heat is great for the eyelids, very, very important. And there's so many different devices. I recently discovered a new electric warm compress that is called Wizard, and it's been wonderful. Another thing is tea tree oil scrubs. They can be very helpful for the ocular surface, especially if they have Demodex. I have everyone think blink. Blinking is critically important. I have them actually do blinking exercises, and remember to avoid drafts. I found this as I was preparing this talk. There's this dryeyeshop.com, and it has a lot of these wonderful devices where patients can, you know, decrease drafts and things like that. They're very lovely spectacles that have a foam lining, and that's been very helpful in patients who have to be in environments where they have to be kind of exposed to air. So let's see. Do I have time to just show a couple more slides? I just like summary slides on HSV and VZV, Ed, or I can easily just wrap it up and I can come back next year and show you that stuff too. Either way.
It's such an interesting talk. I would love to see them. If we could be really brief and close this up in a minute or two. Yes,
I can do that. Okay, so what I'm going to do is I'm going to go to the critical slides here. We're going to do this in 2 minutes. Remember, this is a pseudodendrite. This is acanthamoeba on the left. This is HSV on the right. Okay. If you have a contact lens wearer with a pseudodendrite, take off the epithelium. All right. I guess I did not time this talk appropriately. This is a picture. Take this picture. eyemicrobiology.upmc.com. Everything I want to say is on that website on how to deal with these infectious corneal diseases. They have pictures. They show you how to send a specimen. And some of our talks are there as well. Antibiotic susceptibility. And I'm just going to run through this. Again, remember acanthamoeba. Remember our patients use tap water when they're not supposed to. Try to report contact lens related corneal ulcers. And here's another case I just want to show you very briefly. It'll take me another minute. This is HSV with the terminal dendrites. And here's all I want to say. If you have live virus, so epithelial keratitis is live virus. That's that classic dendrite. If you have stromal keratitis, there's no live virus. That's interstitial keratitis with the vascularization. The necrotizing form does, but that also has an epithelial defect. If there's endotheliitis, there's no live virus. So the critical thing for treatment, epithelial disease, we actually don't use Viroptic anymore. We use ganciclovir gel or the oral agents. And you can see it can be on the conj as well. And I'm just gonna run through this. For immune disease, we use steroids with antiviral cover. And here's the key, and this is my last slide. If there's a live virus with an epithelial defect or staining, use antivirals only. And if there's no live virus like the stromal or disciform, use steroids with an antiviral cover as prophylaxis. So there you go. All right, well, thanks everyone for your attention. And again, just an honor to be here and part of this wonderful meeting. Thanks, Dr. Lim. Thanks to Debbie Osborne and everyone out there for listening.
Thank you so much for coming. It was so great to hear from you, and watch your email for another invitation.
Okay.
Now we're going to return back to the CME portion of our program. If you can still hear me, you'll get 1 more hour of free CME. We hope that you'll stay around for our door prizes. For anyone who doesn't know about our door prizes, hang around and you might be able to walk away with a prize at the end of your day with us today. Our next speaker is well known to our Connecticut members, and we're pleased that he accepted our invitation to speak again. Sunil Srivastava is on faculty at the Coli Institute at the Cleveland Clinic in Ohio. With his retina fellowship at Duke and uveitis fellowship at the NIH, he's an expert in uveitis and is here to share his experiences during the COVID-19 pandemic. Dr. Srivastava, thank you for being here.
Thanks for having me. It's great to be back, and hopefully everyone can hear me, and I'll get started with showing you my talk. I call this uveitis update, but in 2021, my most favorite question I got in 2020 was my uveitis from COVID or my vaccine? And I'm here to tell you, no, it wasn't your COVID, or no, it wasn't your vaccine. But let's talk through some things that we may have missed or at least had difficulty treating during the pandemic. Here are my financial disclosures. And this is my 4th time in Connecticut at the meeting, and I grew up in New York, so it's great to be back in the Northeast virtually. And this year, I hope my reviews are even better because we're Zooming. And why I think that is going to be the case is I'm going to talk a little bit more about surgery this time. I have limited my jokes about Paul Gaudio, but I'm going to show up a couple of fun photos of him here and there with this hat. It's a uveitis talk, so I'll tell you even more jokes about ulcers and STDs. And because it's on Zoom, you can always mute me, or more importantly, record it and then slow it down later. So my goals today are pretty straightforward. I'm going to show you a couple things, 4 cases that help you think through what to do, decide what to order. I'm going to talk a little bit about the new and not so new causes of inflammation that I found in 2019 and 2020, what kind of medications we should use to treat chronic uveitis, talk about surgery in uveitis patients, what to look out for postoperatively, and probably most importantly, how to help you figure it out, what you're comfortable with and when to refer these patients. So I'm going to start really simple. This is a 44-year-old male with a 3-week history of blurred vision and light sensitivity in both eyes, who started on prednisolone drops and atropine in both eyes by an outside ophthalmologist. Has been diagnosed with psoriasis, is currently on Enbrel, and he's unclear history of previous TB tests. 20/70 in the right eye, 20/40 in the left eye, 1 to 2 plus vitreous cell in both. So his fundus photo is pretty unremarkable. There's a little spot out here in the left eye in the temporal periphery. His OCT is probably the most remarkable thing because you can see that he has cystoid edema and probably some vitreous cell, at least in one of the eyes. The fluorescein has and confirms that he has leakage in both eyes, both of the nerve and into the macula. So what's your differential? You have a bilateral pan-uveitis patient who has CME. I already told you that this patient has psoriasis. Could this be HLA-B27 disease? I told you a little bit about the TB. Could this be medication induced because he's on Enbrel? And could this be sarcoidosis? Because this is a very common thing that I see. And is it potentially something infectious like syphilis? So what else do you want to know? So my first kind of tip here is, unlike medical school where we probably ask every review assistant questions, and sometimes that's difficult to do, if you've come up with a differential when you started, you can start tailoring your review systems. I'm not saying you ignore everything, but you can start tailoring and ask a little bit more specific things. So for something like tuberculosis, I'm assessing risk. Do they work in high risk situations? Were they in a place where they were going to get TB? With psoriasis, I'm going to ask them about their skin changes. With Enbrel, I'm going to ask about skin changes as well and new inflammatory syndromes. With sarcoidosis, I'm going to ask about pulmonary symptoms and skin changes as well. And for something like syphilis, I'm going to review risk factors. But you'll notice a theme here, like the 3 things I'm going to ask about the most are about skin changes in this patient. And it's amazing. I'm not bashful, and I start asking people about skin and ask about new skin changes. And many of my patients have tattoos. And this patient says my tattoos look different. And I've done this long enough to know, be very, very careful when someone says, would you like to see my tattoos? And I always ask where they are exactly, because they start to undress. And that's when I usually get the retina fellow to come by. But I'll show you what I've learned over time here is that over time, you can see here, this edge of the skin right here at that tattoo where it's kind of elevated and looks irregular, that's a sign of inflammation at the edge. And you can actually see it right over here really well on this frame. And I think those things tell me that there is an inflammatory process or at least some sort of skin condition going on. And to me, in a uveitis patient, that's going to highlight something like sarcoidosis. So I ended up getting an ICG on this patient, which revealed some choroidal changes in both eyes, which confirmed, if you will, that I was on the right track. And then I went down the road of working this patient up. When I'm suspicious for sarcoidosis, I will order a CT of chest. That's something that we do here at the clinic because we're usually going down the road of bronchoscopy or endobronchial washing to diagnose sarcoidosis. And this patient did have sarcoidosis. So no longer has a diagnosis of psoriatic arthritis, is now on prednisone. I switched him off Enbrel to another agent. And I just want to show you, we made the diagnosis of sarcoidosis only because we looked at his tattoos. So as ophthalmologists in these sometimes complicated cases, we can make a huge difference in this patient's systemic life because we ask simple questions and we put it all together. So we can be very, very helpful. My next case is like kind of a reminder to always take a step back and ask why. And this is a challenging case because of just the poor outcome. So this is a 70-year-old male who presented to us with an evaluation of blurry vision in both eyes, had redness and progressive vision loss for over a year. This really started with a glaucoma diagnosis and had inflammation possibly at the diagnosis of glaucoma. So pressures were elevated, maybe there was some inflammation, and then ended up on the path of multiple glaucoma surgeries. First an angle-based surgery, then a trab-based surgery in both eyes, and ended up with very poor visual acuity in the right eye, supposedly because of a central retinal artery occlusion, and then developed a central retinal vein occlusion in the other eye and has poor visual acuity and is receiving multiple intravitreal bevacizumab injections for cystoid macular edema. So has seen a comprehensive glaucoma, retina, and still not really sure what's going on. The other thing that's kicker on this patient is he has a history of non-Hodgkin's lymphoma for years, was on chemotherapy, and now receives rituximab about every 8 weeks as their maintenance for their non-Hodgkin's lymphoma. He's also on some anti-hypertensive medications and otherwise social history is unremarkable. Slight perception in the right eye and 20/70 in the left. Pressure is 4 in the right and 12 in the left. And when you kind of look into this eye, you can kind of immediately see that there's something wrong that's going on. In the right eye, it's a very poor view. This is a light perception eye. I can't really make out of anything, but there's this very distinctive pigmentary change in the right eye that almost looks like goes 360, almost looks like almost like a laser burn. But in the left eye, you can see it pretty obviously here. And on the highlighted screen here, you can see it, this area of whitening that extends from the periphery towards the fovea. And you can see this almost brush fire-like appearance where the retina's become atrophic out here and is much more whitened down here. Here is, I think, the remnants or evidence of a central retinal vein occlusion at this point. Here's the fluorescein that just shows you peripheral non-perfusion and leakage. So what's your differential? Well, in someone like this, I'm really worried about infection, right? On immunosuppressive medication, progressive vision loss, and in an elderly patient with a history of lymphoma, of course, I'm going to think inflammatory and lymphoma. Could this be something like giant cell arteritis? And someone like this, I'm going to get a sample out of the eye. There is some cells still in the eye, AC tap, and this patient actually has CMV. So this patient actually ended up with CMV retinitis. After a few injections, the left eye starts coming back. Couldn't really do anything for the right eye. The right eye ended up NLP, but the left eye has maintained 20/70 vision, though, with very, very low pressure. So the reason I bring this case up is not to make everybody miserable at the end of the day. It was to go over this. So like challenging cases like this, I think we have to take a step back and say, what happened? Well, the patient presented initially with elevated intraocular pressure. It was resistant to topical therapy and was noted to have inflammation in that eye. And I think what was missed was the fact that this patient had several rounds of chemotherapy and was also on rituximab every 8 weeks, which is very powerful. It's a significant amount of immune suppression. For uveitis or vasculitis, we do it maybe every 6 months. This patient's getting it every 2 months. So when the virus, remember, when most viruses first infect, pressure is usually elevated. It'll CMV, sometimes it can be low, and it wasn't recognized. The back of the eye just wasn't looked at very properly. 4 glaucoma surgeries, untreated CMV for about a year, now blind in the right eye and almost blind in the left eye. So if something's not working out, things are progressing, and you know you have a stable of people that you're having these patients looked at, sometimes it's okay to talk to your referrer and think, are we sure we're doing the right thing? Can we get some more imaging to highlight? Can we like send this off somewhere else? Let's get another idea, another set of eyes to look at this. This next case is obvious, and you all learned about it. It's from residency on call, or maybe it's not. Let's see. 51-year-old presents to the on-call resident, states a week ago was poked in his left eye by his grandson, then lost all his vision in his left eye. Previously, he was seeing perfectly out of both eyes, denies any past surgery or trauma, has had some progressive vision loss in the right eye, but he's a really poor historian. He has multiple admissions to the hospital for substance abuse. He's 21, 25 in his right eye. His light perception in his left eye. His pressure is 9 and 7. Here's his sneaky eye in his right eye, and here's his left eye. So his left eye looks like looks like an old rupture to me. If you just look here, you can see some uveal tissue coming out. You can see some scarring of his cornea as well. This doesn't some nevascularization or at least some into this space. So you can tell that this isn't relatively new. This is probably relatively old. But when you look in his right eye, can't see very well. You can see that there's choroidals or maybe an exudative detachment here in the right eye. The OCT shows a thickened choroid. The B scan of the right eye confirms this choroidal elevation as well. In the left eye, he maybe has some as well. So he's got panuveitis in right eye from a previous rupture, it looks like. Looks like an exudative retinal detachment as well. This sure sounds like sympathetic ophthalmia. So our plan for this patient, it's during COVID-19, right? So we're like, well, are we going to send this patient home on prednisone? We're not sure he's going to show up, and he's essentially monocular. So the fellow calls me. He's like, well, this guy, we got to get him better quickly. Can we start him on IV steroids without a workup? Okay, yeah, it seems to make sense. As long as you do a review of systems, I'm fine. Let's get some labs. Let's make sure we're not missing anything. I mentioned it was 2020 when this happened. Nothing's what you expect. This patient actually is HIV negative, but syphilis positive. So is it syphilis or is it sympathetic ophthalmia? So I started him on IV penicillin. We hold the IV steroids, and then we start him on oral steroids while we're in-house so we can see how he's doing. And really quickly, once he's on the IV penicillin, he gets a lot better. And his vision's better per patient, but he doesn't come back. He just disappears until he comes back 6 months later into my clinic. He's now 20/50 in the right eye with J1 in the right. He's LP in the left eye. He's had no medication since admission, but 3 visits to the ER for alcohol use. Here's his view into his right eye. The view is completely clear. You can see it really, really well. The fluorescein maybe shows this old space of like possible retinitis or possible choroiditis. I can't really tell you what's going on. So was this sympathetic ophthalmia with syphilis? My favorite emoji is the I don't know emoji. It's like the uveitis emoji. Sometimes we don't know. And sometimes these patients, you have to treat them for both things in order to figure out what it is, in order to get them treated properly. And so we did it in the space of having him in the hospital in order to do something like this. I will remind you yet again, the syphilis continues to go up. We don't have the 2020 numbers yet. I don't think COVID necessarily stopped this. Maybe it slowed it down a little bit. But the good news is it's not like the good old days. The good old days were depending on when you were born. If it was the 1980s, certainly was greater in the 1980s. And certainly if you're a little bit older, syphilis was a lot more prevalent in the 1940s and 1950s through 60s than it is today. We're making a comeback though. So who says millennials can't be counted on to do something? So what should you order? I'm going to go through this a little bit and I'll say, don't rat me out to your uveitis local uveitis person and tell them that I gave you a cookbook. I'm not giving you a cookbook. I'm telling you to think about your population and your patient. But if I was to put down sets of things that I like to order, these are the things that I think about. So I'm kind of always thinking about syphilis, tuberculosis, and sarcoidosis. Those are my big 3 probably locally that I want to make sure I'm not missing. So I check everyone for a syphilis IgG, treponemal over a non-treponemal test. Quantiferon Gold for me is easier than a PPD. I get an ACE on everybody, and depending on what my assessment of their risk is, either a chest X-ray or chest CT for sarcoidosis. In anterior uveitis, I will get a B27 in unilateral anterior. I'll get a urine beta-2 microglobulin for those who have acute bilateral disease, especially kids, when I'm trying to diagnose TINU, which is a very common disease, more common than we expect. So I want you to remember acute bilateral symptomatic inflammation in a younger person. Think of TINU, think about getting a urine beta-2 microglobulin. I get an ANA and RF in kids with JIA, and I consider an AC tap in those who I think may have viral disease. Once it gets into the back of the eye, I'm thinking a little bit more about infection. I'm thinking about things like birdshot and sarcoidosis. And if someone has retinal vasculitis, frank vasculitis, sheathing of vessels, those patients deserve a complete workup. So if you're a general ophthalmologist and this is something you're not used to, that's going to your retina provider or your uveitis provider because they need something else. And then you have to make an assessment if they need systemic workup. And I do a fair amount of tissue biopsies in the elderly. I want to highlight one other thing, which is we have such a role, and I've done this, I think, 4 times this year, in patients who've come to me for recurrent unilateral anterior uveitis. Ask about back symptoms. And it's not just back pain, it's morning stiffness. Does your back get stiff in the morning when you wake up? Do you take non-steroidals? Does it make your back better? Do you have radiating pain from your back down your legs? In those cases, you're probably sitting on somebody who has ankylosing spondylitis, and you can fundamentally change their life with, again, one question about their backs. I've done this 4 times in the past few months, just asking, tell me about your back or what kind of symptoms. In young patients who look otherwise healthy. And this happens in women, not just men. So it's 80% men, but 20% women that you'll see ankylosing spondylitis. And you'll see it in older patients as well. So on the left here is a normal SI film. You can see this, they call it a river that you can see is like flowing, if you will, on the sacroiliac joint. You don't need to be a radiologist to see that that has closed in somebody who has sacroiliitis, or at least healed sacroiliitis. So an SI joint film can actually be helpful. I wouldn't order it. I would get the V27 and then send them to a rheumatologist once you figure it out. Don't forget about imaging. Use imaging to help you. If you are someone who is really poor at looking at the back of the eye, I consider getting a wide field photo on these patients. And, just be honest with yourself. If you're not missing things, wide field photography can be very, very powerful and very helpful. It's great in kids. It's great in people with small pupils. And if you're not comfortable looking with a 28 or 90, just be honest with yourself. Get a fundus photo. You can see a lot more. You can take your time looking at it. Get an OCT, almost everyone. That's me. And I get ultra wide field fluorescein angiography often to determine if some of my patients have posterior disease. I'm going to include this slide, and I encourage everyone here to kind of not commit this to memory, but to think about medications, especially in older patients who come in with new onset uveitis. The bisphosphonates are a very common cause of inflammation. Whether it's Prolia, whether it's Zolmed, whether it's Fosamax, all these things could actually be a potential cause of inflammation. So I want you to know that, because I actually have patients who every time they get a Prolia infusion for the week or two afterwards have anterior uveitis. So something to make sure you're looking for. Certainly there are other medications that can do it. Topical therapy, brimonidine, can certainly cause anterior uveitis as well. So something, again, to think about. If you just started someone on therapy and they come in with anterior uveitis, something to think about. We know about things like checkpoint inhibitors, some of the new immunotherapy cancer drugs. I'll leave you with two other things just because they come up. So one is vaccines. Certainly in the past, I would tell you Zostavax. Theoretically, a flu vaccine could do it. In theory, any vaccine could cause uveitis or cause a UVS patient to flare up. And so in theory, COVID-19 vaccines could. In the, 6 months, 7 months that we've had it, have I seen it? I don't know. I mean, maybe I've had one patient for sure have a pretty severe systemic reaction and was pretty sick systemically and had a little inflammation in the eye. And I've had a second patient describe symptoms of flashing, was a multifocal choroiditis patient. But have I physically seen a patient with, clear association? That's not as clear to me. I'm sure there have been, and I'm just not saying there isn't. You would expect a hyperimmune response might cause some people to flare, but it's not enough for me to stop my patients from getting COVID-19 vaccinations. And I tell all my patients, and I recommend that they get it. The other thing I put on here, and this was mentioned a little bit in the last 2 talks ago by Elias, was intravitreal therapy. So any anti-VEGF theoretically can cause inflammation, but we know for sure brolucizumab especially was a prominent cause. I just want to show a case of this. This was a patient seen here at the clinic, serial bevacizumab injections, about 17. I went down to Florida, got 2 brolucizumab injections over the winter. The vision dropped after the second one, came back with significant ACE cells, significant vitritis, and a significant retinal vasculitis. This patient was diagnosed with brolucizumab-associated pan-uveitis and retinal vasculitis. Actually did pretty well because we were aggressive with this patient initially. But this was first described by Carol Baumel and a group of retina specialists last year. There was a second paper that then came out from the ASRS of a group of patients with occlusive retinal vasculitis following brolucizumab. And then finally, the Safety Review Committee, which I was part of for Novartis, published the results of relooking at the Hawk-Harry data. About 4.5% to 5% of patients in the series developed intraocular inflammation, which is not a small number. And it's a significant number of these patients lost vision. And this didn't happen just in the beginning. It was something you could even see 12 months after initiating therapy. So my point, and this is my message, this is not any company's message, this is my take-home message on this, is that I think on a lot of these patients, inflammation may have been present on imaging early on and wasn't recognized, and then retreatment occurred, and these patients ended up doing worse. Inflammation can occur even up to 12 months and 18 months after initiating therapy. And severe vision loss is a high risk in patients once inflammation starts. So you need to stop therapy if you see inflammation on these patients and begin aggressive anti-inflammatory therapy. And essentially what this mandates is careful examination once patients start on brolucizumab. You have to look at these patients to make sure they're not developing any sort of inflammatory complications. In 2021, for me, treatment, 2020 and 2021, treatment essentially stayed the same. Topical for acute disease, and this is for people who have aggressive disease acutely, still acetate difluprednate. I don't usually use intravitreal therapy for new inflammation, but as somebody who comes in with recurrent CME, who I know very well, and I've treated previously in a steroid challenge, I will give an intravitreal therapy. And systemic oral prednisone ranging from a half mg to a mg per kg, maxing out at 80 milligrams. But for the first patient who comes in, you never met them before, and they have an acute presentation, don't give them an intravitreal steroid injection. Start them on topical, start them on oral, and see how they do. And then rule out infectious causes. Make sure you rule out infectious causes before you give them an intravitreal therapy. What changed for me in 2020, probably with COVID, was really kind of my treatment paradigm. I still use the medications, whether they were anti-metabolites like methotrexate and mycophenolate, and the anti-TNF, specifically adalimumab, which is on label. I think there was a lot of hesitancy for a lot of my patients because of the pandemic, but they knew they had something aggressive happening in their eyes. So I often offer local therapy, both the Retisert implant, which is a surgical steroid implant that we've been using for over 15 years, has very good efficacy results, but has a high complication rate of cataracts and glaucoma. And the newer fluocinolone injectable implant in the office called YUTIQ, which is 1/3 of the dose and has a pretty significant effect. And I will say that probably what changed for me was the patients who were severe and had really, really bad disease, we pushed through and we did systemic immune suppression. And we were very cautious, and we had these patients, isolate themselves, and we made sure they took precautions. Those patients, thankfully, have done okay so far. And in others where it wasn't possible or wasn't clear or patients weren't comfortable, we went down the road of probably more local therapy in 2020 than I probably did in the past. This is just highlighting the adalimumab, which is a very powerful systemic therapy, even in Visual 1 and Visual 2, which were the trials used to get this drug approved. There were patients who broke through and had inflammation. It's not universal that this stops inflammation. It just reduces the recurrences. And you look at the first time recurrence for the intravitreal fluocinolone injection, this is the YUTIQ, the difference between the implant and the sham, and so the top is the sham, the bottom is the implant, time to recurrence, you can see that there's a pretty striking difference between those two curves, with the implant working probably 70 to 80% of the time. I highlight this case. This is a patient of mine from 2020 who was on adalimumab, continued to have flares. Pandemic was occurring. It was kind of late 2019. Late 2019, early 2020 when we were first starting this. Was going to come off of adalimumab because of COVID. Just wasn't going to take it anymore. So this patient, I gave an intravitreal YUTIQ injection to both eyes, and a year later, she's done great. She's off of it. She's just seeing really, really well, and it's worked well. So I had to modify my treatment. I had to adjust a couple of things, and we just made kind of best for what the patient was going through. But there was a lot of discussion of what can you take, what are you comfortable with, and for us to give patients options for this. If there's a question for you that you have about vaccinations in patients who are immune suppressed, the rheumatology, the ACR, American College of Rheumatology, has a great website and a great portal discussing when you should hold medications when you get vaccines and such. It's great. I put the website here just in case anyone wants to look at it. So let's talk surgery. I promised this, and we'll end over these last few cases. My favorite and probably my most memorable case in the past year. This is a 45-year-old male, few months history of progressing vision loss, light sensitivity. He's of course a commercial truck driver. He needs to renew his license in 3 months. He has a history of JIA, B27, developed ankylosing spondylitis. He has significant kyphosis of his cervical spine, which is going to come into play. He's on anti-IL-17 medication and difluprednate in both eyes. He's 2,200 and count fingers. Did I mention he's a truck driver and needs to get his license? It always seems they come right when they need their license renewed and their license is about to be taken away from them. He's got certainly cataracts in both eyes, but he's active, especially in the left eye. You don't have a really great view in the left eye, sort of a good view in the right eye. So what do you do next? How do you get these patients kind of treated, and what's the best way to go? So let's talk about a couple of these things. I mean, ideally, we've all been taught and trained this. 3 months of quiescence is desirable, 100% agreed. And the longer you're quiet, the better it is going to be, the less risk you have for post-operative inflammation. everyone's going to get postoperative inflammation. Let me be very clear, just the severity of it. And so if you're not controlled when you walk in, you're going to have significant postoperative inflammation. That's manageable, but you have to be ready for it. So sometimes we have to operate when there's a dip in activity, maybe not complete quiescence because you're in a scenario where someone can't see. You don't necessarily have the time, well, you want the time, but the patient doesn't have necessarily the time to wait that long. You know, how long can you keep a patient 2,200 count fingers? Well, maybe in some cases it makes sense to wait because they're not compliant, they're not coming back. Don't operate on somebody when you're not in that scenario. But in others where you have a pretty good feel and they're compliant, you just got to get their disease under better control, kind of operate during a window of opportunity when I've aggressively managed them perioperatively. So my overall approach, this is just kind of my tips here. I'm going to show you it on a table form. You know, in chronic anti-uveitis, I use pre-op topicals, and then I'll either give them an intravitreal triamcinolone on the table or oral steroids or a dexamethasone implant a week before. Once it has involved in the back of the eye, I'm doing a combination of all three, topical, intravitreal, and oral. If I have no idea if there was an infectious cause I never tested, I don't inject steroids, period. In the scleritis patients, I avoid intravitreal injections. I tend to use oral. Maybe you could convince me of periocular, and I taper really slowly. This is the same thing in a table form. If you snap a picture, screenshot it, or look at it later, again, don't rat me out to your local uveitis person. These are just recommendations. This is what I look at. I kind of think about this. I adjust based on like the patient who's in front of me and the severity of disease, of course. I don't tell you how to do this, but my uveitis fellow tends to do a fair amount of these surgeries. I sit there to make sure, I feel like I'm a charm to make sure it doesn't drop in the back of the eye because I'm a retina surgeon. But in general, iris hooks or Malyukin rings are needed. I would love to tell you can minimize iris manipulation. That's not possible in some of these eyes. So knowing that and seeing it for myself in the operating room, I really adjust the amount of immune suppression I do, because I know if there's a ton of iris manipulation and the iris is pooching out, or there's iris atrophy, or a significant amount of just the iris just feels different, I'm going to put these patients on a significant amount of steroids. I tend to stain the capsule just to make my life easier. I don't do prophylactic vitrectomies unless really needed. So this patient was quieted, scheduled the left eye, got preoperative intravitreal triamcinolone. I'll give him a pulse of steroids, ready to go. This is what he looks like on the IOL master, just to show he does have sneaky eye. He's ready for his left eye surgery when his right eye started hurting last night. His pressure was 60 to 70s in the right eye in the pre-op area, and he's in Bombay. So I put him on some drops, put him on Diamox, and I changed the consent. So now we're going to work on his right eye. Now he's not completely immune suppressed, but I did have him on oral steroids. He was quiet. I didn't give him an intravitreal triamcinolone pre-op. I feel pretty confident I can get things kind of done here because, you know, I need to. His pressure is really high, and this eye really needs probably work on it now. So I have him in the operating room. Here's his kyphosis. We had to put his legs essentially in an L shape with his legs hanging up. Just want to show you the case just so you can see it. I put a trocar cannula in and did a little vitrectomy to decompress the eye, and then I had my fellow go for it. So we're going to break the synechia eye here. We're going to use a fair amount of iris hooks. I always tell my fellows to breathe. We're going to get through this. It's going to be fine. And we just got to work on it and take our time and just do it under control. So we put our iris hooks in, we break the synechia eye, and then we're going to put in some trypan again, just to make our life easier, make it a little bit better, make it a little less complicated for us. But you'll see as we do this rhexis here, we're going to get it out, and it actually works out well. We do a divide and conquer sort of in this patient, and we're going to remove the lens here. Pretty straightforward. You'll see here as we go through it. I won't pretend to tell you the nuanced tips of phaco, but again, controlled. Put the lens in, triamcinolone in through the, and then we get out. Patient actually does great, does very, very well. We ended up doing the other eye as well. 20/20 in the right eye, 20/40 in the left eye. My fellow and I were feeling great, giving each other's high fives, sterile high fives, because we couldn't touch each other. I forgot it was 20/20. Because he comes back about a month later, irritation in both eyes, and his optometrist is concerned about an infection. You can see here what he looks like. He's got this area of scleral whitening in one eye and another area of scleral whitening in the other eye, temporal in both. This is awesome. Bilateral scleritis, I think. Could this be infectious? Is this inflammatory? What the heck, man? I mean, I had this guy seeing, he's going to get his commercial license. We were feeling great. So in this scenario, I put him on a fair amount of steroids. It could be infectious, right? I mean, he's on a ton. Could this be necrotizing? Kind of be odd, but again, you know, I operate on him, manipulate him. It's possible. Sometimes you got to treat him for both. So I did scleral cultures. I started him on steroids. I put him on antibiotics. I had him come back really quickly. And we had a culture and a PCR that started growing on this patient, histoplasmosis. So this patient ended up with histoplasmosis, scleritis in both eyes. So you ask, where did the histoplasmosis come from? Actually, it worked him up. Maybe he had some lung changes, but he wasn't sick. He wasn't hospitalized. He had nothing else going on. He is on an anti-IL-17. Maybe that put him at higher risk for it. Started him on systemic antifungals, put him on topicals. And over time, I'm happy to say he did pretty well. So here he is 6 months later. He's now a year, 18 months later, and he's doing well. I will not tell you how well he's doing because I will never take anything for granted on this patient or maybe any other patient. Just when you think you're doing well, something can turn the corner. So the rules of control for inflammation for cataract surgery is also the same for the rules of control for inflammation for retinal surgery. Control the inflammation before you jump in the eye, even if it's a pucker. If you are doing a detachment case, remember in young patients who maybe have acute retinal necrosis, sometimes they have extensive peripheral pathology, the hyaloid's down, you have to put a buckle on, check for persistent preretinal membranes, be careful on these cases, and make sure you image preoperatively to understand the anatomy. I show you this picture, not just for the retina surgeons, but for the anterior segment surgeons to just talk about one thing, which is this is a patient who had chronic intermediate uveitis, had floaters in the eye, but was still kind of active. And my concern, and this patient wanted to have their floaters removed. They were 20/20. Pressure was sitting around 9 or 10. And they were 20/20, but they were really bothered. Asked me to do a vitrectomy. I said, no, I don't think you should get that done. I'm really worried about you. Went to an outside provider, had the vitrectomy done. So pre-op UBM on top, post-op UBM on the bottom, has the vitrectomy done on the outside, comes to see me to manage the post-op care because his pressure is now 0. And not surprising why, because going through the pars plana on some of these patients with chronic intermediate uveitis, they'll have a snowbank, they'll have a cyclitic membrane, you're going to change the anatomy. Now, knowing that, it's important when you do something like a sutured IOL or an IOL exchange on a uveitic patient. So this is a patient who had a tilted lens. It's a chronic uveitic patient who was inactive for years. I'm going to suture in an IOL. I like to put multiple trocars and cannulas in when I do my sutured IOLs in, but I'm getting in to do the vitrectomy first. And you'll see here, he's got a pretty significant snowbank with a little bit of hemorrhage on the surface of the retina. He's got a little schisis cavity that's also apparent, which I couldn't see preoperatively because his pupil was small. So I couldn't see my cannula. So I move it to another space. I'm sorry, my infusion line. I start doing a vitrectomy. There's one of the cannulas I put in, and that's where normally I would suture right over here. It's in the snowbank. So you can imagine if I threw a suture through there, it's going right through this snowbank. It was probably going to bleed postoperatively. It's probably going to give me some issues. See how anterior this is. There's ciliary processes are right there. So here's an OCT just kind of confirming all this process. So sometimes when you have this, you have pars plana fibrosis, I have a tilted IOL and I want to get rid of that to help them. You know, what do you do at this point? You know, we've been kind of mentally taught maybe that we shouldn't do ACIOLs, but I do ACIOLs in some of these patients in a scenario where I try to think to myself, what's the best outcome for this patient? Their iris structures, as far as I could tell, was fine. Pressures were normal. The angle structures were pretty good. I'm going to put an ACIOL on this patient after treating the posterior segment with laser and cryo. We do a scleral tunnel. We're going to remove this lens by first cutting the sutured IOL. I'm sorry, the iris sutured IOL. And here we'll see the rotation of taking the IOL out. And then we'll put an ACIOL into this patient. This patient has done really, really well. The important thing afterwards was controlling the inflammation, because again, I knew how much this patient was going to have. Gave him oral steroids, gave him topicals, gave him a periocular, and no cystoid afterwards. Ended up with very good visual acuity. So longstanding uveitic patients, watch carefully for pre-op exam. Watch your secondary IOL placements in those patients with chronic intermediate. Maybe do a preoperative UBM. Be flexible with your surgical plan, and then control the postoperative inflammation. So what do you worry about postoperative inflammation? I kind of have this mantra where most postoperative inflammation is not uveitis. So like, I don't think you're sort of all of a sudden unmasking uveitis in a 75-year-old patient who just had cataract surgery and now you can't get rid of inflammation 3 months later. Most of that is because of surgery and genetics. How is your own local immune response? How do you respond to pigment being released, which happens in most cataract surgery? Are you brown-eyed or blue-eyed? And I think there's a difference in these patients. Maybe it's the fact that you kind of didn't use enough topical therapy, or not for long enough. You wanted to get them off really quickly. And maybe the cataract surgery wasn't perfect. You know, maybe there was iris trauma, maybe there's capsular rupture. but sometimes it's really important and there's something that's could be wrong. So you have to do a workup. So first thing I do is like, okay, increase your topical therapy frequency. Use real topical steroids, whether it's prednisolone acetate or difluprednate, usually those two, one of those two. And then if you can't get them quiet, ask yourself, do you think the patient's taking it? And if they're not, or you're not sure, put them on oral steroids. Put them on a week course for oral steroids. You're not going to do much harm to a patient in a few days of oral steroids. You want to see how they respond. And if their eyes are getting better, it just tells you that, boy, if I had them take enough medication, they would probably get under control. And if you're not getting it better or they're recurring, that's when you need to start considering another workup or a biopsy. So I'm going to show you my 4 last cases of 4 postoperative inflammatory cases with some surgeries in here. So this is a 49-year-old male who presents with vision loss after dropless cataract surgery in both eyes. A few week history of vision loss, was known to have a cataract. 6 weeks ago had droplets with intravitreal steroids, did great and had droplets in the other eye, but then noticed a significant decline of vision with inflammation in both eyes after week 1. Count fingers 20/25. It's got triamcinolone in the vitreous in both eyes. The fundus photos unfortunately show a lot, right? So you got this area of whitening that you can see out here nasally in the right eye. And in the left eye here, you won't see it initially, but you'll see it here on the fluorescein coming up. Fluorescein shows you kind of the salt pepper appearance with this diffuse loss of the retina. You can just see it like you're looking through to the RPE. There's some leakage and of the retina, nasally and within the macula itself. And here in the left eye, you can kind of see the extent of the retinal involvement in the left eye. OCT shows complete ellipsoid zone loss on the top film on the right. In the left eye, you have some early ellipsoid zone loss. In the right one, you can just see this kind of loss of interretinal structures as well. So is this bilateral retinal whitening after cataract surgery? You have outer retinal loss on OCT, multifocal lesions with confluence. Could this be infectious? Could this be inflammatory? Could this be HORB? This is a drug reaction because he had intravitreal therapy at the time of his cataract surgery. Well, it turned out this was syphilis. Now, this was syphilis all along. This was syphilis preoperatively. I'm sure of it, right? Because it doesn't happen like that, right? I mean, this is probably the cause of vision loss in this patient from the beginning. So the reason I again highlight that is, ask yourself, in a 40-some-year-old patient who has maybe trace to 1+ nuclear sclerosis, does it really make sense that of their vision complaints? Don't forget that syphilis is still something. Now, we looked at a lot of maps in 2020. Like, it seemed like we had a political map, we had a COVID map, there were maps all over the place. And I'd like to say that you can see here in the map of the United States, we look at syphilis rates, we're pretty much even. There's no red and blue. We're just the shades of syphilis, as I like to say, because even in states that don't have high rates, you look at it county by county, there are pockets throughout the whole country. So we are all one in this. This is not something you just see in one place versus another, or one demographic versus another. This happens everywhere throughout the United States. So we can make things worse if we're not looking, if we're not testing, if we're giving steroids in potential infectious cases, or local steroids in infectious cases, or local steroids without looking in the back of the eye to make sure there isn't an infection. You have to be very, very careful. Be careful with your perioculars and intravitreals as a patient who, elderly patient, gets a periocular for inflammation. 3 weeks later, it was toxoplasmosis to begin with, snuffed out the nerve and the macula. So let me show you a case of chronic inflammation that's been going on for a while after cataract surgery. A 53-year-old male who presents with chronic inflammation with worsening of vision in the right eye. Worsening vision for about a year. Had phaco about 6 months ago, no improvement. Had a YAG around that time, no improvement. And he's had progressive color change in his right eye for the last 9 months. This is the only slide that you need, right? So you look at this, you collective you and me look at this, and we see a different iris color change. And in our head, we're saying, well, when are you going to tell me about like the trauma, right? I mean, this has got to be, or this is Fuchs, right? I mean, those are the two things, right? Siderosis or it's Fuchs. It's a UVI's talk. It's got to be one of those two things. You can see this kind of ground glass appearance along the endothelium. Kind of makes sense. Posterior segment exam, you can't see anything. So I'm sorry, it looks normal. Sorry about that. So I asked the simple question. I think hopefully you do. Yeah, any history of eye trauma? He said, yeah, I had a blood trauma about 18 months ago. I didn't seek eye care. What hit your eye? A piece of screwdriver that broke off. I'm like, has no one ever asked you about this? I mean, come on, I'm not that intelligent. I mean, other people have done this. It's like, yeah, I did. And they looked and didn't see anything. I was like, okay, when you say they looked, did you get like a scan of your eye? No, I didn't get any scans. They just looked. And sitting right there on your CT scan of orbit, that's all I did was order it because I didn't see anything on my clinical exam. It wasn't until we did the CT and we did a UBM that showed it, that you could see, and an ultrasound would have shown this very easily, that metal piece. So this patient ended up with intraocular foreign body. The UBM confirmed it. Here's the case. And you can see how tiny this is. This is a really small piece that flew in his eye, probably was the original cause of his cataract. Remember, he's pretty young. He's in his early 50s. And he had a pretty significant cataract. So this one we're going to take out. I like to use a chandelier when I do intraocular foreign bodies. I enlarge the wound, and we tend to use this kind of bimanual technique where we'll grab it and then carefully grab it and then clear the vitreous with our cutter. I always tell the fellow, don't drop it, don't drop it. And most of the time the fellows listen, but sometimes in like this case, they'll drop it. So they just make it more interesting video to show. But we'll get it the second time and get it out of the eye here. But this little piece of metal was the cause of the siderosis in this patient. So again, just highlighting, some of the stuff is just history. Wasn't anything different I did. I mean, he shows up, I asked him the questions I think all of us would have asked. And then I did the next step, which was to order an imaging test. It's doing great post-op year 2, 2025. These patients require topical steroids for a long time. He was on topical steroid for at least a year just to keep him quiet. What are the signs of postoperative infection? So I'm going to end on these 2 points. And if I am over, please just tell me. Poor pupil dilation, material on lens capsule, UBM findings that are strange KP, vitreous involvement, and chronic despite our rounds of real steroids, right? So if I see these things, that's what I'm thinking in my head is like, okay, what infection am I missing? So I want to show you my most amazing one. That's actually for my partner, Sumit Sharma, who's phenomenal retina specialist, uveitis specialist here at the clinic. I say that because he was my resident, so I'm allowed to say he was phenomenal. But he's my partner now, and he shared this case with me. So if you guys get sick of me, Sumit Sharma's the guy to ask to come to the next meeting. 2013, crystal lens implanted in both eyes. Chronic inflammation followed after YAG. Had a vitrectomy in February 2014 for sterile endophthalmitis. Serial intravitreal steroids, IVK, intravitreal Kenalog, and Ozurdex implants the last time in 2016. Oral steroids as well. Finally decided, let's just take the lens out and the capsule due to this intractable inflammation. It was placed on a Duracell taper. Actually did great. 5 to 6 months later, is quiet, off of the medications, decides, well, let's put in a secondary IOL. Gets an AC IOL placed. Now in 2020, this is now 2 years, 3 years after the AC IOL, 4 years since this last surgery, has this profound inflammatory reaction in the eye. You can see this. This looks like lens material. It's actually endothelial plaques on the surface. And look at those large, weird looking keratotic precipitates. It almost looks like they have a little S shape in them. So this to me, like when you look at this and you say, okay, there's something infectious going on in this eye, or there's some sort of malignancy. Something's not right in this eye. So this is clear. We got to do a biopsy. But I told you, we took the capsule out. We took the lens out. Where would it be? So here's the case. I'm going to show you here. I'm going to start by just doing a vitrectomy and to take a sample. So a vitrectomy is done to take a sample. I'm going to run through a couple of things here just to, we first start by exploring the lens. Remember, ACIOL, capsules removed. So now Dr. Sharma is just looking around. He's just pulling with a Sinski or Kuglin, I can't tell which one this is, and just looking around to see if there's anything, any capsule that's left, anything that would highlight. And it's not really seeing that much. There isn't much there to explore that looks like it has anything interesting. So now going back to the eye, now doing depression, because the amazing thing is, even when you take the capsule on some of these patients and you do a pretty good job, sometimes there's remnants of the capsule or fibrosis on the ciliary processes that are really, really challenging to see. So this might be a case for an endoscope, or drop the pressure, really good depression, take your light pipe and look against it. And you can see it here coming up in a second. You'll start to see these deposits on the ciliary body, and ends up, there's a bunch of collections on the ciliary body itself. So Sumit and I have shared a number of cases. You can see it right there, this whitening that's right over here, where we've had chronic inflammation after taking a capsule and it's clear infection. I'm going to tell you what infection is here in a second. You guys can probably guess. And the only way to treat it, even when you give them serial antibiotics, is to destroy this area. So I got this tip from my colleagues in India where they use intraocular cryotherapy. I don't have that in my place. I haven't used an intraocular probe for cryo in a long time. So we just use laser, long burn, high burn, low power, long duration to get a burn in that area to essentially turn that area white. And I know it's over the ciliary process. I'm not trying to do 360. I'm just trying to do it in that one area where it is. And I've had pretty good success of essentially, hopefully killing the bug, whatever it may be there, and stopping the inflammatory process. This culture was positive for P. acne 7 years after cataract surgery. 7 years after cataract surgery, slow taper steroid drops, and the patient's now completely quiet a year later. So in summary, proper identification of location of inflammation, talk to your patients, order appropriate labs, don't rat me out to your local uveitis specialist. There is no cookbooks, but I gave you a couple things to order. Consider medications, both systemic and local as causes. Control inflammation preoperatively and of course postoperatively as well in the uveitis patients. Watch for any signs of strange postoperative inflammation. You ever have a question, you need to talk to somebody, you want to be talked down from the ledge. I'm not a licensed therapist, but I share a lot of cases with colleagues throughout the country. Feel free to email me and we can chat over the phone. Thanks for the time. I hope I get to come back and see you all live again in a couple of years.
Thank you, Sunil. It's so good to hear you again. The cases were so interesting. You really should consider writing bedtime stories in uveitis for retina and uveitis people.
I think it might be a horror film. That's the problem.
Great cases. Thank you again
Thank you.
for coming.
My pleasure. Thanks for having me, and guys have a great one.
All right. So we're coming to the close of the meeting. Before we get to the door prizes, I'd like to remind people how to get their CMEs. So what you do is you go to the Connecticut Society of Eye Physicians website at Connecticut Society of Eye Physicians, no spaces.com. And on the right side of the page, click on the CME evaluation form above the meeting announcement. Fill in your information, starting with your name and email address, and end with the competency questions at the bottom. You have to answer the questions to get the credit. Then hit the submission button.